Okay. Second comment, which I genuinely agree with sir, is please use a dyeing agent in the disc. I have taught many of my students, we though in India even use, if you don't have indigo carmine, we even use methylene blue. And the problem is that the fact is that the disc material by nature becomes acidic. And that is why on a T2 MRI, it is seen as a shining spot when you have a HIZ zone. So this is an acidic glycoprotein. When you put in a dyeing agent, the dyeing agent, whether it is indigo carmine or methylene blue, it binds with the acidic component. So it binds with the pathological disc and it aids the surgeon in removing the pathological disc, whether you do UB, monoportal, or you're doing transforaminal. Third comment that I would really love to make upon is regarding reherniation. Statistical significance of what sir mentioned, that if you have a micro tear and you just remove a small fragment, it's all nice. But when the tear is large, when you suspect a large central herniation, and sir mentioned that the recurrence rate is 28% or 30%, the reason is this. Annular tears below 6 mm usually have a recurrence rate of between 7 and 14%. But any annular tear which is more than 6 mm will have a recurrence rate by 4 times. So if you have a 7 mm tear, it becomes 28% chance of recurrence. So therefore, it is very important that you map an annular tear. So how do you map an annular tear? Every time you don't have to take a cut centimeter ruler into the wound. No. A normal ball tip hook, you know if that is 3 mm, just put it on the annular tear and calculate. If you know this annular tear is big and you know the chances of recurrence is going to be massive because you have had a massive rent, what sir recommended? Yes, you have two options. You do a complete subtotal discectomy and pray to God it doesn't recur, or you have the option of proceeding with a fusion surgery if there are associated signs of instability, facet effusion and whatever. Let's not go into all those things. But the idea is map an annular tear. Never ignore the size of an annular tear, because what happens by the time we reach that surgical spot, we are tired. Then we grab a big fragment and we are very happy. Yay, photograph in the theater, right? But you forget to map the bloody tear. And 1 week later, when the patient comes crying back with severe pain in the back and in the leg, then you say, oh shit, what did I do? I forgot to map a tear. So please, mapping of a tear is of vital importance. That is my suggestion to all of you, please. So use of an indigo carmine dye, mapping of a tear, and if you are going to do a PTED, please add a foraminoplastic volume expansion to that thing, because 99% of all disc surgeries do have a small component of reherniation. Always, that is human nature. And there's something that we can't control. What sir said, we can't control. Okay, thank you so much, sir. Very informative talk, fantastic talk. Yes, Dr. Jipin.
So post discectomy, after 3 weeks, patient came with severe backache. On re-MRI, there was a small abscess in the outer area, and there was an plate affected also. Aspirate showed there was organism infection, infective discectomy after 3 weeks. How to manage?
In case you have a discitis, first option would be definitely, what I do as a protocol is I put in a central line. Already the patient is harassed with so much of peripheral line surgery. I put him on broad spectrum general antibiotics. I try to aspirate with a transforaminal needle to try and get a culture or a tissue culture piece. So if you're going to shift the patient in the OT and he's got severe spondylodiscitis, he's got pain, please use propofol as an anesthetic agent when you're turning the patient. Let the patient wake up in a prone position. By the time you have infiltrated your tract with local, your needle is almost at the facet. Wait, let him wake up, have a cup of coffee, then put your needle in the disc, then do your aspiration. If you are good at PTED, put in a scope, get a tissue biopsy, wash out all the negative substance from there. because the very fact that you're putting in a scope and you're washing out all the toxins, that gives you a better control for your antibiotics to act immediately. You will not believe this. A patient who has undergone a secondary wash wakes up with 90% less pain.
Okay.
And since you then have a specific tissue culture program, you can monitor ESR and you can monitor procalcitonin levels. Until they come to normal, continue IV antibiotics, whether it's 10 days or 12 days. So that is where a central line makes the patient very comfortable. Okay. And after that, 6 weeks of oral antibiotics. That is the protocol I follow. People follow different things. Okay.
Okay.
Thank you. Thank you so much. Our next speaker, sir, please. We'll now go back to our regular schedule. I think Dr. Puneet Gulati is over here.
No.
ને પેલાના 4 બાકી છે ને સર, એમાંથી કોઈ આયા છે એટલે પુનીત ગુલાટી સર આયા છે. So let him start. Okay, Mukul, you go ahead. No problem. Next, we'll take Puneet.
Dr. Mukul Kaushal is going to talk on uniportal to biportal simplifying conversion.
Good morning, everyone. I'm Dr. Mukul Kaushal. I come from Chandigarh, and I want to thank Dr. Malcolm for giving me this opportunity to present this talk on how I am trying to simplify my conversion from a uniportal to a biportal technique. So when we are planning for a biportal technique, especially for an interlaminar technique, usually we want to be aim at the base of the spinous process. We have to draw a couple of landmarks on your skin, take a lot of image shoots, and usually it goes something like this. This laser pointer is working. You need to mark the disc level, you need to mark the midline, you need to mark the medial pedicular line. Then you keep your instruments where you want to give a skin nicks, then you give your skin nicks also under image guidance, and then you dock your initial dilators, and then you dock your tissue dilator, and then you create a working space, and then you put in your scope. Similar thing repeats for your scopic channel also, and then you start your biportal work. But the thing which we are not talking about is that invisible devil in that OT. It is your radiation, the amount of exposure you're getting whenever you're doing this particular technique. So what we are trying to do is we are trying to modify our UB triangulation in an attempt to minimize our radiation shoots and hopefully also simplify the triangulation. And for this method, we only use lateral views because the first lateral shoot is taken when we just put in a needle to localize our disc space. And the second is to check whether our tube is docked on the right level with the monoportal tube, but whatever system you're using. So this is a small schematic. We can see that the needle is in line with the L4-5 space. If this is the skin and the fascia, usually a skin nick is given in line with the disc. Your tube goes and docks over the interlaminar area of your serial dilation. And then you create another port cranial to that. The stab knife goes in through the skin and the fascia. And like a simple switching stick, which we use in routine arthroscopy, you can hit your tube through that, and your tube acts as a guide to dock this switching stick on your lamina. And then over that switching stick, you can put in your arthroscopic sheath, connect your camera, and convert it to a biportal mode. So this is a small operative video of the steps. So this is the system which I use. This is a monoportal arthrospine system, serial dilation. Over this, I slide my arthrospine tube. And once the tube is docked on the interlaminar area, I connect my arthroscope and everything to the system. And under vision, I create my working space initially. So the inside picture looks something like this. Through the tube, the lamina is towards the 9 o'clock. The interlaminar area is towards the 3 o'clock. I put in my patty. This patty is also going to act as another guide when I put in my scope. So my tube is now covering my interlaminar area. I give a small nick through the skin and the fascia. A simple switching stick, which we use in routine arthroscopy. It goes, hits the tube, and it slides onto the lamina. Then I just do a bit of a wiggle or this dance of dilators. Introduce my arthroscopic sheath over the switching stick. Connect my camera to the arthroscopic sheath, and I remove this tube And what was initially my tube portal, it now becomes my working portal. So this is how the image looks like. That patty which I had put, that is another guide that I'm on that right level. I'm not lost somewhere in the soft tissues. So I remove this patty and then I start my biportal work. Same thing can be done on the right side. The needle localization, skin incision, tube docks over the interlaminar window, a small nick given caudally through the skin and the fascia. This is the operative flow on the right side. Here the orientation changes because in right side, usually your 3 o'clock becomes the cranial end and your this 9 o'clock becomes the caudal end or the interlaminar area. So same thing, the tube is covering my interlaminar area, a small nick through the skin and the fascia. My switching stick goes in. I'm a right-handed surgeon, so I'll always be holding my scope in my left hand, and my working hand will be my right hand, which is my dominant hand. And again, that patty again gives me a guide that I'm on my right level, and I can start my biportal technique. We try to modify this further and innovate it further with a freehand method, which we do totally under vision. So in this, my tube comes out totally. I introduce my camera through that incision, same incision. I'm looking directly at my inside picture. Under vision, I give a nick. I don't want to see my blade coming into my arthroscopic picture. I just goes to the skin and the fascia. That simple switching stick we use in routine arthroscopy, that I see coming under vision. And once I dock this under vision on the lamina, I remove my arthroscopic camera. My assistant hands over me the sheath. I dock it over the lamina, sound it, connect my camera back again through the different stab portal, and the previous incision for my tube, now it becomes my working portal. So in this way, we are minimizing our radiation shoot. So what we feel is the advantage is it's a tube assisted visualization of anatomy. You can take it a step further, do a freehand option, less need of CM radiation, less exposure, and probably an easier conversion to biportal. So thank you very much.
Thank you very much. Nice technique to convert this into biportal. Excellent.
Thank you, sir.
Any questions? Okay. Thank you. Dr. Mohinder Kaushal, cervical canal decompression.
Ladies and gentlemen, after lively evening, Dr. Malcolm, which he had organized yesterday, I think, and Sunday morning, I mean, no one of us is in mood to indulge in academics, but it is a commitment which we have to meet. So my talk is on endoscopic cervical canal decompression, and I'll be sharing my experience. Yeah. Yes. So thanks once again, Dr. Malcolm and his team for inviting me for this fabulous endoscopic spine conference. I belong to Chandigarh, a city beautiful, which is one of the first planned city of Tri-City. I bring greetings from that city and my disclosures. So various systems today which we are using in our day-to-day clinical practice, you all know these systems you are conversant with, but this is an arthrospine system which I'll be sharing with because this is a new system. Many of you are not conversant. So briefly, I will highlight the advantages. Then I'll get back to my actual topic given to me. So it is now patented by Indian patents. And it is a sort of 3-in-1 system, quickly dry mode. It works like a miniature Pestonji system. Here it works like a PSLD. And here you can switch over to UB as Dr. Mukul has just now shared with you. And just to share with you the simple instrumentation, nothing much complicated. Only thing is that for neurosurgeons, it is little difficult to switch over to UB because we orthopedic surgeons who have some knowledge of arthroscopy, we have arthroscopy equipment in our theaters, and we have to simply switch over to, we have equipment in place. We go to a master, learn UB technique or PSLD, and then equipment is already there. You don't have a additional inventory or you don't have additional spending also. And again, a simple instrumentation, same Carrison punches which we use in conventional surgery, same micro instruments which we use in conventional surgery. And just modification is that thus when we switch over to a saline mode, when we are working to the nearest, I start with my procedure with the air endoscopy. Then when I'm very close to a surgical target, the problem here with us is that those of you who use dry endoscopy, that there is a repeated swelling of the scope with the blood. So to address that problem, you see here I switch over to saline mode, and this scope can very well advance beyond your working port of the tube, where this is not possible in a Pestonji system. So this is a little bit of innovation. As you can see on a spine model, how the scope has gone well beyond the confines of the tube, especially when you're working in an opposite recess or you want to advance into the foramina. So some salient features, I'll not go into the details. And this system can be used in all the pathologies, degenerative pathologies especially. And now coming back to my topic, today for canal decompression, cervical spine, we have option of laminectomy, anterior cervical decompression and fusion, and laminoplasty. To me, endoscopic spinoplasty seems to be a viable option. So the drawbacks of laminectomy, you all know, there is a risk of kyphosis in a kyphotic spine. Laminectomy is not indicated, and it can add to spinal instability, and there is a risk of laminectomy membrane also. ACDF, a beautiful procedure, but it is a lengthy and complicated. It immobilizes adjacent segments and imposes high mechanical demands on adjacent segments. And it has been seen that clinical and radiological deterioration during follow-up or subsequent follow-ups. Laminoplasty, again, a well-established procedure, but it requires a extensive dissection, which we all subscribe to a philosophy where we call ourselves as minimal invasive, or as Dr. Rohidas yesterday said, at the site of the pathology, we are maximally invasive. We are only minimizing the collateral damage. So we want to avoid the extensive dissection. So to me, from last 5 years, I felt that the way forward is the best alternative would be endoscopic assisted limited laminectomy and bilateral decompression by unilateral approach, ensuring adequate decompression, thus preserving integrity of contralateral musculature and posterior ligament complex. So my journey of cervical canal decompression started with in 2000. From 2000 to 2007, I was doing laminectomy and laminoplasties. Then I switched over to endoscopic bilateral hemilaminectomy. I was putting tube on one side, then on other side to do a good decompression. And spinoplasty I started doing it since 2017. And the indications, OPLL, multi-segmental cervical stenosis, in ligamentum hypertrophy, surgeon can use this technique, but it is a questionable here. And contraindication, the surgeon should avoid doing decompression, such kind of decompression when there is a focal anterior compression, there is an absolute kyphosis, isolated radiculopathy, and spinal instability such as tumor, trauma, or infection. So this is a demo case, 45 years old male patient. He was brought to us on a wheelchair. You can see there is a severe canal compromise. There are cord changes also here. And in axial cuts, you can see there's a big osteophytes anteriorly, and cord is very badly compromised. And just to share with you the operative technique, marking the level with the needle, then you use a 5 mm dilator, then there is a Weibel kind of a 10 millimeter cannula which slides over the 5 mm, and this 10 mm cannula dilator rests over the interlaminal window, and you can do a little bit of soft tissue retraction stripping from the superior and inferior lamina, and then the tube is slid over the 10 mm dilator. And this is how you work in a dry mode. And when you're close to the surgical target, there is a change of a working insert which has a rubber tubing, and then a switch over to a saline mode. And here is I'll try to play this video. Yeah. So part has been exposed. It's a 2-level spinoplasty. I am trying to remove the superior lamina here. So same principles in dry endoscopy as of Pestonji, but this is a miniature Pestonji tube because we are talking about small incisions. So this is I am using a miniature Pestonji tube here. You can call it as a arthrospine system, as I call it. And then the cord has been decompressed. You can see as I am trying to remove the phlegm. So that is now trying to go to the opposite side. I am trying to achieve contralateral decompression, contralateral side of along the cord. And this is a little, and this is a final decompression. You can see here, I have osteotomized the spinous process. This is a loose ligamentum flavum here. And you can see the osteotomized spinous process here. You osteotomize it and go to the opposite side and do a removal of the lamina of opposite side. And then finally, I switch over to a saline mode to have a closer look of the opposite side and to control the bleeders. So same instruments which we use in fluid medium, especially during UB. Here I am using a single portal fluid through a single port or a mono portal tube. So after achieving a good decompression, we close it on a subacute closure over a drain. And this is a post of picture of a MRI of a patient. You can see a reasonably good cord decompression and nice opening of the canal. You can appreciate that. Huge osteophytes anteriorly is not touched. And this is a post of X-ray of the patient. You can see the floating spinous processes here. So very small number of canal decompressions in last about, say, you can say 15 years. But this is how we keep on learning and adding advantage of endoscopic spine to our patients. So these patients were evaluated by a Nurex grade. And all patients have improvement in degrees only because our Indian patients, I don't know what happens in other countries, they come to us in a very bad shape. There are cord changes. They are very, very spastic. At times, most of them, they come on wheelchair. At times, you feel you should not be operating on these patients. But I have seen that if a good job is done, the first thing which disappears is spasticity. And next day morning, when you come for a round, they're able to stand with a walker and take few steps. 4 patients in this series had poor recovery. So friends, having said that, I just want to put a message across that as far as these techniques are concerned, mastering them, learning them is hard. But take your time, learn to adequately decompress first. Most common cause of failure or the poor result is a inadequate job done by a surgeon at the site of the pathology, because now these techniques have picked up. And there's a huge market behind these techniques, and they are pushing the surgeons, buy the equipment, we are with you, we'll teach you, we'll do this, we'll do this. But at the end of the day, now we are getting more and more failed cases where attempt have is made, but the inside pathology has not been addressed. So I do get 3 or 4 cases in a month where someone has attempted spine endoscopy, but the job inside has not been done. And to master yourself, master these techniques, keep going to as many as these courses as your practice and time will allow. So I always put this slide to share with my younger colleagues that once you're convinced about a particular technique, I think when we started spine endoscopy, it was only a transharmonic technique and distensive technique. So we had to choose between the two. Today, I think the youngsters are confused. There's a whole array of endoscopic systems around, and guys confused what to do, what not to do. So visit a surgeon where you feel that you are convinced with the technique, spend few weeks with him. Then once you're convinced, attend few cadaver workshops. That gives you more confidence. Then you do a first surgery in your theater. This is how I tell younger colleagues who want to learn these techniques. To summarize, endoscopic spinoplasty retains median structures, contralateral musculatures with least disturbance of mobility, stability, and lordosis of the cervical spine. Need of implants is minimized or eliminated. But I feel that well-designed clinical trials to show the effectiveness and long-term outcome of this surgical procedure is warranted. So, final thoughts, a technological innovation continues to facilitate reproducible surgical technique and expand the indication for use. We believe that endoscopic spine surgical techniques will provide surgeons with a more powerful and less morbid approach to spinal pathology that ultimately elevates the standard of care and when we are treating our patients. Thank you very much.
Nice technique of decompression of the cervical canal, wonderfully demonstrated. I fully agree with your training program. One has to train himself for various techniques and do a cadaveric workshop, and training is a must before you go on a live. In 1991, when I went to Professor Yassergill to learn something, microsurgery, I had in a laboratory we were doing on animals, one Japanese neurosurgeon was there. Very interesting. So I asked him, since how long you are here? He says, I'm here since 3 years. I said, have you operated on a human? He says, no. I'm still learning. So this is something very important for all of us. Before we start for any technique or anything, we must train ourselves in various ways.
Thank you.
Yes, now we are going to learn more about exoscope, which is going to replace many, many things. We are talking all about endoscope just now, and maybe in a couple of years or 3 years, we'll see exoscope. Thank you.
Thank you. Thank you, sir. So, no questions? Thank you.
Now I call upon Dr. Shidem.
Good morning, dear colleagues. Today I will talk about contralateral sublaminar UBE technique for L4-5 femoral migrated herniated disc. For one cases. Intraforaminal and extraforaminal lumbar disc herniations usually refer to as far lateral disc herniation. Usually involve free fragments which have migrated superior lateral to disc space of origin. They occurs 7 to 12% of all disc herniations, and it's more common at the L3-4 or L4-5 level. It's rare L5-S1 level. Clinical syndrome reflects compression of the superior exciting nerve root and ganglion. They can cause severe pain and often lead to motor and sensory deficits. Often it doesn't respond to conservative treatment, and usually it requires surgery. Sorry. Here it is showing anatomic zones described in axial and coronal projections. On the horizontal plane, these landmarks determine the boundaries of the central zone, the subarticular zone, the foraminal zone, the extraforaminal zone, and the anterior zone. Herniated disc may be purely for lateral or extraforaminal in location, located beyond the pedicles, or may include intraforaminal and even intracanalicular components. Surgical approaches to the lateral disc herniation are challenging because of the anatomic limitations in the region. Due to anatomic location, the disc, a standard paramedian approach would require significant drilling of the facet joint and the potential for creating iatrogenic instability. Various techniques for the surgery of lateral disc herniation have been reported, including interlaminar approach with various degree of facetectomy, intertransverse, and far lateral approach. In our case, we performed that contralateral sublaminar endoscopic foraminal discectomy with biportal technique through the right side interlaminar window. The patient is 38 years old, female. She presented to our clinic with a severe radicular pain on the left leg during the 1 week. The straight leg rise test was 20 degrees, her left leg. Her period operative visual analog score was 9. The patient was neurological intact, but according to the patient, the pain was severely limiting her personal life. This is her MRI. MRI T2 weighted sagittal and axial view demonstrated a left-sided L4-5 disc herniation causing compression of the exciting left L4 nerve root at the neural foramen. Now you can see intraoperative video. First, spinolaminar junction is drilled. Upper lamina, L4 lamina. We were drilled right side. Now I identified in the midline cleft, and then now contralateral side. We are drilling contralateral side lamina. We are doing sublaminoplasty. Sometimes too much bleeding, but don't worry. Subluminoplasty should be extended more cranially, more cranial on the lateral border until the flavum edge is freed. And also subluminoplasty should be extended caudally to the superior articular process with optimal decompression of the lateral recess. We should see insertion of the right side ligamentum flavum. Now ligamentum flavum is dissected away from the dura. And too much bleeding foraminal because of the vessels foraminal area. If when too much bleeding, we can use gel foam to control hemostasis. You can see huge vessel under the ligamentum flavum. Now we are doing flavectomy. Flavectomy starts from midline towards to ipsilateral side of the rupture disc. Now, actually, we can see transversing root under the Carrison punch. Yeah, it's not touching actually. This radio frequency probe 50 degree is nice for contralateral side to control bleeding.
Can we go ahead?
Yeah,
faster?
so yeah, I couldn't move yes fastly. Sorry, just 1 second. Almost done. Now we can reach fragmented disc. So just 1 second. Um, You can see herniated disc. Now I removed. I will try to remove under the exciting route. Actually, we are reaching extraforaminal area. Yeah, it's, because this herniation is extraforaminal area. Now, remove big parts of the disc. Then hemostasis is done. And also we can in this method we can reach inside the disc. Now we are doing discectomy. Sorry. This is the patient's post-op MRI. You can see this fragmented disc is totally removed. You can see on sorry, on CT the way of you can see trajectory here. Conclusion, contralateral sublaminar foraminal discectomy using biportal endoscopic approach can be an effective and alternative procedure to remove combined intraforaminal and extraforaminal disc herniations. It may avoid the risk of iatrogenic instability and maybe neuropathic pain in the foraminal and extraforaminal disc herniations. Thank you so much.
Thank you very much. Nice demonstration.
Yeah.
Excellent. I
Thank
think
you.
we should move ahead. The next session.
Thank you. Thank you so much, Dr. Harshad sir, for gracing us and sharing these sessions. May I request Dr. Anand Kavi to please take the stage. Dr. Bhupesh Patel, please. And I think Dr. Tariq Yazar is waiting online. So we'll finish his talk and then go to Dr. Puneet Gulati, who's also been waiting for a long time, and then carry on with the regular program. Dr. Bhupesh Patel, please. Dr. Anand Kavi, please grace us on the stage. And we are now connecting with Dr. Tariq Yazar. He is one of the most senior spine surgeons of Turkey. And it is amazing to see that at the age of maybe 70 plus, he has learned biportal endoscopy and he now practices it. So I think that is a clear message to all of us. The change is inevitable, the change is necessary, and the change must be adopted from the heart. We are all spine surgeons and we are all progressive in mindset. And that is what this Congress underlines to all of you. So I'm waiting for Dr. Tariq Azhar to join us. Can you please get him online?
He's online. Sir.
He's online. Dr. Tariq Azhar, can you hear us? Dr. Tariq?
Yeah.
Good morning,
Morning.
sir. Good morning to you. We are about to play your talk, and please be online to take some questions, sir.
Okay,
Thank you very much.
Thank you.
Thank you very much for being with us.
It's very kind of you, dear President. You are very kind. Many thanks for your nice words.
Thank you, sir. Thank you, sir. You are an icon to all of us. You are a beacon of hope. Thank you.
It's very kind of you. Thank you.
We are about to play a talk, sir. Your talk is on, sir, now.
May I do virtually?
Beg your pardon, sir?
May I do from the
You want to share your screen? You can do that, sir. 1 minute, sir. 1 minute. You can share your talk directly then.
Thank you.
So please start.
Okay.
You can see your screen, sir. One minute, your sound is lagging, sir. Sir, your voice is a little less. Can you speak loudly, sir? Yeah. Please go ahead. So please put up your computer volume and please play your video from your computer.
Okay, I'm trying.
Yeah, please. Yes, you're on, so now.
Do you hear me?
Yeah, we can hear you, sir. Can you please start from the first slide?
First slide. Okay, sir. Excuse me for the technical problem.
No issue, sir. We are with you. We are with you, sir.
Thank you. I will talk about the segmental instability. What does the mean of it? And when there is a physiological load on the spine, there is more than normal movement between two adjacent vertebrae. In order to truly understand what segmental instability is in the spine, it is important to understand spinal anatomy. At the picture, we see the cross-section, sagittal cross-section. Motion segment is a trio consists of two facet joints and disc. This structure provides balance and transmission of the load to the ground. And this is pars interarticularis has obvious sclerosis. The defect can be seen with a very little axial rotation of the patient. This is a spondylolysis. Like this. This is the same patient. We can see two positions altogether here. Instability, very obvious here. And I would like to share just cases only. And this is another one, L4-5 segments shows us defects, 4 different defects in this patient. And these are the Mosher hooks from Zurich, Switzerland. Once upon a time, we have used them, and they are very strongly and with the nice results we have. And this is quite interesting case. He was working in a factory for the production of mineral from the ground. Suddenly, a dynamite explosion pushed his pelvis from posterior to anterior, and the whole spine fell down, fell to the posterior of the S1, L5, S1. This is the CT. This is a segmental instability, extreme example, but it's a segmental instability, and this post-operative appearance. There's a defect. It's my fault. This part of the corpus of L5 disappeared. We destroyed it, and we fixed like this. It's 1990 years, and in approximately 10 years later, the spine is the young man here, and this is the very, very degenerated position. But the patient like this, 11 years later, this is the walking pattern of him, and paraplegia disappeared. Cauda-Equina syndrome more or less disappeared. He married and he got children. This is very typical, very well-known monosegmental instability. This is spondylolysis. And this approach with geometrical sagittal approach is extremely important, because we have to know the pelvic incidence, the sacral slope, and the lumbar lordosis. These are extremely important topics. We have to plan preoperatively, plan the postoperative quality of life. We have to plan when it's possible, of course. On the lower row, we can see the postoperative appearance. And this here also very tricky points. For example, the support, anterior support, must be more than 30% of the end plate surface against subsidence. And we have to be very careful. For example, patients with low pelvic incidence should probably have lumbar lordosis of pelvic incidence plus 9 degrees. And those with high pelvic incidence should probably have a lumbar lordosis of pelvic incidence minus 9 degrees. the distribution of lordosis along the lumbar vertebra is extremely important. 2/3 of the lordosis should be located from L4 to S1. And here, I'm trying to do UB, not very fast, but Zila. Do you hear me?
Yeah, we can hear you.
Thank you. I made a mistake. I wanted to faster movie, but unfortunately, it's frozen. Must I stop?
Do you want me to play the recorded
Yes,
talk
please.
instead?
Yes, please.
So you can exit that presentation and stop sharing the screen, but be with us. We will play the recorded talk.
Okay, okay. Oh. Mm.
Yeah, started. So we've started it at the same spot where you were demonstrating UB.
Okay. After 2071, Can you manage? Oh yeah. Do you see the screen?
Yeah, we have played the recorded talk and we are able to see the screen where you are doing UB. Are you seeing the same screen?
Yeah. Yes. Thank you. There is no distortion now.
No distortion at all.
And can I change the slide? May I proceed?
Yeah, you can. Okay, so we have gone to the next slide, load transmission.
Okay, thank you. Axial load transfer should be uniform across the intervertebral segments. Some low back pain probably is correlate with the abnormal load transfer between the vertebral bodies. The goal of fusion is to maintain the solid and uniform bone mass throughout the segment. Thus, this position allows stable load transfer. Amorphous irregular fusion may be the cause of postoperative pain. Balanced load transmission prevents graft subsidence. Fusion area must be larger than 30% of end plates. Otherwise, pseudarthrosis could occur. This is another instability. And multifidus muscle, like a conic geometry, and we mustn't disturb any one multifidus muscle. I don't have time. I don't want to disturb the Congress. With your permission, I would like to thank for your kind attention. Many thanks, President. Thank you very much.
Thank you so much, sir. And it was a very insightful presentation. Thank you so much for joining us.
Thank you, dear Professor. Thank you. It's very kind of you. All the best. It's a wonderful Congress, really. I'm very sincerely excellent. I would like to congratulate you, and I'd like to extend my cordial regards. Thank you very much, sir.
Thank you so much. So with that, now I call upon Dr. Bhavin. Dr. Bhavin, is he here? Then Dr. Ajay Krishnan. Dr. Varun, are you there?
Very good morning to everybody, and thank you, Dr. Malcolm, and all the organizers for inviting me for this lovely conference. And we've all been having a nice time. I'll be presenting on endoscopic and MIS management of tuberculosis spine. I'm Dr. Varun Agarwal, Associate Professor of Orthopedics at Rohilkhand Medical College in Bareilly. So I don't have any financial disclosures, and all the cases which I'm going to present are my own cases. So skeletal tuberculosis is common in India, and vertebral tuberculosis is the commonest form of skeletal tuberculosis, like we all know. And dorsal spine is the most commonly involved. Only 10 to 30% cases present with neurological deficit, and it is more seen in the first 3 decades. And diseases below L1 vertebra rarely cause paraplegia. We all know this, and this is the basic principle of management: early diagnosis, expeditious medical treatment, and if needed, an aggressive surgical approach, and everyone can expect a good outcome. So this is how we divide the present management of spinal tuberculosis: conservative treatment with chemotherapy alone, a middle path regime, and radical surgery. We have all been taught this. So this is a case of a 28-year-old female, carries back pain, constitutional symptoms, no deficit. So we all follow this in India, the middle path regime. Everybody has grown up with this, Dr. Tully's middle path regime. that all spine tuberculosis do not require surgery, and all those who do not respond to conservative measures should be operated. So this is the middle path regime: rest, POP bed, hard bed, and these drugs. We all have our own regimens, mostly follow the DOTS regimen, and then monitoring every 6 months and gradual mobilization as the patient is recovering. So these are the absolute indications for surgery. No progressive recovery is there if there is any neurological complication, worsening of neurological deficit, recurrence, pressure effects, etc. So this is a case of a 16-year-old female, caries, presented to me with quadriparesis, and you can see this big vertebral collection of pus and the destroyed vertebral segments. And this is what we did. We did a USG guided biopsy, and then we did a radical surgery and fixed her from both anterior and posterior, the big autologous graft. And these are the scars, and she did very well. And at 1 year of follow-up, she's recovered fully. So another case of mine, 12-year-old male, elsewhere operated 5 years back, presented to me with a severe kyphotic deformity at D2 and D5, a sequelae of tuberculosis, and with impending paraplegia. And you can see the preoperative scars here, where he was operated earlier. And this is how we operated this under O-arm navigation. So this is the O-arm, which we take the 3D scan of the patient during the surgery. And then this is how under navigation, we can use the screws, and we exactly know where we are placing the hardware. It is especially boon for such high-grade deformities. And you can see where the screws are going, in which direction, even the axial plane you can see. And this is how it was done. You can see the screws being placed in this high-grade kyphotic deformity. And then a VCR operation was done. And this is how it looked like intraoperatively. You can see the graft being placed posteriorly and the cage anteriorly. And this is the post-operative result, patient doing very well. So between this conservative and the radical two ends of the spectrum, are there any other options for us? Is there a surgical middle path, so as to say? So this is another case, 39-year-old female presented with caries of L4, L5. You can see here the amount of pus there. She had debilitating back pain and radicular symptoms, but she didn't have any loss of power. So this is how we manage these cases nowadays. We just do a percutaneous endoscopic decompression under local anesthesia. And you can see how big debridement and this debrided mass has been taken out, and the patient gets good relief. So this is another case of mine, 17-year-old female, caries of L2 with a debilitating back pain, power grade 5. And you can see on the X-ray that there's destruction of the vertebral body. The spine is at risk, and this is the CT scan of that same patient showing the vertebral body destruction. So in this case also, just percutaneous fixation under O-arm navigation was done. No debridement, no anterior job. Just stabilize the patient, mobilize the patient the next day. And you can see here that at 5 months, there is good fusion of this mass, and there is bone formation also under AKT treatment. There's another case of mine, 15-year-old female, presented with caries at D7, D8 and complete paraplegia. The MRI shows a big paravertebral collection and compression of the cord. So the patient was planned for decompression and fixation. She came to me during the COVID times. And as we all know, then the second wave of the COVID, there was a severe oxygen crisis in the hospital, and we were not getting any oxygen for the surgery. So this is what we did. So this was under O-arm 3D navigation and under local anesthesia. This is how a percutaneous endoscopic decompression was done. I put a navigated Jamshedi. The pus was aspirated. This is all being done under local anesthesia. The guide wire is being passed now. And then the dilator over the guide wire in the thoracic spine. This is just confirming the placement. And then the scope is there. The scope is put. So this is how it looks like. This, the navigation tracker has been put on the scope. And you can see here, this is how the debridement was done under local anesthesia. And I took some couple of shots the C arm. And then and even I was surprised that after 4 months, this patient presented with complete neurological recovery. And then I just did an MIS fixation under GA, again using O-arm 3D navigation. So this patient was walking from the next day, and this is at 1 year follow-up. She is doing very well. So the radical surgery, which we all would have done, has been just converted to percutaneous and minimally invasive. So this is another case of mine, a 51-year-old male with spondylodiscitis D10, D11, again with paraparesis, bladder bowl involvement. And you can see the big pleural effusion there with the pus. And there you can see the body is getting destroyed. Even the chest tube is placed. And he had type 2 diabetes mellitus. No anesthetist was ready to give general anesthesia, and nobody was, giving him fitness for surgery, and he was in very bad shape. So again, this is under, and percutaneous endoscopy was done under local anesthesia. And then the debridement was there. You can see here the superior articular process, the exiting nerve root in the thoracic spine due to the collapsed vertebra, the caseous material all got debrided. This is the intraoperative video. The caseous material there all evacuated under an endoscopy. And then under local anesthesia, again, the Jamshedi needles were put, guide wires, the screws were placed, rods passed, and then percutaneous stabilization again was done. So this is how it looks like post-operatively. And the patient, you can you can see the chest tube was still there inside. So if the patient is neurologically intact, we apply Taylor's brace after surgery for 48 hours. The patient is ambulatory. Then follow-up as per the regular protocol is being done. And then the recovery taken for near complete recovery varies from 3 to 6 months. We usually give the AKT for 12 to 18 months. So this is our recent publication, percutaneous pedicle screw fixation in the Carey spine. Does early MIS fixation has advantage over conservative. And this, we have showed that it is a safe small incision procedure which provides a good internal rigid stabilization, improves disability, and attains fusion, which prevents progression of the angular curve. So in conclusion, tuberculosis is a medical disease, and in indicated cases, timely and complete intervention gives good results. It also helps in rehabilitation of the patient. The surgery need not be extensive, and it should be directed at the problems. So with this, I invite you for this upcoming cadaveric course at Dehradun. And thanks a lot for a patient hearing. Any questions?
Thank you, Varun. That was a very nice presentation, challenging cases and wonderful use of technology.
Yeah, so we've realized that we don't need very extensive surgery every time, and a targeted approach, even in these kind of patients, gives really good results.
Thank you so much. Yeah. Now I call upon Dr. Ajay Krishnan.
Just as I'm connecting, I would put the questions to the chairpersons and Varun also. At what point do we decide that it is the mechanical instability which is dominating, or it is the infective component which is causing pain in a spondylodiscitis? Because that is the major thing which would decide. As yours have been an unstable case, but for a discitis or a spondylodiscitis, there has to be a timeline or a cutoff beyond which we know that it is the mechanical symptoms which has added on, and probably just a debridement or just a transforaminal surgery or just antibiotic may not work. If anybody has read or anybody has any guidance to give, please help.
That's a very good question, sir. Typically, I stage cases. So if the instability is not very apparent, I just do an endoscopic debridement. If the patient is getting relief, don't offer percutaneous stabilization. And if even after a week the patient is still persisting with pain and still debilitated, then sometimes I offer the pedicle screw fixation. So it is a good idea to stage such patients also.
Condition of end plate is also important. If the end plate are totally destroyed, then it would be mechanical instability which is contributing to the pain. And if end plate is intact, then it would be, we can't give a conservative treatment. Is what I feel.
Because that is the thing. If Varun said, if we can stage it, that is the best thing. And probably for even degenerative disorders, it is the same thing. If the patient's mentality and education level is such that they are ready to accept as a staging procedure and intermediate procedure, then everything should go on from a pain procedure as an injection therapy to a smaller invasive endoscopic surgery to a fusion surgery. That would be the ideal thing to happen. But it is seemingly not apparent in the society, and we all jump to the next level.
We have to stick to the basic tenets. It is, we have to prevent neurocompromise by neural decompression if at all it is occurring. And secondly, we have to prevent instability and see to it that it fuses.
Yeah. Thank you. Just to add to what we all discussed on transforaminal endoscopy, my talk. Thank you for the society, and thank you for Malcolm specifically, who had given the opportunity to present here. Complications and the pitfalls regarding the PTLD, there are many, and few of them will just go through to make it understandable. And many a times the patient wants support. That is the biggest thing, and that's why there is a lot of difference in the entire world as to somebody will do under local anesthesia to regional anesthesia to general anesthesia, and each has got its own pitfalls. And local anesthesia, if you are doing, then the counseling and making the patient understand is very important. I've been doing since in the local since years. It has been 2 times I had to get the patient back and then again take inside. So it does happen. So counseling is important. While executing the procedure, you have certain problems you find, and there are problems which you find after executing of the surgery itself. So you can say the executional problems. At the same time, there are many which you will find after you have executed. So that is the post-operative problems or the future problems which you can see in the patient. So per-operatively, what you find is a bleeding is one of the things which is there, and that bleeding has to be tackled by, say, fluid is first, or waiting, putting your trocar back. You can use pressure with instruments to just push it on the bone to seal the bleeding, and waiting does help. Waiting does help in many of the cases. Mechanized irrigation pumps definitely help, but at the same time, it can increase the utilization of the water, and the same time increase the intracranial pressure to a big extent in long duration surgery. So time should be in mind. Hematoma is rare to form, and that can be an epidural hematoma, which could be small, or it can be symptomatic even. And vascular injuries can occur of the radicular vessels or any of the vessels, which can present as even a retroperitoneal hematoma. Rare mentioned things which is there, and you need to actually again coil a pseudoaneurysm which may form. And then the injury which can occur is the dural sac tear. And dural sac tears, as you share amongst your own peers, everybody says that it is less noted or less troublesome. It's the same thing we have all shared across, and it is less noted. That is the thing. It does not occur, it cannot be said, but it is that it is not recognized many a times. The reason being it is not recognized is the tears are usually small, and it is the fluid which is pushing the neural tissue further into, and this is ventral, and that is the probable reason why rootlets may not herniate out, unlike a dorsal surgery wherein a small tear happening, with the pressure itself the rootlets come out. So that would be the reason which is not wherein it is not recognized. But I also agree that it is not that it's not happening, but symptomatically it presenting is less. So a mechanical tear can occur, or a thermal tear can occur, and what to do if it has happened. So that depends upon which stage of the surgery you are. Already, if the decompression is done, you may just finish it and wait and manage the patient like any other transformal surgery with some amount of rest, and probably the patient will heal out. But if there is a CSF leak, then you need to either suture it down or go in or pack it. That's it what you need to do, from whatever I've heard from my peers who have done. At the same time, if the surgical objective is pending, you need to re-explore it and complete the surgical procedure. At the same time, take care of the dural tear. Or if the patient becomes symptomatic after the dural tear because of a rootlet herniation or new symptoms, then again you have to go. So this all depends upon the endpoints of the decompression. At the same time, whether the patient is symptomatic or not. This is how you see a dural tear if it has happened there in PTLD, and usually in the interlaminar it just herniates out. So that's why you are able to recognize, and that is what I have noticed and understood. Abdominal injuries to any of the structures can occur, intestine being the most common, or the ureter or the bowel, the bladder, anything can be injured. So that is the trajectory injury which can occur when anything has come into the path of the needle and you have taken, and for the upper lumbar or dorsal disc, you have gone more horizontal, you can enter into the peritoneal space. So that is, and the most important thing for any instrument which can pass across the disc to cause an injury would be a spondylodiscitis being addressed with a transforaminal surgery. So the annulus being soft, the instrument can cross over and can grab anything and cause injury. So be cautious when handling spondylodiscitis. Seizures, say prodromal symptoms in the form of neck pains, headaches, confusions can occur in long duration surgeries, or when more amount of fluid has been infused or mechanical irrigation pump has been used. And it also depends upon the indications of the surgery which you are doing. Say you are doing stenotic decompression, ventral stenotic decompression, wherein you are doing more amount of epidural work. So you need more fluid. So the amount of fluid, the speed of its infusion, and the time taken would decide whether you will have these symptoms or not. Under GA also it has been mentioned that it does occur. So local anesthesia is in fact good for doing this, because you are able to understand the prodromal symptoms of say neck pain or a confusion or a headache, where the patient would say, and you can stop there, just wait there for the fluid to regress. Then again you can attempt, and if supportive you can go on, otherwise you have to abandon. So prodromal symptoms are what to be looked on before letting a seizure precipitate, because seizure would be which can cause major problems. Failure to decompress or an incomplete decompression and leading to a surgery is something which is the worst part of transforaminal surgery. And in the learning curve, everybody would face this out. And to prevent this, what you need to do is a post-operative MRI and assessing your own decompressions. And wherein this failure occurs is usually the migrated disc herniations, where the fragments are more. It's not a single fragment. There may be multiple fragments, and you may miss out small fragments. Axillary fragments may be there, wherein you are not able to reach into the axilla and remove it until unless you have pre-identified on the MRI that you need to address to the axilla. You may fail. Central disc herniations, actually these all were contraindications to the surgery itself, like an associated stenosis, a calcified disc, dynamic stenosis, or instability if you have missed to identify them. These are the cases wherein you get a failure. But at the same time, you have to understand that many of the surgeons, including me, have gone on to this territory also to do the surgeries. So if you achieve the decompression, you can succeed, but they have all been contraindications 5 to 10 years back. Still, in many of the literatures, it is said that these are all contraindications, but we are able to do it now. My first case failure was this third case. First case I won, second case 14 years back when I started, first case was okay, second case was okay. That was paracentral disc. The third one, I took this case, I went in, I kept on doing this. You can see the direction of my scope. My entry at that point was 7.5. And that day I changed my entry. I went to 12 to 15 centimeter from that day, from what I learned. And then I immediately moved to, I have to be in the epidural space to decompress. So that's how this patient I had to revise to an MLD at that point of time. And that was a decompressive failure. Decompressive failures don't occur now because I changed my concept to reach to the epidural space and decompress. Now, just this year, I published this article, Endpoints of Decompression. See, for any surgery, not even for the traditional interlaminar surgeries or a endoscopic surgery, the only way is subjective ways of assessing the decompression. What you end up doing is, say, mobilization of the root by half a centimeter to 1 centimeter to midline. So that is the feeling. Then you feel the nervous tissue. Is the tension in the neural tissue which you there. You probe into the foramens. you probe with the pencil or the hook, and then you identify the points of decompression. This has been traditional training, but for transforaminal endoscopic surgery, there has been, or any other surgeries, there has been no objective criteria to define what is the end points of decompression. I tried to pin them down and got it published. That would be worth to go in. Not all can be achieved. As maximum you achieve, it would be that you will be able to get near to your better results. As Malcolm was saying in the morning, the reason for failure of the transforaminal in many of the cases is that you are addressing only a focal pathology, not taking into consideration the general things which is around. So all things needs to be considered, and you have to address it as a complete pathology to have a better outcome. Infections can occur, and if it happens, then you again can go in and get a sample, give a wash, and it may succeed. You may succeed provided that the mechanical dysfunction has not settled in. So a conservative care is possible if you have intervened in the first 1 to 3 weeks probably, but not later than. You cannot, otherwise the treatment gets protracted and the patient is into suffering, and it may take say 3 to 6 months to get a autofusion. So therein you need to intervene and do a fusion by yourself. That would be better. Reherniations can occur up to the tune of 15%. It has been reported in the literature, and the most common reasons have been mentioned by few of the literatures as a male: hyperactivity, obesity, end plate osteochondrosis, Fuhrman Gates 3, disc space collapse, central LDS. These were all the cases. Yesterday, Arvind's talk, that was a good talk to just listen, because in those criterias, indirectly this was coming. It was coming indirectly. So you need to identify which are the patients you are going to offer a decompressive surgery. Radiation safety, as Mukul also talked about it, but An was good at it long back in 2001. I thought I missed that year. He mentioned that if you are doing 291 PLDs a year without radiation protection, you can do safely. So that's a big thing which he came out, without radiation protection. And if you want to increase your numbers up to 5,000, then you need to be using all shielding measures. So that was a very big paper from somebody who has excelled and a master in endoscopy. Anesthesia and sedation, all gauze, all the medicines, all the drugs which has used, all can give you some problem or other. And that's the reason why you need to have a professional anesthetist with you always. Don't take it lightly. The day it happens, it can cause havoc. Unique complications like a broken implants can occur. Seen people having broken the cannula inside, the hooks inside. You need to remove it. So that can happen. Don't use force. It's all a neurosurgery, orthopedic spine surgery. Everything is about being gentle. We can be aggressive in our outlook, not in the surgery. Just see this. Anybody can guess what you can see in this MRI, which is different, or if you're not noticed anything new. As you go on doing, you notice new things in the MRI. Now, this is another case wherein I spotted small dots here. This is air. This is air. So this is air in the epidural space. So this can happen when you are removing the scope and putting it back. There can be bubbles. This just goes off. It's not complication. Just notice. So you keep an eyes open to identify more and more things. Transient and permanent paresis. So that can happen only if you are meddled with the neural tissue. Either it is the traversing or the exiting nerve roots, and it can be old or new injuries or new roots. That is the most important thing which you need to actually point. A new symptom which can precipitate is the post-operative dysesthesia. The post-operative dysesthesia has always been mentioned in the interlaminar surgeries also, but it was more for the traversing nerve root, which was as such also symptomatic. So the patient has symptoms which you are able to control with medicines, and over a period of months to weeks, it goes off. But in cases of transforaminal, you can get a exiting nerve root injury or a pressure symptom. That is called post-operative dysesthesia, and it's a new symptom. But to remember, it's a new symptom. It's not the same root which the patient had symptom. So it can occur for blind foraminoplasties, for more in outside in. It occurs in advanced fusion indications, upper lumbar disc, and in L5S1. So just an example, another, this is a case wherein you can, I've reached the posterior border of the vertebral body in the transforaminal approach, but you see in the AP, it is at the middle to lateral border of the interpedicular space. So if you are not at medial pedicular line and you go here, so the endoscope tries to push this root more laterally, and there is where you can precipitate. And that's why I had to go and I went in by a transiliac approach. So you have to identify wherein you can cause a problem. A needle will not cause a problem, but as a bigger instrument will go and you're not recognized, as it goes there, you can create problems. Irritation to the nerve root, if at all you have identified while you're putting it, just change your trajectories, and many methods have been mentioned for this. And the most one of the things which you should notice is conjoined nerve roots and the crowding in the foramen, which you should have to look for. In the axial section, you can identify something like this, a large root at the upper level of the disc. So this is the paper for that. If you take a section at this level and this root which has already exited, you should be able to see that distance to identify and be away. And this is again mentioned by many, and this is a floating retraction technique wherein you go in the lower foramen and then shift to the middle into enter in. So by that you are able to take the nerve root more above. These are other methods which have been mentioned. If you go to search the literature, how many complications, what complications, this is the best literature you have. And out of the 26,000 cases which they reported, the complication rates were overall less than 1%. So there's a big series to quote for, and POD approaches just 0.2%. So, and then another one of the complication paper which has been given by Kim, that also talks about all complications, but they are shrinking percentages of complications and very less complications. So literature support is very, very less, and but it is shrinking percentages. Complications can, nutshell the take home messages, complications can be parallel or as higher or lesser than the traditional surgery. So you have to be aware of it. Steep learning curve is required, and initial learning curve will have more complications. So be careful. Experienced surgeon, by expanding the indications, adds new complications. Like I have spotted new complications. Preventive, most of them are preventive you are aware of, but open procedures must be mastered by the surgeon to go into this further. Technology will definitely improve the outcomes. It is improving as in our hands. At the same time, fluoroscopy, navigation, intraoperative ultrasound, XMRIs, that will help you achieve a per-operative decompression and a completeness. So if it gets reproducible and the learning curve gets shortened, we can definitely master this, avoiding the complications. Thank you.
Thank you very much, Ajay. Now I call upon Puneet Gulati to present his talk.
Thank you. Thank you very much.
Okay, good morning, everyone. A big thank you again to Malcolm sir and the organizing team for this invitation. Thank you, sir. So I'll be presenting my talk on discography now. So today, clinicians are dependent on advanced imaging studies such as MRI to diagnose low back pain. However, there are many patients with low back pain, as we all see, who demonstrate no structural abnormalities on MRI. Studies show that MRI findings such as degenerative changes in the disc morphology do not correlate with the presence or severity of the low back pain or even the outcome of treatment. Now, these are the cases which require supplemental diagnostic studies such as discography to confirm the disc, the degenerative disc, as the pain generator. So coming to the indications for discography, it is typically reserved for patients who report back pain for an extended period of time. And obviously, it's not the first diagnostic study of choice, currently performed only after other imaging studies such as MRI are completed to obtain additional information for further management. Now, many asymptomatic discs appear abnormal on MRI, and there are discs that appear normal on MRI but have been found to be causing symptoms on discography. The North American Spine Society recommends use of discography in persistent back pain where correlation with images is lacking, negative imaging findings where pain is unexplained, suspected disc abnormalities, patients being considered for spinal fusion surgeries. For spinal fusion surgeries, discography helps to assess the levels for possible fusion. There are studies showing where, with the help of discography, the number of fusion levels have been decreased or increased. So to assess the levels above or below possible fusion, to include or exclude those levels, and also in patients with failed back surgery, whether the adjacent level is actually the cause of the pain, this discography can be used to extend fusion if needed. Procedure: provocative discography involves insertion of a needle into an intervertebral disc and injection of the contrast agent into the nucleus pulposus under pressure. 2 to 3 ml of contrast is injected as a maximum, and conscious sedation and painkillers are not to be used during the procedure to avoid masking the pain sensation. A schematic representation. Now, what for to look in discography? Concordant pain is the first thing. Is the injection producing pain? And if so, whether the pain is concordant or discordant with the patient's primary pain. Pain provocation is crucial. A positive level must be re-stimulated several minutes later to confirm the finding. Then pain score: pressure within the disc is measured with a manometer. Means ideally it is measured, but like in my practice, I don't have in fact, I haven't even seen a manometer, to be very frank. And I just go by the feel and what the patient tells me after injecting some amount of dye. Volume of medication injected is checked. Dye distribution and disc morphology, including presence of tears. And a follow-up CT is highly recommended. Now, non-painful discs with positive imaging findings are considered not significant. Painful discs with negative imaging findings are considered inconclusive, and repeat testing is recommended. Coming to disc pressure, this is measured through a manometer connected to the inserted needle via a tube. Opening pressure is noted when the dye is appreciated within the disc space, and disc is pressurized till 90 psi or till the pain is elicited. Now, so the pressures at which the pain is provoked, this also tells us something. At less than 15 psi, the disc is considered chemically sensitive. This indicates that the disc is highly sensitive and does not require increased pressure to respond. 15 to 50 psi is the mechanically sensitive disc. This is generally the pressure range where we get the patient to where the patient tells us that now he's having pain. 50 to 90 psi pain comes, investigate other sources. And if no pain is provoked by 90 psi, the disc is considered negative. Now, the discographic imaging findings on our plain fluoroscopy images. So the first picture we see here, this is the cotton ball. There is no degeneration, soft amorphous nucleus. This is normal. Then a lobular, which is the mature disc, lobular, the mature disc, where the nucleus starts to coalesce into fibrous lumps. Next comes the irregular, where the irregular disc, where the degenerated disc with fissures and rents in the nucleus and inner annulus. The fissured disc, where the degenerated disc with radial fissures leading to the outer edge of the annulus. And finally, the ruptured disc, where the disc has a complete radial fissure that allows the injected fluid to escape. This can be any stage. Then C-arm pictures. This one is the lobular disc. This is a fissured one. And the last one obviously is a ruptured disc. Role of CT scan. Now again, this is something which ideally is recommended in every case, but I don't know, in my practice, not routinely done. But yeah, ideally immediately following discography, CT scan is performed. It confirms contrast injection into the nucleus pulposus and further assesses the annular degeneration and annular disruption. And contrast distribution within the CT scan is assessed using the modified Dallas discogram scale. So here the grade 0 is a normal disc, no contrast material leaks from the nucleus. Grade 1 tier up to the inner 1/3 of the nucleus. Grade 2 tier contrast leaks through the inner 1/3 up to the middle 1/3. And a grade 3 has a contrast leaking right up to the outer 1/3 of the annulus. Grade 4, not only does the contrast spread to the outer 1/3, but there is also a concentric spread which needs to be at least 30 degrees for it to be called grade 4. And grade 5 is again a rupture where the contrast spreads outside the disc. Functional anesthetic discogram. The goal of discography is to identify a potentially symptomatic disc that will likely benefit from a treatment intervention. This improves the predictive value of the discography test. Once painful discs are noted on provocative discography, the next step involves the placement of a catheter into the lumbar disc that was painful. And on injection of radiographic contrast, it is highly suggestive of being a pain generator. So now there are catheters which are specifically designed for this purpose. But otherwise, even a normal epidural catheter, if you tape it in place, this can be used. So where this proper FAD catheter is used, its coaxial over the wire technique is used to insert it. And it's a small flexible double lumen catheter inserted into the nucleus and secured in place by injecting a balloon port and inflating the tiny balloon at the tip. This ensures that the catheter stays in place, and when the patient moves to reproduce the pain, the catheter doesn't come out. This is the balloon tip. The second lumen allows for the injection of liquid agents into the disc nucleus. So the disc is injected with a small volume of either a local anesthetic or a saline, with the saline being used as a placebo, just as a control. Patient is asked to perform simple maneuvers which typically elicit that back pain. It generally is most commonly sitting. So the patient is asked to get up from the table, sit in the position he normally sits in when the pain is reproduced, and after the injection, whether this pain is relieved or not. The initial injection of local anesthetic typically causes exacerbation of the pain, followed by, in positive cases, the onset of effect of local anesthetic in 2 to 5 minutes, where the pain is relieved. Coming to contraindications, pregnancy, coagulopathy, skin infection of the puncture site, allergy to contrast medium, psychiatric conditions, depression, as the test relies on patient input, or where secondary gain, patient has some secondary gain, then ideally this procedure should be avoided. Solid bone fusion, which does not allow needle entry, severe canal compromise, as that may result in canal obstruction, and acute cauda equina syndrome. Complications, nausea, headache, increased pain, these are transient temporary complications, may be seen in a few patients. Then among the complications, we worry about discitis, nerve root injury, dural injection of dye, urticaria, contrast reactions, then bleeding intrathecal or retroperitoneal. Thank you.
Thank you, Dr. Puneet. Now, next speaker is Dr. Bhavin Shial, will be talking on management of high-grade listhesis.
Good morning, all. So I'm going to talk on something non-endoscopic. I think this is one of the few scenarios where endoscopy is still yet to get its mark. So there are many challenges in high-grade spondylolisthesis. So high-grade spondylolisthesis, when we say the slip is more than 3, so more than 50% of slip is occurring. So how many of you are operating high-grade spondylolisthesis in the audience? If any experiences with high-grade spondylolisthesis? Any comments or tips for how to do it? Auditors, anything? Any experience with high-grade spondylolisthesis? नहीं इसमें पेन ड्राइव Refresh here. इसको बोलो। देखना जरा That's fine. Finally. I think that's good. So high-grade spondylosis has this unique set of challenges because of the amount of slip, the risk of neurological damage, amount of reduction, how much to achieve are the one of few questions which has to be answered. So I'm trying to just throw a light on how to manage these difficult cases. And the world literature is still confused regarding what is the best mode of treatment.
केबल निकली
ये back to- उधर नहीं है ना? Yeah.
back करो
So imagine this 12-year-old female with progressive claudication, not able to walk and early bladder deficit. And you see this kind of an MRI and X-ray picture. If you notice, the L5 is almost slip. It's grade 4. It's all at the tip of the sacrum. The neural elements are severely compromised. The roots are getting crushed. So what do we do? So we are shell shocked regarding these kind of cases, and there are real challenges for the surgeon. So to decompress, how to decompress, which routes to tackle, do we need to do any kind of osteotomies? Do we want to reduce it completely? Or how many levels to fix? These are the some things which go through your mind when you encounter such kind of cases. And there's always been a controversy. Do we want to do an in situ fusion or you want to do a complete reduction? Closed postural reduction versus open reduction and instrumentation. Open surgery and now MIS surgery. So these are the things which we are looking at. So let's look at first in situ options and what the literature says about it. So in situ options are, you can do uninstrumented posterolateral fusion. It was done once upon a time. And the others are instrumented posterolateral fusion, anterior interbody fusions, transvertebral, transsacral strut grafting, and delta fixation. So one of the examples, if you see in this high grade, says only just uninstrumented posterolateral fusion was done. But there are high chances of pseudoarthrosis and failure and recurrence of the symptoms. And it has not been given up. But overall, a long-term follow-up of these pediatric orthopedic conditions, if you see just interlaminar fusion in these high-grade listhesis, what you see, the failure of arthrodesis, even though it's noticed, but the overall results does not change. So do we still do it? That's the question. Higher pseudoarthrosis rate, if we do just an instrumented posterolateral fusion, a long-term clinical and functional outcome of 21 years, which is a long duration. They have seen and studied this adult high-grade listhesis. They said standard uninstrumented posterolateral fusion has satisfactory long-term fusion rate, but good functional outcome is also there. So do we still want to reduce? Here another case where it has not been reduced. In 5-year post-op, patient is doing well. It's just an in situ instrumented fusion. And patient is doing well. So are we looking at to give complete reduction and cause more neurological? Just this is also okay. So 5-year follow-up, another case, 5-year follow-up. You see implants are broken up. The X-ray is looking bad because the screws are broken up. But good clinical reason, patient has no complaints, happy smiling coming to the clinic. Do you want to still revise this or do something else for these kind of cases? In situ sacral L5 fixation. What you do here, they put a screw in this high grade, this is a spondyloloptosis. So you put a screw through the sacrum into the L5 body and just decompress the neural elements. Because the main target, what we are doing is to get rid of the claudication and deficit of Claudia equina syndrome. So this is another way to approach these kind of scenarios. Transsacral screws for in situ fixation and fibular dual graft have also been attempted, but they have high pseudoassosis rate and implant failures. Delta fixation, another, the similar kind of a thing, you just stabilize in that position, don't want attempting any reduction. But again, these kind of patients also have known to cause a lot of pseudoarthrosis rates. But clinically, not much of a difference. And what exactly we do in reduction and what are the challenges we are facing? In this high-grade spondylolisthesis, where the L5 is almost at the tip of the sacrum or in front of the sacrum, when we try to reduce, there can be a iatrogenic L5 root injury which can cause a foot drop. This is the drastic, in a young patient, a foot drop can be devastating for the rest of the life. So to do it safely is another challenge. So basically in spondy reduction, we want to do a decompression posteriorly, put a posterior implants, put screws, your pedicle screws in the L5 and the S1, and slowly and gradually after preparing the disc space, want to get it in alignment, do the disc preparation and fusion. So this is the idea of doing this. So just another illustration of how we are trying to attempt this. So putting pedicle screws, preparing the disc space, put a bone graft or a spacer and just reduce it. But in this process, there should be no neural injury. So what does reduction of a high-grade slip actually achieve? It reduces the pseudoassosis rate, decrease rate of progression of deformity, better decompression, correction of sagittal alignment, and saves extra fusion levels. But what does the evidence-based medicine say? What about the in situ fusion versus reduction in high-grade slips? If you see, the conclusion is very variable. There are no clear-cut guidelines. They say the evidence is less and there can be a formulated literature which can be established to give a direction to how to treat these difficult challenges. Also, another 15-year follow-up of this severe spondylosis in adolescents with comparison of reduction versus in situ fusion. They said they have a good functional outcome, even in the fusion in situ group. Now we are still confused. What should we do? But people and surgeons like, we want to see, no, we want a good X-ray. We want a good realignment. We're still trying to get attempts to get it reduced completely. And with the advent of neuromonitoring, those chances of getting neural injuries have minimized. So another kind of gains he used to do in his early days, without doing much of a reduction producer, he tried to take off the vertebrae, L5 vertebrae in the front by doing a complete vertebrectomy. Becomes easier. He approached it anteriorly, do a complete vertebrectomy. And from posteriorly, he would put pedicle screws and get the alignment. But it has a lot of complications, neural and vascular, and it was a very radical invasive surgery. In 2014, a group evidence-based surgeon, they favor of 165 reduction as compared with 101 in situ fusions. But look at the level of evidence. It's just grade 3. It is not a strong evidence base. It's a retrospective analysis. And they say that reduction is much better than in situ fusions. And that's where more and more technical, let's reduce it completely. So this idea, okay, which ones to reduce, which one to do in situ fusions always stayed back. And younger surgeons who are coming into practice, they won't know how to tackle this challenge. So reduction of high-grade listhesis, as an orthopedic surgeon, we think lesser fusion levels, better decompression, better sagittal alignment, and also higher fusion rates. But spinal deformity group came up with a classification, okay, which differentiate between low-grade and high-grade listhesis depending on the pelvic incidence and all. And they gave us some clarity about who we need to reduce and who we can do in situ fusion. So they've classified into 6 groups. The type 1, 2, 3, where they have a low grade, less than 50% reduction, which we are not going to talk about today. We are going to focus on the type 4, 5, and 6. These two, they are differentiated into a balanced pelvis and an unbalanced pelvis, or we also call it as an retroverted pelvis. So type 5 and 6 are the retropelvis group where it is unbalanced, and they are recommending it to do a proper reduction. So sagittal balance parameters and their role in reduction in for high-grade spondy has to be looked after. So if you look at these 6 types which we have described, the last 2 types, type 5 and 6, are the ones which are unbalanced pelvis, where you can attempt reduction, and also you don't need to get a 100% reduction. You can just try to get it to a balanced pelvis to type 4. That is also okay. So we don't need to go hungo and trying to cause more damage by attempting a complete reduction. We can keep on assessing during the maneuvers and do what is best for the patient. So we have to have an understanding of a sacral slope, pelvic tilt. Depending upon those characters, we can decide our planning. So if you see in this image, the image on the right-hand side where the sacrum is anteverted, which is a normal position. In an unbalanced pelvis, the sacrum is vertical. So that's in type 5 and type 6. And the pelvic tilt also we should look after. So in a normal, the pelvis is anteverted. If it becomes retroverted, these are the signs which you should look for in an X-ray also. And we should get always a standing X-ray, preferably a scanogram in these kind of cases. So this concept of balanced pelvis and retroverted pelvis gives us an idea of which ones to go after reduction or what we can attempt to do an in situ fusion. So they have classified this high-grade spondyle depending on pelvic version and spine balance. And what they say, treatment strategies differ in these patients depending upon an unbalanced pelvis versus a balanced pelvis in this high-grade spondylolisthesis. So these spinopelvic parameters, once they are set a balanced and unbalanced pelvis, what they are suggesting is you should attempt reduction in this unbalanced pelvis only in their pelvis subgroup. So if you notice, type 5 and 6 are the only 2 ones which are remaining in the group of high-grade listhesis. So a rough algorithm would be in this high-grade grade 3, 4, and 5 spondylolisthesis. If it is a balanced pelvis, okay, and the sagittal balance is also balanced, we can try to go for an in situ fusion. But if pelvis is retroverted and the spinal balance is also, if either balanced or unbalanced, we can, if it is pelvic balance is retroverted and spine is balanced, we can do in situ. If pelvic balance is retroverted and unbalanced, we can have to do a mandatory reduction. So these are just suggestions. It is not a norm. But how many of these cases are really is unbalanced and how very much we really have to reduce these cases? They're hardly 13% of the total cases we see. So reduction for imbalanced pelvis and imbalanced spine, we should be attempting. This you can see a 4-year follow-up in an in situ fusion for a balanced patient with pelvis. The patient is doing well. So the take-home messages are, if you want to reduce or fuse, there is no level 1 or 2 evidence for these kind of challenging cases. There is no clinical significant difference between the clinical outcome of these treated with in situ versus reduction. Historically, there are many papers which say high-grade listhesis can be treated with just in situ posterolateral fusions with satisfactory results. And reduction of high-grade listhesis, which is a demanding surgical procedure with fairly high complication rate and advantages of which are still not evidence-based. Rather than doing harm to the patient, we can play safe. So partial or no reduction with correction of the lumbosacral kyphosis is a reasonable surgical option. We just want to get the pelvis into balance and the neural decompression should be achieved. Reduce those with retroverted pelvis and high pelvic incidence. Only 13% of the study of 214 high-grade spondylolisthesis have a retroverted pelvis. So to conclude, study the pelvic, sacral, and general sagittal alignment. choose your cases properly for reduction and in situ. If you do an in situ fusion for a retroverted, it's bound to fail. And if you can, and where you have a balanced pelvis, you can get away with an in situ fusion. So the norm is to reduce as best as possible with a wide decompression and see that the L5 root is properly decompressed. And so to minimize the pseudo-associates rate. Thank you.
Thank you, sir. We are running a little late, so we'll take
Okay.
question answer session
Thanks.
after. Now our next speaker is Dr. Rudolph Perez.
Thank you very much again for the invitation from the Trade Congress and Dr. Malcolm too. How are you? But what about night, no? Okay, I promise you that the topic is very friendly, is very, and then the other one. I need to talking about the biportal surgery versus monoportal surgery, myths and realities. What do you like to do in your spine? Left or right? Or depends on what is it really need, no? Science Campbell give us the K, everything change. And he say, never forget your bases, your columns, the balance about that. ABC. ABC is the safe for the patient. ABC is the safe for every step in the life. ABC is the K for the surgery spine. In the uniportal surgery, you have good things and bad things. That is my opinion. That is not an article. In the uniportal is one hole, is in reclined. The curve is less than the more simple for learn that, and is fast. But all the material are special. The material are expensive, limited the vision, and limit the move in the surgery. That is the normal material you need in the uniportal. It's expensive, is special, no have in all the hospitals. And the biportal is a little different. It's similar to the open surgery. The vision is more big than the general. It is necessarily expensive material because it's the same material for the open surgery. It's very cheap in comparison with the uniportal. The curve is more long, more invasive, use more water and more blood in the surgery. More blood, maybe 10 millimeter. That is the material you need in the biportal surgery. It's the same to the open surgery. Really not have other problem with that. The myth of this is the endoscopic surgery is only for people touch for God, because it's for all. No, the answer is no. It's for wherever to like to change the mind and the form to do that. You need special things? No. You only need your mind. You only need your hands. You only need gains for doing that. Need many special machine for will be expensive? No, it's the same machine you have in all the hospitals. You only need careful You only need gains. You only need change the mind and change the form to do it that. And difficult to do? Really no. You only need a curve. Be careful, be safety. Is the new to form to do? In my country, yes. Maybe in India is more common, is very normal. In America, no. In America is very different, is new, and yes, is a new form. And is the form. Everybody like to do this vision, to be stating and do that. Is very safety. You have the control in the vision. You have the control of the structure anatomic. You have everything. Is better than the microscope surgery, in my opinion, in a special thing for the hernia of the disc and descompression. In other type of the surgery, maybe in tumors, no, in the endoscopic surgery right now, no have a comparison with the microscope surgery, in my opinion. But depends of the side of you see that is the answer. For me, is the new form is the best form, because everybody like to work and do it that for the patients. When the patients are happy and you recover the form of the life of the patients, that feelings is a do it the life, is the do it your work is great, is the save the date. And when the people return to work and say, thank you very much, doctor, because I have a lot of pain before that, you really feel very good. That is the superheroes. The superhero is like you. Try to change the life of the people. Try to change the world. Thank you very much. I have a glad for a state here. Mexico is your house. Wherever you need in Mexico, you have a friend, you have a family, you have a house. Thank you very much.
Thank you so much. Thank you so much. Wonderful presentation. So with that, we conclude this session. And in the next session, I think before we start, we have a virtual talk from Japan, which is ready by Dr. Koichi Sairio. Can we play the virtual talk? Dr. Sairo, are you there? Dr. Sairo?
Yes, I'm here. Yes,
Yeah. So
Thank you.
we'll be playing your talk now.
You have my video already.
Yes.
Please
We'll
start.
be playing it in few moments. To moderate this session, now I call upon Dr. Varun and Dr. Ketan.
I think you have my video.
Yeah, we will be playing it in a moment.
Okay.
We're just loading up the talk.
Yes, this is my talk. Thank you. My name is Koichi Sairyo from Tokushima University, Tokushima, Japan. My talk is on fluoroscopic transcambient lumbar interbody fusion for spondylolisthesis. This is my COI. I call KRIF in this presentation. What is a KRIF? KRIF is transcambient lumbar interbody fusion. Under full endoscopic guidance, you see here, this is Cambius triangle. We insert a cage through this Cambius triangle. So I named it full endoscopic KRIF. Yeah, sometimes someone may confuse the difference between KRIF and TRIF. KRIF is insertion of the cage through here, Cambius triangle. However, the TRIF, we need a facetectomy. So KRIF corridor and TRIF corridor is totally different. And a couple of years ago, I invented a full endo KRIF system with surgical spa in Japan and Senko Medical Japan. For such 4 small skin incision, we inserted the pedicle screw and the cage is from here using the fluoroscope. First step is percutaneous pedicle screw insertion because most of my case is spondylolisthesis case. Using PPS, reduction is completed as much as possible. Most important part is foraminoplasty. With a foraminoplasty, we made enough space of safer cage insertion. I say 12 millimeter of the disc is safe. The one drill head is 3 millimeters, so I confirm 4 drill head diameter. And then next, through the fluoroscopic cannula, we insert this guide and spacer. The spacer is 8 millimeters and 10 millimeters. Using the spacer, finally, I insert the open cannula. Open cannula is just inside the disc. Of course, we are having a VLAN monitoring so that we can avoid the injury. Using this open cannula here, discectomy is very possible with accurate. Now, after we insert the open cannula, we can protect the thing here. So just cage is inserted like a sliding into the space. I can show you one example. 7 years ago, one this. However, in some condition, it is almost going to. Symptoms is just the medication within 100 meters. That rest, no symptoms. No weakness, no disturbances, just the medication. See here, this is narrow, a jaw, rhythmic dance coach. It's very difficult to stand and walk, so she was teaching the students with a city. So what's a plan? In Japan, live with EPS or mini is also popular. It also goes after that. I selected the fluoroscopic case of the compression because at least no signs, no symptoms. So we did we inserted the pedicle screw and 8 millimeter cannula, endoscope, and spacer, and inserted a cage. So here, this is before and after surgery. Totally broke of the myelography during surgery, but after surgery, it goes to the other side. Cage is there. See here, spondylolisthesis is almost fused completely. So there is no symptom at rest, so I recommend fluoroscopic K without decompression because K has a great power for anatomical reduction. This is MRI before and after surgery. Here, spondylolisthesis is reduced in anatomical position, and the canal is also cut bigger. After surgery, no more symptoms anymore. She returned to as a teacher. This is a final case of 61 years old female. See here, she's grade 1 spondylolisthesis. See here, narrow canal. The narrow canal. Her symptom was also intermittent claudication within 100 meters, but at rest, nothing. So at rest, no symptom, but spondylolisthesis, narrow canals, also ossification of ligament flavon there. What's the plan? You need a removal of this ossification for decompression, like a direct decompression. I don't think so because at rest, no symptoms. So for her as well, I did fluoroscopic transcumbent lumbar interbody fusion. I said K-leaf without decompression. Here, the slippage is mostly reduced in anatomical position. See here, ossification is still here and here, but neural canal is decompressed. So no more symptom, no more intermittent claudication anymore. I started the K-leaf surgery in 2018, and totally I performed for 46 cases for fluoroscopic K-leaf. And earlier 13 cases, I used Professor Nagahama's PET system. And after that, I invented my system. And so totally 46 cases. The clinical outcome is basically okay. However, I had encounter for editing nerve root irritation. So 8.7% show some numbness and a little bit weakness. But it improved within 3 months. Regarding slippage, so you see here, grade 1 and grade 2 slippage is almost improved to about 3%. As you know, TPS with cage reduction, so both two combination for reduction, so K has a great power for the reduction. This is a merit for fluoroscopic K-leaf. Number one, it is minimally invasive fusion surgeries. Skin incision requires for just 12 meters for cage insertion. Minimal blood loss, less damage for back muscle. And unlike X-leaf and O-leaf, there is no major vessels, no ureter, no colon, so no major complication in our series, just edictive nerve root irritation. How about the comparison with P-leaf and T-leaf? We don't need laminectomy or prostatectomy for cage insertion. So no worry about dural tear and neural injury as well as hematoma. And my team performed over 200 K-leaf, but no infection. So it is very important. No infection in the K-leaf surgery so far. And thank you very much for your attention. I presented fluoroscopic K-leaf surgery for the sepsis case. I made Japan K-leaf Society. If you're interested, please attend Japan K-leaf Society. See you soon. Bye-bye.
Thank you, Dr. Sairo, for such a nice presentation. What are you using for graft material? The voice is not there. Can you bring up the voice? Just a minute, sir. We are just having some technical issue. We are just trying to get the voice back. Can we have the sound, please? Meanwhile, anybody has any question, you can tell us. We'll put it up. Dr. Ajay, please.
Oh, thank you. Yeah. First question is grafted material. There are two. In some university hospital, we can use allogenic graft. But in a small hospital, I use autologous graft from a pelvis, iliac crest, and also artificial bone.
And what is the time required for the surgery?
What is
the total duration for the surgery?
Duration? I mean, 2 hours.
2 hours. And you are using the regular T-lift cages or some specially designed cages for this?
Yeah, this is a traditional T-lift or pull-lift cages, just box type or gauge-up system. Today's talk is I use expandable cage.
Right, sir. So expandable cages are actually going to revolutionize this kind of a procedure. Any other questions from the audience? So we'll move ahead with the next talk.
Okay, thank you so much.
So thank you, sir.
Thank you
for sparing time and all the way from Japan. We'll take the next talk now.
Okay, thank you.
So we'll be starting with session 4. Do we have Dr. Nantavat Uttamu? Yeah. So his talk is, he's from Thailand, and his talk is the role of UBE in surgical management of degenerative lumbar scoliosis.
Okay, good morning, everybody, and thank you for having me. I'm Dr. Nantavat Uttamo from Veteran General Hospital, Bangkok, Thailand. Today, I would like to present about the role of UBE in surgical management of degenerative lumbar scoliosis. And there are two primary types of adult scoliosis. The first is adult idiopathic scoliosis. That is a continuation of a disease from a childhood and not progressing until you reach adulthood. And it can affect both thoracic and the lumbar spine. For adult degenerative scoliosis, it develops during adulthood and is caused by degeneration of spinal structures. In this form, aging of disc and joints in spine occur asymmetrically and causing a tilting and slipping between the vertebra, and then abnormal curvature of a spine can develop. And this form affect the mostly of lumbar spine. And patient could present with many symptoms such as leg pain or claudication, due to neural compression, back pain from facet arthritis, or instability, or progression of a deformity and imbalance. And there may just one or more symptoms. So listening to the patients will lead to a better plan of surgical treatment. According to the complexity of adult degenerative scoliosis, many classifications were developed to achieve the goal of the treatment. The AB classification is unique, helpful in understanding the natural history of adult deformity due to its etiology foundation. And however, it lacks guiding surgical treatment of ASD. And Lenke-Silva classification describes a 6 level of operative treatment that depends on patient symptoms and radiograph. And SRS Schwab's classification establishing criteria of severity of a curve by including the coronal curve type and spinal pelvic parameter. For Berhano and Lamartina classification system focus on degenerative segment disease in adult with deformity affecting the lumbar and the thoracolumbar spine by identify the candidate for selective fusion of the one area of the curve or to assist the surgeon with the surgical planning. For MAS spine surgery, the MAS-DF2 algorithms was developed by Dr. Mumanei, and the branch points of algorithm are based on the flexibility of the curve and preoperative spinal pelvic parameters. However, this algorithm does not take into account the patient health status or the age-adjust alignment goal. Nowadays, several UBE techniques have been developed and applied to many spinal conditions, such as interlaminar and a translaminar approach for the intracanal lesion, and contralateral approach or paraspinal or transforaminal approach is for the foraminal and extraforaminal lesions. And several studies such as of Professor Hayati show that UBE decompression or discectomy give more benefit compared to conventional surgery and other MAS surgery. In case of spinal instability, the endoscopic fusion can be done by U-lift technique. It provides good the end plate preparation as shown in this video. You can see that clear end plate preparation, and it allows a convenient interbody cage insertion. And you can see that we can observe the cage and the neural element during we insert the cage. And many studies comparing between U-lift and the conventional interbody fusion, such as a study from Dr. Manku Park and Professor Son Sanku show that the U-lift is less invasive and can improve both back and leg pain and has a lower complication rate. And by the way, the U-lift case has a small case footprint and is limited use of lordosis correction. So Professor He Donghua and Professor Jinhua has developed a new UBE fusion technique for a large case insertion as an O-lift or the egg-lift case that can provide a large footprint and create lumbar lordosis. So you can see that UBE has many advantages and can apply to many spinal conditions. But how about in spinal deformity? And according to the MAS DF2 classification, the class 1 approach is reserved for my case in which the main pathology is radiculopathy and without back pain. So UBE surgery has a role in decompression alone. For example, in this case, the 68-year-old female present with a severe right leg pain and have lumbar spinal stenosis and right foraminal stenosis at the L4-5 level. So the left side contralateral approach was chosen. And you can see from the video that we decompress foramen and do the discectomy. And we use this approach because to preserve the stability and in concave side. And for multi-level stenosis, Dr. Wenlong Wang has reported a 5-level bilateral decompression with the 2 stages of a UBE. And in case with a present with leg pain and spondylolisthesis, selective fusion with the ULIF could be done, like in this case, as shown in the presentation. And the class 2 approach addresses patients who suffer from stenosis or radiculopathy, as well as deformity-induced back pain. So the symptoms occur over main curve. And the surgical treatment include a multi-level ULIF or the XT-LIF or hybrid surgery combining UBE and L-LIF as a report from Professor He Donghua. And the fusion should include all main curve and extend to the L5S1. For class 3 and 4 approaches are used in complex or the severe deformity that require open surgery. So UBE in these 2 groups could be challenging. There are many things to concern, such as long operative time, fluid-related complication, correction of the deformity, and intraoperative blood loss. But however, UBE decompression and ULIF may be used as an adjunct to a multi-level L-LIF or MAS posterior approach for ASD. In conclusion, UBE decompression alone or the ULIF proper for the MASDF2 class 1 and 2, and still challenge in the case of a severe fixed deformity and a significant spinal imbalance. So please respect the patient body, age, bone quality, and comorbidities. And the most important thing is listen to the patient problem and treat the patient, not the X-ray. Thank you.
Thank you, Dr. Tamo, for such a nice talk. Any questions?
Okay. Thank you so much.
Next, I invite Dr. Anand Kavi for his talk on PELD for foraminal and lateral stenosis.
Good morning. I hope everybody's awake now. So I'll be speaking on use of transforaminal percutaneous lumbar endoscopy under local anesthesia for foraminal and lateral recess stenosis. This is a slightly thought-provoking presentation. We all know that the stenosis pathology, it starts with internal disc disruption. Then it proceeds to annular tear, herniation, disc height collapse, buckling of the ligaments, facet arthrosis, narrowing of the foramen, microinstability, and then soft tissue hypertrophy and calcification. But the main determinant, which is annular tear, so everything starts at and inside the disc. Conventional classification for stenosis according to the zone is the central zone, subarticular, foraminal, and extraforaminal zone. There are 2 types. One is the congenital stenosis, which has the short pedicles and patients like achondroplasia, but we're not talking about them here. What we are talking about is patients of degenerative stenosis. So traditional surgery for degenerative stenosis involves interlaminar approach with laminotomy, laminectomy, facetectomy, and excision of the ligament flavum. So is this a real culprit? So with the newer concepts, now we know, now these are the coronal sections of the ligament flavum we are seeing from the ventral aspect. So there is lateral extension of ligament flavum inside the foramen, and which goes on to continue as an intertransverse membrane. And this piece of tissue is actually the main culprit and not the central ligamentum flavum. If you see the practical MRI grading for the stenosis, the exiting root is compressed by all four sides, out of which the two sides are bony and other two sides are mobile, that is the disc and the tissues around the superior articular process. Claudication, as we all know, and the radicular symptoms, they can be unilateral or bilateral. Now, whenever we come across bilateral claudication, it can be due to bilateral foraminal stenosis and not always due to central stenosis. So in case of bilateral stenosis, does the symptom start on the same day? This is what you need to ask your patient. And you will find out that commonly it starts differentially. So those patients who have bilateral symptoms starting together may have a congenital narrow canal with disc herniation and not flavum hypertrophy always. Another thing to note that radicular pain and symptoms are due to the compromise at the dorsal root ganglion and not the pathology posterior to the dural sac. Also, most common clinical patients what we see have the symptoms around L4 and L5 dorsal root ganglion, and this dorsal root ganglion lies inside the foramen. So lateral encroachment of ligament flavum to the neural foramen gradually increases from upper lumbar to lower lumbar levels. And actually, this is the main culprit. Now, with the advancing age, there is no change in the dimensions of the bony boundaries of the foramen because after skeletal maturity, the bony boundaries are constant. What actually changes is the disc height. It reduces due to the collapse and it herniates out. And what happens is the tip of the SAP, it high rides into the superior foramen and the tissues around the SAP tip hypertrophies and makes the area more narrow, hard, and unyielding. Now the exiting root is very tightly held in position with foraminal ligaments, which do not allow it to move. And with foraminal compromise, there is increased vascular congestion, venous congestion to be particular. And this is also the main contributory factor in claudication symptoms. So conventional treatment of foraminal decompression and detachment of lateral border of ligament flavum is very difficult if you come from the interlaminar approach. Because if you calculate the distance from the medial pedicle to the lateral border of flavum, it grows on increasing from 6.51 to nearly 12 millimeters. So that much decompression is needed if you come from behind. So resecting all that flavum located at neural foramen, especially at lower lumbar levels, is challenging. And access to the lateral attachment of ligament flavum at lower lumbar levels requires more resection of lamina and pars in the traditional approach. And that is one of the major reasons for these patients undergoing fusion. Now, can this be approached easily by transforaminal approach? Yes, you can. Endoscopic approach around the superior articular process is very easy. Removal of the lateral aspect of the flavum and the junctional tissue, it gives excellent clinical results and excellent relief to your patients. Now, this is a landmark line which passing through the inferior end plate of the upper vertebra, which is just touching to the SAP. In case of collapse and degeneration, the SAP tip will be cranial to this line and pushing into the root. Now, this is another good paper by Saeed Usman and his colleagues, where they have seen that through transforaminal area, we can have a better foraminal decompression rather than the interlaminar approach. So this is an endoscopic view. This is how we look at the foramen between the axilla of the exiting and the traversing root. And we just do undercutting and deroofing of the superior articular process and tissues around it. And that's all. The equipment required is very less: a simple hook, a curette, an endoscopic punch, burr and an up-biting forceps. So these are some of the videos. So this is a case showing anterior down migrated disc herniation as well as foraminal compromise. So what we can do is with a simple burr, we undercut the SAP, and then there lies the lateral expanse of the ligament flavum. So very slowly we separate it from the dural tube and the traversing root. And we can piecemeal remove the flavum with an endoscopic punch. So once you remove that part of the flavum, you can actually see the lateral border of the dural tube and the traversing root. You can very well go beyond the end plate and the vertebral body to reach that down migrated fragment. And that is the final picture, the complete lateral recess released. This is another case of foraminal stenosis where you can see that the tissues around the SAP tip are hardened and there is an osteophyte there. So again, we just do a undercutting. This is a 3 mm burr, so we do not cut more than 3 mm of that bone there. So once we do that, we reach for that flavum and the lateral expanse of flavum is cleared. And then you can see that osteophyte coming from the vertebral body. So you can chisel that bone, morselize it, and voila, that's the free dural tube. That's the axilla of the exiting root. That's the post-operative picture. The foramen nicely recreated. The osteophyte gone, and a happy patient and happy surgeon. You have to be aware about the radicular artery which lies just cranial to the ventral root, and always be very careful and avoid to manipulate in that area, or else you can have catastrophic bleeding. Another case of foraminoplasty. So again, slow undercutting of the bone there. Endoscopic punch. Remove that part of the flavum. Use radio frequency in the axilla, and that is the free exiting root. Turn the cannula and you will see the traversing root and the lateral dural tube. So this gives wonderful decompression and another happy patient. Last case, this was a 65-year-old lady, already underwent a fusion. She had multiple comorbidities. You name it and she had it. So she was a very difficult case, already hardware in place. This was her MRI. So this is how we put the endoscope in L5-S1, and also we put endoscope in L4-L5 to remove that part of the disc material which was pushed by the cage and causing symptoms. So another video, very similar. remove the soft tissue, do the undercutting of the facet. And that is the free L5 root. This case was done without any sedation, only under local anesthesia. And this is the free S1 root and the dural sac. Complications, yes, sometimes I've encountered dysesthesia because I'm working in the foramen and I work around the dorsal root ganglion, but it is short-lived and it is very well controlled, especially with one of the drugs called as nefopam. It gives wonderful results. Yes, dural injury can occur, but usually it is inconsequential. It is a very small dural tear, and just by packing and removing your instruments, you can get scot-free. Bleeding, as I've already said, you have to be very careful when you are in the upper part of the foramen. Otherwise, you can have that catastrophic complication. So friends, this is me with my beautiful wife enjoying a holiday and completely stress-free because of the transforaminal surgery under local anesthesia. So next time, please do give it a thought. So every time you do not require to operate from the interlaminar approach and remove that ligament flavum in its entirety, please look at the foramens. Maybe the culprit is there. Thank you very much.
Thank you, sir, for such a nice talk. So when we operate and try to remove the SAP, the capsule around it bleeds sometimes, and that's very irritating. So what is the tips for that?
So
not the radicular artery bleed, the capsule. Which
yes, I understand. So there are two tricks to control. Of course, radio frequency is one of that. And another thing is you can use some instrument like a straight curette or a dissector and just try to puncture that hole and keep it as a tamponade. So the bleeding stops. Or otherwise you can just remove your dilator and cannula and wait for a moment, and then the bleeding gets coagulated, it stops, and then you can redo the case. It has never happened that you have to abandon the case because of that bleeding. But radicular artery, yes, that can be a serious problem.
Right, sir. Any other questions?
When you start your burring, you started from the base of SAP, like we dock at the base of the Camden's triangle. From there you start, or you start from the more of the cranial part, the tip of SAP?
Yes. So in the initial cases, when I was inexperienced, I always docked my endoscope at the base of the SAP near the lower pedicle, and slowly I ride along the bone and then try to reach the tip of the superior articular process and then start using the burr. But slowly with experience, and once your vision develops, it is the same case. It is like, you know, working in a factory, like some product comes, you are packing it and sending it ahead. So it is a no-brainer. When you enter, what you see up is the bone. Just look at the tip of the superior articular process, try to identify the facet capsule there, and then you can use the burr very safely.
Any problems you encountered when it was a vertically oriented facet and a transversely lying?
Never actually. So you can always use your burr, just a 3 mm undercutting of that area, and you will directly reach upon the lateral expanse of ligamentum flavum. So yes, I have been through all those articles. They are wonderful, no doubt. But to be honest, for transforaminal approach, I think it is inconsequential.
And your lateral to medial amount of bone cutting, do you take CM's help, or is it just the medial border? You see the flava and you're through?
Yeah, initially I used CM, and I saw to it that I do not cross the medial pedicular line just to be safe. But later on, because it is under vision and endoscope has a beautiful resolution, so it can show you all the tissues and you can identify very well when you come across the lateral reach of the flavum, and it protects the dural tube. It is not possible directly to push inside the canal with that slow burr.
No, because the last case you showed, it was already a T-lip done.
Yes.
So in that case, when the midline structures are not there.
Yes. So that was a difficult case. That was not an easy case. and I would not advise anybody to start with that case. So, but there was no other alternative. She was a friend of another spine surgeon's mother. So I had to do it. And fortunately, I had a wonderful result.
Thank you, sir. Even I do agree that burring from the tip of the SAP actually helps save a lot of bone rather than coming from the base. You end up resecting more.
In fact, I have published one article on foraminoplasty where I've been using different modalities, right from directly using trifines under CM. But nowadays, I'm not really advocating that. Best way is to put the endoscope and go under vision. Okay, thank you very much.
Thanks a lot, sir.
Yeah.
May I invite Dr. Andrew for his talk?
Andrea Sinagra
Sorry,
from
Dr.
Argentina
Andrea.
for her talk on endoscopic treatment of failed back syndrome through the transsacral approach, which would be something new for all of us. We are very keen to hear how her techniques tackle all this.
Do you want to take this? I put it. Okay. Okay. Good morning to you all. I see you have survived last night. I want to thank again Dr. Pestonji for his kindness and his generosity. We are very glad to be here. I have some photographs of Argentina. I hope you can go there one day to visit us. I will talk about the endoscopic treatment of failed back syndrome through transsacral approach. We all know what failed back syndrome is, the patient what nobody wants. That comes with persistent lumbar pain, isolated or combined with radicular or referred pain after a surgical procedure. It comes once and again. We have a problem in Argentina, that is that orthopedists don't perform an endoscopy and don't believe in endoscopy. So when the patient goes to them, they say, no, endoscopy doesn't exist. It is useless. So they perform, especially arthrodesis, and after 1, 2, 3 procedures, the patient goes back with pain, with the same pain, worse pain, or as they say, I have traded one pain for another pain. And so they say, okay, you have to look for an endoscopist. And then they come to us and we try to do. I always tell them that they came 3 surgeries later because endoscopy should be the first procedure. But then we try to do what is something good for them. And I think epidural is a good treatment of fibrosis, and we can provide them some relief. Here you can see some endoscopic photographs of fibrosis, which is one of the main reasons of failed back syndrome. I will show you that there are different grades of fibrosis, and these grades have been determined by the epiduroscopy. Here you can see some of them. I will show you them more of pictures. Transsacral epiduroscopy is a safe procedure, minimal invasive, which allows visualization, diagnosis, and especially treatment of fibrosis. Visualization is important because there are papers that state that fibrosis exists even though we don't see it in MRI. So that happens when we perform endoscopy. We can see fibrosis that wasn't seen on MRI. It should be previous to neurostimulation because it's less expensive, it's easier, so we should try it before neurostimulation. Epiduroscopy allows lysis of adhesions and fibrosis in mechanical ways I will show you, with the use of lasers and radiofrequency too. Here we can see a typical image of fibrosis in MRI, where you can see the nerve root embedded in a tissue that we will see in epiduroscopy now. The severity of epidural fibrosis was determined by epiduroscopy. There's a nice work of Hussain, which shows 4 grades of fibrosis. Grade 1, we find loose fibers and layers of fibrosis, but it's a very easy patient to perform. You can see on the right, there are a few loose fibers. This is grade 1. Grade 2, the fibers and layers are organized. I show organized fibrosis with no resistance to epiduroscope. We can enter easily. You can see the difference between grades, the first grades and the last grades, because it's more red, it's more reddish. There's more inflammation and more congestion. Sorry. So these are the usually stage 1 and stage 2. In grade 3, we have dense and continuous fibrosis, which still allow the advance of the epiduroscope. Here you can see a Fogarty balloon we are opening. Dense adhesions. Why are dense? You can see they are very white and have no vessels. This is grade 3, which can still work easily. And grade 4, which is most severe, where we see dense and fibrotic material, which precludes the advancing of the epiduroscope. Here I will show you, we usually use a laser to open a small hole in adhesions and then enter with Fogarty, with grasping tools, with any tool to reach the root. Ross described in neurosurgery, there was a very important article, which described that patients with more extensive caring were 3.2 times more likely to develop recurrent radicular pain after discectomy. This was attributable to nerve compression, restriction of nerve movement through the nerve sleeves, and decreased flexibility of nerves due to tethering. I will show you this in endoscopy. I've already talked about the materials in introductor and endoscope, laser fiber, Fogarty balloon, saline solution, and medication. We have used many types of endoscopes throughout these years, all flexible endoscopes with integrating fiber optical illumination. The technique, I have talked about the technique already, puncture of the sacral hiatus, dilation, introduction of the epiduroscope. Then we do adhesiolysis and we leave medication. We can see here the OR setting. You have already seen how we enter the endoscope. That is a dolphin which we use sometimes, which is directly connected to the computer. So we take the images, go directly to the computer. This is another image. We have a light fiber, very thin light fiber there in the left, with the patient in a prone position, of course. We talked about irrigation. There's no need to irrigate too much with saline, such a low volume of irrigation, because it may provoke pain if we do it, and also raise ICP. So the fluid constantly enters and goes out, so not to raise ICP. We have seen how we enter the catheter to the disc, and especially that we can move the catheter in any direction that we want. We also saw this, the sacral approach, how the catheter is shown in the ventral space. We can go to the ventral or the dorsal aspect of the sac. Here we have some images I will show you. Now how we are entering the canal. We have already opened a hole over there. So you can see very dense adhesions, very white and dense adhesions, so you cannot see the root. we start working. You can see how the bubbles start going in, and that confirms that we are in the epidural space. There's no chance of being in another place because of low negative pressure. So we start working like that. There are different images there, a bulging disc, because you can find things that are the cause of failed back syndrome. Although you are not looking for that, we can find some disc materials, remnant disc materials. Here you can see how we are using a Fogarty balloon to open a hole in fibrosis, but then we can use also a grasping tool to get fibrosis out. Here you see another Fogarty balloon working to open adhesions. I will show you how the lumbar root is freed. Thank you. Here's you can already see the lumbar root. Again, we are inflating the Fogarty. Dense adhesions, you really see no vessels. Use one more. Here's the inflation of the balloon to open the space. Then can you also use a laser? You will see how it opens a hole. It works easily on fat tissue, obviously. It takes some time to open a hole in adhesions. This laser works in the point, so it's quite safe. It's very difficult that that heat can harm the root. Here you see some fatty tissue already, which is a good sign. It significates that we are releasing the root correctly. Has the laser working again? You can see there are no vessels. This is a grade 3 fibrosis. You can see the root and the fatty tissue around already. It's a great difference from the canal at the beginning. Here you can see the root, the space. In the video, you see how the dural sac is pulsing. So it's a good liberation of the root. You can see quite well on that root. This was a patient of 29 years old which had had arthrodesis 5 years before with a great infection, and he came with fibrosis. He had started with pain, with the same radicular pain 3 months after the surgery. So here you can see LFS1 exiting the foramen. Here you can see how we use the laser to cauterize vessels too, if there's any hemorrhage. The same as here. You can see great congestion of an epidural in this case. We also work with a laser. Usually a epiduroscopy takes around 60 minutes, no more, 45, 60 minutes, depending on the case, the severity of the case. Which is a rationale for success, which is the question Here, well, this is a finished case. We can see the root already over the areolar tissue, fatty tissue, only light adhesions. One of the reasons of success is electrolysis, because of what we said, because it tractions the root. It allows no movement to the root. When we liberate adhesions, the root can regain its irrigation. There is also the theory that epidural works because it washes inflammatory mediators with saline. And of course, because we administrate epidural medications after we finish the procedure. What would we use? We use hyaluronides, betamethasone, bupivacaine, the three of them together. There are other medications, but we usually use these. Here you can see the OR. The procedure is obviously made in OR with local anesthesia and sedation. On ambulatory basis, the patient lives around 2 hours after the procedure. You can see the setting here, our beautiful L5S1 root. There are very few complications related to epiduroscopy. This is why we laugh and say that no one should be denied epiduroscopy, because it's a very safe procedure. We can sometimes see headache. We never saw retinal hemorrhage or intracellular hemorrhage, although they are described, it's very rarely seen. If you just watch the volume of saline infusion, that never happens. Paresthesias, can happen when there is a spinal stenosis. Sometimes we see that they have 1 or 2 days of paresthesias in legs. And pain at site of entry, I say this is the most common encounter, pain in hiatus, sacral hiatus. The results, in immediate postoperatively, 95% of patients achieve alleviation. We usually say that it's simply because of bupivacaine, and then we see what happens. 6 months later, 85 patients refer 5 points average reduction in visual analog scale. At 12 months, 72% of patients sustained significant reduction in pain. At 2 years, 15% of patients require another procedure. We always tell that to the patients in minimally invasive, that maybe only one procedure is not enough and they should have a second procedure soon, so they know it from the beginning. So as a conclusion, epiduroscopy is a safe and valid alternative to treat failed back syndrome, serving as both diagnostic and therapeutic tool. This is our team. Here we are. Thank you very much. We had a great time here. We have learned a lot, and we had a really good time. So I hope we see you all soon.
Thank you for a wonderful presentation. And I think you should show this presentation to your orthopedic colleagues back home so that they will start referring patients to you.
It's a great fight, because when the patients, the thing for minimal invasive is that patients are looking for minimal invasive. Patients don't want long surgeries, don't want arthrodesis. You sometimes need it, of course, but not as a first treatment. So they come for looking for minimal invasive. And they usually tell them, we don't know what they do. So as if it was something witches. So, well,
So Dr.
I know.
Are you using the sacral approach always?
No, we started using always sacral approach until we started doing transforaminal and other approaches, but we still use it a lot. For example, when we have migrated discs, we sometimes use transforaminal and complete with a transsacral approach. So why do we do that? Simply because it can be done with sedation and the patient goes home. So it's easier.
And are you doing these procedures for cervical and thoracic regions also?
Yes, I have had to say that with these epiduroscopes, you can reach the thoracic region by the sacral approach because they are very long. If not, you can enter interlaminar with the epiduroscope too. So it's a possibility in every region. Yes.
Thank you, Dr. Andrea, for changing our perspectives toward minimally
you.
invasive. Any more questions? I see Dr. Sigdem wants to ask a question.
Check.
Can we have the mic, please, in the audience?
Thank you. So nice presentation.
Thank
you. Just I want to say something. I used to do this technique is 5 years ago, transsacral, and I had I had complications for two patients, urinary incontinence and bowel incontinence. Then maybe if some colleagues want to try this technique, just they can careful like this complication.
Yes, of course.
Because it happens.
Yes. I think we are on endoscopists. I said in the first lecture that I think everyone that is trying to start with endoscopy should start with epidural. But to all of you that are master endoscopists, this is a very simple technique.
Yeah.
Of course, when you start doing endoscopy, you don't understand where you are. So of course, it's not easy for anyone, but this has a less steep learning curve than transforaminal or translaminar, which I think are quite more difficult to learn. So we did the other way. We started with this. So when we understood where we were, we hit it to transforaminal and to translaminar. So this was very simple in comparison to the others.
One more question. Sometimes transsacral hiatus is not open congenitally.
Yes, it's calcified.
What do you do? That
Sometimes it is calcified, so we have to do some work to enter it. If not, we can enter one level superior to it. We usually do that too, especially in ancient people that have calcified hiatus.
Yeah, right.
Thank you very much for sharing us your nice experience. My question is, how can you sure that is your catheter on anterior or posterior compartment?
You can do it with radioscopy. I have shown only a small picture of radioscopy, but we can assure we are there with radioscopy if we want.
Okay.
But you really know when you're doing it that you are in ventral epidural space. It's very anatomical epiduroscopy, so it's not the same as transforaminal, where you really need to find the root and to find where you are situated. This is a very anatomical procedure, so it's very difficult that you don't know where you are.
And for cervical, it is easy to go to anterior epidural compartment?
Yes. You have to be very careful, of course, but it is. Yes.
Well, thank you. Now we are oriented about epiduroscopy. Before that, we are puzzled.
Thank you.
Since we are running short of time.
Just one.
Yeah, meanwhile, I'll invite Dr. Ketan to set up his laptop. You can go ahead with the question. He's just setting up his laptop. Yeah.
Just I wonder how can you do cervical enter?
How do we enter
Yes,
cervical
yes,
arthroscopy?
yes.
My colleague gave that lecture. We enter under C7. We puncture with the trocar, and then we advance with the epidural curve.
Yeah. Okay.
You can't be afraid to do that.
One last question. Any fellowship opportunities for training with you?
You can come whenever you want. We were very pleased to show you
so much.
what we do. Thank you.
I'm coming if anybody else is not coming, but.
So we need to flash her
So I have a
email.
company.
Argentina is beautiful. It's very chaotic, but it's beautiful. You can
Andrea, you are also very beautiful. We got double reason to come there.
So now I have company.
We need to charter a flight next time to Argentina. take the entire.
Yeah, he can
thing
sponsor
there.
us also. So,
Dr. Ketan?
yeah.
Who, Anand or you?
After that, you can go to Antarctica.
So my next topic is UB TILIF, and we'll be just going through the basics of it. So just like we talked yesterday, it is basically endoscopic assisted interbody fusion. It is more closer to PLIF than TLIF, or as Dr. Sun likes to call it as ULIF, UB assisted lumbar interbody fusion. We talked about this yesterday. The difference is the medium of the material. It's not an air medium surgery, but a water medium surgery, because we are doing it under continuous fluid irrigation. The procedure is simple. We do start with the skin marking, working in scopic portals, strangulation, decompression, and we end with minimal invasive percutaneous pedicular screw fixation. So that's the major difference when we are talking about UB. There are two ports, and it's a percutaneous procedure. The scope is going in directly through the scope, through the skin, and there's a separate channel that is also percutaneous, and they're meeting at a common point or triangulating over the interlamina space, and that's the flow of irrigation. So it is attached to the outer port of the scope. The fluid goes inside, it accumulates. It just doesn't come out. It accumulates, creates some pressure over the interlamina space, and then it flows out through the second channel. And that is how the irrigation outflow needs to be before you start this particular procedure. So we'll just directly dig into the procedure. These are the three skin markings that I start with before I start my TLIF procedure. So the first line is the midline, the second line is the medial pedicular line, and the third line is the midpoint of the transverse processes. So when you actually take this incision, this is the midline, that is the tip of the spinous processes. That's median pedicular line. As you can see, the midline is straight, but the median pedicular line will be obviously slightly tilted towards the midline, as the pedicles are closer in the upper lumbar level and they go on laterally in the lower lumbar levels. And this is the midpoint of the transverse processes. So my incisions, usually they start from the just medial to the second line, and then they extend over the second line towards this third line. Initially the incisions are smaller. When we are doing decompression and at the time of cage insertion, I increase the size of the incision, and similarly for pedicular screw, depending on what size of screw and rod I'm using, and I go on increasing the size of the incision. So this is a video. It's L5 sacralized, so last level, mobile level, which is lytic listhesis, and patients having typical claudication symptoms, standing intolerance, and radicular symptoms. Here, the major difference is we use very less of a burr, because we want to harvest as much as bone graft as possible from the facet and the lamina and the base of the spinous process. So we use more of Garrison punches, more of osteotomes and chisels to take out as much as bone graft as possible. So we, even though the incisions are slightly lateral as compared to a normal decompression or discectomy, the meeting point remains the same. We dock at the medial most point of the lamina, the junction of spinous process with that of the lamina. We start by removing the lamina, then slowly moving laterally, erasing the capsule of the facet joint with the help of a radiofrequency probe. And once you expose the IAP, inferior articular process, you start osteotomizing it. I have made the mistake of osteotomizing it in a single piece and then struggling to get a big chunk of bone out. So now what I do is I take smaller bits and pieces so that it's very easy to retrieve the bone graft also. After removing the SAP and after removing the IAP and some medial portion of SAP, you can see the traversing nerve root there. Then you retract the traversing nerve root, you cut the annulus. So the site of annulotomy is also very important. So it is in line with the lower pedicle, medial margin of the lower pedicle. So you cut your annulus from that point onwards laterally, so that you get an inclination so that the cage is placed right in the center. And the rest of the procedure is similar to as you would do in open surgery or MIS TLIF. You go on sequentially dilating the using the rimmers and widening the disc space You go on removing the end plate cartilage and disc material, creating the space as you would do. A couple of CM shoots in between just to confirm where your position is and you're not going or damaging the end plate there. The rest of the thing is under direct visualization. This is a great advantage wherein you can actually go in and see what you're doing and go inside. The scope can go inside and visualize the denuding of the end plates, the cartilage is removed or not, how much of cartilage is still remaining inside. So this is the scope that is going inside and actually seeing the lower end plate. If you are using an angled scope, you can rotate the angle and then visualize the superior end plate as well. This is the peak cage with the bone graft coming inside. Initially, we stuff some bone graft anteriorly also. So the traversing nerve root has been retracted by an assistant and the cage goes in. This is under direct visualization on a CM lateral view and the cage goes inside. You confirm the position. If you want, you can still rotate it later on and make sure that the cage is centrally placed slightly horizontal in both AP and lateral views. And this is followed by percutaneous pedicular fixation. So that's the end point of the surgery. You can see the traversing nerve root, the axilla, as well as the shoulder region and the cage lying anterior to it. You put in percutaneous pedicular screws and this is the final picture. This is the preoperative and postoperative MRI of TILIF. And the major thing, in addition to the amount of decompression that you have achieved, is the posterior musculature there. You can see the postoperative, in the postoperative MRI, you can see the amount of muscle damage that is there, which is very less. If you see an open surgery postoperative MRI, the amount of paraspinal musculature that is damaged, you'll see a lot of white shadows there. But here it looks quite symmetrical to the non-operated side. So that is a big advantage. This is a case of revision TILIF wherein previously there was laminectomy and intertransverse grafting was attempted, but the patient still had a left-sided facetal hypertrophy with left-sided radicular pain only when she was standing and walking. So she still had a flexion extension view, she had dynamic instability. So this is the normal triangulation. But when you have a case of revision, just like we would do in an open surgery when we are trying to attempt a revision, the docking points would change to the nearest bony landmark that you have. So instead of docking at the laminofacetal junction, here, when it's a revision case, the laminectomy already has been done. You dock at the facet joint directly. And this is the docking. You do the serial dilation and some amount of work creation. You do triangulation directly over the facet joint. And you rest of the things you do under vision. The most of the rest of the procedure would remain the same, except for the medial part where there will be a lot of scar tissue. So you go on directly exposing the tip of inferior articular process. That's the tip of IAP. You start osteotomizing the tip of IAP, and slowly as you approach the epidural space on the medial side, you'll encounter the scar tissue. But revision surgeries like this can also be done via biportal endoscopic approaches. You start removing the bone, and on the medial side, you can see that now we are coming up with the scar tissues there. Yeah, that's the dissection of the scar tissue from the medial aspect of the facet joint. So you slowly go on removing the scar tissue. Sometimes it is very difficult to get an osteotome or a Kerrison punch underneath. So you use burr to trim off the sharp edges. This is the scar tissue that's a hooked radiofrequency probe, which is used to separate the scar tissue from the neural structures. And once you identify the lateral margin of the traversing nerve root, the rest of the procedure is again same. You do annulotomy, you do end plate preparation, you go inside, put in a cage, do percutaneous fixation on both the sides, and you're through with the procedure. That's the denuding of the end plate. You can go inside and check that both the end plates are very well prepared. You stuff in the bone graft. That also can be visualized by putting the scope inside. There's adequate bone graft anteriorly. You retract the nerve root, then you go inside, you put in the cage and bilateral percutaneous pedicular screw fixation. That's the end point of the surgery, the root that was getting compressed under the facetal hypertrophy. This is the actual scar from the previous surgery. They had taken posteriorly iliac crest graft, and that's the original scar. And we could just bypass all that, use a slightly paraspinal approach and do a complete fusion. Even if it's a case of two-level listhesis, we can still do it like this, two-level UB till if we start from the caudal level and then move to the cranial one. So it's a combination of tubular and uniportal endoscopy in the form of UBE, wherein we have a great advantages of having a fluid medium surgery, familiar approach, better visualization, and direct access to the pathology. On special demand of Dr. Malcolm sir, I have added this video because he always wants me to show this when I'm demonstrating a case of TLIF. You go inside the disc and to see how much of adequate you have done the end plate preparation. You stop the flow of irrigation, you see those beautiful waterfalls of blood coming in from the end plate. So that gives you a good sense of relief that it's going to be a beautifully, it is going to get fusion. So you stop irrigation and you see that the end plates are bleeding very nicely. And then you go in and put in your cage. If you want to learn more, you can go to this channel. I have my YouTube channel all about UBE, wherein I've posted a couple of videos about how I do it, the external video, the internal part, everything, unedited part. Also, I'd like to take this opportunity again to invite you all for this hands-on, this MISAPCon 2022 that is going to be in Pune from 17th to 19th of November. And we are going to have 4 delegates per cadaver in the pre-conference workshop, cadaveric workshop. There is going to be live demonstration of UBE as well as the rest of the minimally invasive spine surgery techniques. So thank you so much.
Thank you, Dr. Ketan. Any questions? Meanwhile, I'll request Dr. Siddharth to please ready his talk. Any questions for Dr. Ketan?
So thank you for the gracious invite, and it has been a great 3 days of the event. Now coming to the last day, my talk has been more of an academic talk, but I'm sure that by the end of it, although there's no lead, I'm sure you're already convinced. But this is just about the evidence what we have on date today for the endoscopic spine procedures as compared to other treatment modalities. So why make the fuss about the about this is because it's often a beginner's dilemma. You may be an expert in other procedures, but when you start endoscopy, then it's going to be a dilemma for you many times because you have other techniques to tackle this common problem. And can we do it? How to start? Result, safety, efficacy, and of course, not to talk about the steep learning curve. So when any one of you starts to think of the solutions for your possible problem, so it can range from anywhere from epiduroscopy, as we heard, to TLIF, or of course depending on the indication. So it's sometimes it depends on the technique which you are well versed with, and this is the reason why there is a bias. So there's always a bias while beginning. The more fluent you are in, or the more expert you are in a particular technique, you want to do the procedure with that particular one. And this is where you need to just pause and think and rather focus on the better outcome for your patient. While starting and transitioning from various techniques, it's often a stepwise learning pattern, and you need to do an n number of cases, and many times these have been documented in the literature very well. So you'll find papers documenting how many techniques, how many procedures you particular XYZ technique in order to have proficiency. And they've done studies on fellows and surgeons who are doing the procedures. And just even if I talk about just the injection is a learning curve, and there's a lot of time, and most complex procedures will take more time. And contrary to what the doctor from Argentina it looks simple, but it's quite difficult procedure to master. So as the time and complexity increases, you need to make this choice. And a couple of slides coming here, you will always be presented with multiple options. This is especially true in the current situation where more and more I would say multi-technique conferences are being organized like this one, where you're having different approaches. So it's more like choosing from, if you have a sugar craving, now what do you want to eat? It's many times it becomes like this. I will also, we are in Mumbai, so sometimes in your career you will find one technique looks better, and the other time you'll find the other one looks better for any case. So this is one of the famous Bollywood numbers, and the translation is that sometimes you look like X thing and sometimes you look like Y. So the same surgeon or the same endoscopist or the same physician may find one technique better at a particular time and the other one at some other time, depending on his training. And not to say this, you have a lot of different bullets in your armamentarium. Only you need to select the correct one, which one to fire. And the key is to master as many of them as you can, so that the bias gets over. So that this question of which one to fire, probably it's reduced. So coming on to the topic, I'll just go on with this was the standard approach, which is more of a traditional surgical approach to tackling the problem. And this was what revolutionized the thinking, and more popularity for this technique is underway. So what is the evidence? Focusing on the evidence, and if you see this particular diagram, it clearly shows the various techniques which you can. So this is a standard endoscopic transfemoral approach. This one, you land on the facet and kind of remit and becomes more of an outside in approach. And with this one, you go far lateral and come inside. These two approaches are also mentioned depending on how you approach and reach the target point. So what's the evidence? So as early as 2016, and if you study this paper, this is not new, but I wanted to mention this because this was as early as 2016. It was the percutaneous endoscopic lumbar discectomy. It was often pitched as an alternative to open lumbar microdiscectomy for a large lumbar disc herniation, which they defined as the one occupying more than 50% of the spinal canal. And this was considered a very viable option. And the cases which they took were from 2012, around 2012. So it's not something which is new. And we have almost a decade of experience after this. And if you see, 43 patients were included in this particular study, and this was not a very significant higher difference in any of the groups. And they found that the surgical satisfaction rate, they proved that it was more in the PLD group, which is the endoscopic group. And the mean operating time, hospital stay, and I think it's already clear, but that was established way back. The key here is, however, that the disc height, which they have very detailed study. If you go through this paper, this did not change significantly after the endoscopic procedure, while this advantage was not seen with the lumbar microdiscectomy. Also, one of the proponents of this technique has done a comparative assessment, that also quite early. And if you see, this is by Dr. Kim et al. In 2013. I'll come to the recent evidences also. And what he found was that the recurrence rate, which was a problem often at that particular time, was reduced if you started doing the annular sealing. And that's why most of us are now doing this, post procedure. Maybe our documentation or maybe the pictures are not as stark, but this one is very clear, and they demonstrated how they are doing this, after the procedure. So after that, we may be using the platelet plugs or different techniques, but the key was to reduce the recurrence rate, and this was also well taken. Coming on to this is a more recent paper, and this was a group which did a randomized trial for again transfemoral endoscopic discectomy versus microdiscectomy. And they found, although that there was a greater revision rate, which is very well agreed by many of you as well, I'm sure, but there was a more rapid recovery. So they said that you have to balance these two things going forward. A recent one where they compared, again, this was a 2021 article which I could find. So they also had similar findings: the low incidence of low back pain and fewer complications and early recovery. So as we have a transition from more focus on early recovery, so these techniques are gaining more and more importance. So this particular paper again compares the application value of commonly used techniques in the treatment, and they found that this was again an orthopedic hospital, and they found that again the first choice for the lumbar disc herniation had to be the endoscopic technique. So as it was being discussed by the previous speaker, that where do you start? So from literature update, most of the studies will conclude that although there is very good efficacy with both these techniques, and there are ways and means to counter both the disadvantages, however, data is quickly piling up in favor of endoscopic techniques. And you can even find some papers like this one, wherein they have done 8 different approaches. They have done the comparison, including the APLD, which was quite a primitive one. Then chemonucleolysis, again a primitive technique, now I will call it. The standard microdiscectomy, the microendoscopic discectomy, open discectomy, of course, the percutaneous endoscopic lumbar discectomy, and laser disc decompression as well. And they, in addition, they included the tubular discectomy as well. So this was what I could find, that in a single paper, this was the single most study which covered all the different techniques, and the most lower complication rates were found in the endoscopic techniques here as well. You can also see that even in the laser disc decompression, in indicated cases, it can be very helpful. But definitely the safest procedures as far as the post-procedure complications are concerned, they of course, even the macrodiscectomy was considered a safe procedure in this study. So as far my personal opinion is concerned, learn on techniques which are possible for you, and then gradually start one by one. Even to a trained surgeon in a particular technique, the next one may be totally different. So get result oriented and probably not technique oriented. And of course, we colleagues are always here, and I'm sure to help. Thank you so much.
Thank you, Dr. Siddharth. If there are any questions from the audience. Okay, thank you. We are just changing the schedule slightly because of the flight timings. So I would request Dr. Shesho Shah to come and present his talk on the technical aspects of making portals in UB and its pathoanatomical correlation. We will have Dr. Namit's talk after this, and then we'll break for lunch.
Good afternoon, everyone. I am Dr. Seshav Shah. I am the owner of Endospine Clinic. I'll be talking on technical aspects of making portals in UBE. I think we'll be talking UBE quite a lot since 4 days. I'll be just briefing you out how the portal changes are made for different types of disc herniation, different types of pathologies. So the objective for this presentation was to understand about the applied anatomy of UBE discectomy, different types of disc herniations, avoiding complications. So it is not an easy process to reach the success, especially in UBE endoscopy. We go through a lot of bleeding, and ultimately, when we reach the success, it seems quite easy, but it is not that easy as it seems. So what I feel are the 3 must-do steps for before starting a discectomy is it is preoperative planning, adjusting your portals. There are micro adjustments for the making of portals, but these micro adjustments do help a lot eventually. I do get bony work before flavectomy. I generally avoid doing a bony work after a flavectomy to avoid complications and controlling bleeding at each step when it comes. We'll just see about the bleeders, and there are generally 2 types of bleeders above the bone, which are arterial bleeders, and below the dura, which are venous bleeders. These are generally at 7 o'clock, 6 o'clock, and 5 o'clock. Generally, the bleeders are at these points. If the bleeders are not visible, you can blindly ablate that part, coagulate that part. The deep bleeders, the venous bleeders, we all know this. I may not go in much depth into this. So this is the scope of the endoscope. We've been seeing this quite a lot. We can go half a body above, half a body below with the UBE, interlaminar endoscopy. So practically we can tackle almost all the parts. So checkpoints. This is a small video for a central disc herniation. A central disc herniation, more towards the left side, alpha S1. These are the basic steps. I think we all know the basic steps of UB. Just a small video. I may even skip this part. A laminotomy, then a flavectomy, base burring, base of the spinous process, going towards the contralateral facet, a flavectomy, removing the superficial part of the phlegm, and finally the discectomy. So different, we were just discussing about the different types of disc herniations: central large disc herniation, up migrated, down migrated, and extraforaminal disc herniations. And there are many ways we've been seeing transforaminally, uniportal, biportal, different ways to tackle different types of disc herniations, but I'll be talking about UBE. So this is a large central disc herniation. You can see a huge disc herniation, L4, L5, last segment. So in this, generally what I believe is taking the portals, generally we take the entry of the portals at the pedicular or medial pedicular line. In a central disc herniation, I feel a little lateral entry is more better, so that we need not retract much of the disc. As such, in central disc herniations, there are deficits or chances of more deficits. So taking a little more lateral entry is better for central disc herniations than the usual. Yes, we might have to do a bit more bony work, but there are lesser chances of deficit. Now in upper lumbar, considering upper lumbar spines, the lamina are elongated as compared to the lower lumbar spines, and the bony work to be done for upper lumbar is more. So there are different ways for going to the translaminar. We saw a sublaminar approach in the morning. We can tackle upper lumbar pathologies in that way. Translaminar, sublaminar. You can see if we go ipsilateral, we need to take down the facet. So contralateral is more better if the disc herniations are migrated. This is the facet preservation that we see for a contralateral approach, and the facet that we need to take down if we go for an ipsilateral approach. So for an upper lumbar, the retraction of the root is not that much as compared to the retraction of the thecal sac that we see in a lower lumbar. So this is a contralateral approach, sublaminar or translaminar. For a down migrated disc herniation, I feel, I'll just show you the, yeah. For a down migrated disc herniation, the usual portals are here, but a little above, little more cranial entry would help us tackle the down migrated disc herniation without tackling the, without dealing much with the bony work. Now, the right-sided disc herniation, I think this is what a right-handed surgeon is very skeptical about everything. For a right-handed surgeon, standing with either standing on the right side, doing it from the right side, or standing on the left side, tilting or making the keeping the portals same, or shifting the portals. I personally feel I stand on the left side for either of the pathologies, right or left. I do from the right side, left side, keeping my portals, keeping my orientation as the same. I feel it is much more easier rather than changing the portals, or we all are not ambidextrous. For extraforaminal disc herniations, para-UBE is a good approach. Many might differ as transforaminal surgeons. I personally do more of transforaminal, but I need to talk UBE today. So I'm talking about para-UBE, paraspinal UBE. So the incision for paraspinal UBE is more lateral, starting from the lateral pedicular line, docking over to the SAP facet joints, taking out the facet tip. This is a more, drilling the facet tip. This is a better image. You drill here. This is the safe zone. As you drill, the disc is ready to come out there, waiting for you. This is a case of right-sided foraminal disc herniation, foraminal extraforaminal. You can see how battered the root is in this image. So this is the CT scan image and correlated with the endoscopic image. This is the SAP. This is the transverse process and the disc. Even the recurrent disc herniations can be tackled off easily. Because of the fluid medium, the dura is pushed forward, and there is a good plane between the dura and the fibrosis that we generally see in a recurrent disc herniations. So endoscopic fluid medium is a very good approach for recurrent disc herniations. Thank you.
Thank you, Shesha. May I invite Dr. Namit for his talk? Meanwhile, if there are any questions for Dr. Shesha, we can have them.
Dr. Namit Nitharwal from Jaipur, Rajasthan, for his talk on retrospective study of unilateral biportal endoscopy technique versus open microdiscectomy for the lumbar spine.
Good afternoon, respected faculty and delegates. Thank you, Malcolm sir, EFSI, and managing team to invite me in this great conference. Myself, Dr. Namit Nitharwal from Jaipur, India. Today, I'm presenting a study on UB versus microdiscectomy. Sorry, this is not working. Sure. Yes. UB is a technique minimal invasive procedure for spine surgery, while open microdiscectomy is the most common surgical treatment for ruptured disc herniation of the lumbar spine. A new endoscopic technique that use UB approach has been applied to conventional arthroscopic system for the treatment of spinal disease. In this study, we compared and evaluated the perioperative parameters and clinical outcomes between UB and open lumbar microdiscectomy for a single level discectomy procedure. And we compare pain and quality of life modifications, patient satisfaction, and complications. In this study was conducted at Manipal Hospital, Jaipur. We took patient from February 2021 to 2002. And all surgery done by me. And in this study, we took 86%, 46 for UB and 44 microdiscectomy. And we took patient of back pain and radiating pain related to lumbar disc herniation and symptoms persistent for more than 6 weeks, and MRI images correlated to the symptoms. And we exclude the patient of extraforaminal disc involvement, recurrent disc, motion instability, spondylolisthesis, revision surgery, spondylodiscitis, and we collect the data perioperative period to 6 months post-operatively. Pain intensity is analyzed by visual analog score 0 to 10, and patient satisfaction was studied by modified Magnava score, and quality of life by ODI, Osteoid Disability Index, and we analyze the patient on second post-operative day, second week, and 6 months. And we collect perioperative data on length of operating time, hospital stay, estimated total blood loss, and complications. Radiologically, outcome were took on pre-operative and second post-operative MRI images. Surgical technique, as many faculty have explained in detail, so I don't want to take much time. We did surgery in general anesthesia, patient on radiolucent table on prone position, and we are using the simple arthroscopic instrument, no other instrument. Instrument like 30-degree 4 mm rigid arthroscope and 4.5 mm spherical bar and striker radiofrequency ablator and some specialized UB instruments like tissue retractor, like tissue stripter, some special dilators, and some retractors. And in UB, we took a standard standard portals, like one for scopy portal, and lower pedicle we took working portal, and our target area were spinolaminar junction, and we mark on AP and lateral view, and then standard procedures follow after making endoscopic and working portal, and then we took triangulation, and then make a working space with the help of radio frequency probe, and then control bleeding with radio frequency probe, and then do a laminotomy by bar, and then took phlegm, and rest of surgery is followed by open surgery. And in open lumbar microdiscectomy, we did this surgery under general anesthesia, and in this study we used tubular retractor system of Jayon and Carl Zeiss loop. I got some problem, please. Sorry, we got some technical problems. इसमें लगा दो। इसमें लगा दो। इसको निकाल तो पहले मैं निकाल लेता हूँ, इसको निकाल दे। Sorry for inconvenience. Computer has stopped. I have described this open lumbar discectomy, and this is the MRI images. In MRI images, this MRI is showing L5S1 huge disc on left side. In this case, we did UB discectomy, and this is post-operative image. The fragment was completely removed, and I want to show a small video. In this video, we are showing this is the large fragment here, and we remove this large fragment with in UB technique, and patient got complete symptomatic relief. And this is statistical analysis. The average age of patient in UB was 40.5 and in microdiscectomy 49.33, and symptoms in UB only pain was in 19% and pain and weakness that is in 27%. In microdiscectomy only pain was in 18% and pain and weakness was in 22.7. Symptom duration of an UB group that is average 6.57 weeks, and in microdiscectomy 6.40 weeks, and follow-up duration average in months in UB that is 6.1 and in microdiscectomy 6.15, and disc level L4 L5 was in UB in 28% and in microdiscectomy 17%, and L5S1 was in UB in 18% and 23% in microdiscectomy. And clinical outcome in UB as compared to microdiscectomy, preoperative VAS score for Beck was 7.22, and post-op VAS score was significantly reduced to 0.94 in UB group. As compared to microdiscectomy, preoperative was 7.33, that reduced to 2.2. This indicates that in UB surgery, immediate post-operative back pain was significantly reduced than microdiscectomy, and post-operative leg pain was same in both groups, and preoperative ODI and post-op ODI almost similar in both two groups, and back pain at 2 weeks and 6 months almost same. Back pain on 2 weeks study was lower in UB group than microdiscectomy, but back pain at 6 months are same in both the groups, and improvement of leg groups are similar in both the groups, and improvement of ODI on back pain and in UB and microdiscectomy was same, and modified neck score almost similar in both groups. Operation time almost same in both UB and microdiscectomy. Estimated blood loss was lower in UB than microdiscectomy, and hospital stay was significantly reduced in UB than compared to microdiscectomy, and we are lucky that we have no complication in UB group and only one complication in microdiscectomy. That was a dural tear. It was repaired intraoperatively with silk, and patient no have post-operative complications. And UB show superiority in terms of short-term back pain recovery and small volume of intraoperative blood loss and less hospital stay, and improvement in short-term leg pain and long-term back pain and leg pain almost same, and quality of life was comparatively better in UB than microdiscectomy. So UB is a new method that combines the advantage of interlaminar endoscopy and microscopic surgery. UB system use two independent channel for instrument. Thus, movement of instrument are not restricted, and instrument of both 0 degree and 30 degree arthroscopy for knee and shoulders can be used, and standard laminectomy instruments are used. So beginners, this UB technique is no much investment. So beginners can who are doing a microdiscectomy can easily shift to this technique. And endoscopic trajectory is same as the conventional operation, and thus an experienced microscopic spine surgeon can achieve the necessary surgical skills without a steep learning curve. And high resolution video equipment pressuring the facet and ligament complex, lessing the tension of the nerve possible. And limitation of this steward is a retrospective as in nature, and we took a small sample size and short follow-up, that is 6 months. So we to establish the result, we should do randomized prospective study for UB to verify our present results. In conclusion, UBE can be an effective treatment modality for lumbar disc herniations. The anatomical trajectory and endoscopic view is similar to that of conventional discectomy. So UBE is a highly feasible alternative conventional to microdiscectomies. Thank you.
Thank you, Dr. Namit. That was very precise and crisp presentation. If there are any questions, yes, sir. Can we have the mic?
Whatever in this prolapse, and is
Sir.
there an indication that you do, and with what you do the fascectomy, with the burr or with the?
Sir, in routine discectomy, there is no need of fascectomy. If we do interbody fusion, then we have to do. Otherwise, in our case series, we did only laminotomy, flavectomy, and just remove the disc. We took only the central and paracentral disc protrusion. We exclude the extraforaminal disc in this study.
Oh, I see.
Sometimes you have a flatter facets and a disc that is pushing the traversing nerve root laterally. So unless you see the shoulder of the traversing nerve root, you are not satisfied whether you have done a complete job or not. But in that case, you just need to cut some medial portion of SAP only.
Yeah.
So the junction of the lower lamina and the SAP is where the shoulder of the traversing nerve root usually lies, unless it is a high or low riding nerve root. So some amount of undercutting of the base of SAP with a Kerrison punch, not with this thing, because once the epidural space is open, even though you're using a protection sleeve burr, a Kerrison punch is a much better tool there. And just like you would do in an open surgery, you use an angle probe, you feel the medial border of the pedicle. From there, you retract the neural tissue, take the disc fragment out, and then you analyze. Because see, my boss, Professor Gancha, he always used to tell you should be minimally invasive in your OPD and not inside the operation theater. Inside the operation theater, you should be doing what is required to get adequate decompression and not think on those terms.
No.
Even if you have to remove the whole facet and convert it into fusion
Can I just
technique,
finish up my thought?
that should be allowed.
Yeah. What I was seeing in most of the videos and all, use the burr, part of the facet was removed, and then use the punch, So he has not shown anything in his studies. That means the disc was far not lateral, but more medial and more
That could
soft.
depend on upon the pathology.
Yeah.
So our aim is always for any MIS surgery is to get the pathology. The resection is of secondary consideration. If it is needed, it has to be done.
Yeah. So,
basically, what we are treating is a compressed nerve root. It is a surgery of nerve root, not disc. So we have to be careful that we are able to see the root from shoulder, axilla going into the foramen. We should be able to see the mobility, confirm the mobility of the root. Discectomy is a part of the game. If we are inadequate in decompression of root, even adequate discectomy also will have problems in future. A small fragment coming and going into the foramen. In our student days, we used to see that the patient microdiscectomy was quite good. Second day, patient went to toilet and he had little bit of cough, started pain again. When we re-explored, a small fragment has come down. So it means that our nerve root decompression was not adequate. Same thing applies everywhere. It is a canal decompression. We have to see that both the roots are nicely decompressed. So this is in open surgery. That's why in my course, I tell them to get an old atlas of spine surgery, which is open technique, and follow each and everything with endoscope.
Absolutely. A
when
very
you
wise
see-
message for all
Yeah.
the youngsters.
Because when you see in the video, we don't realize how much the nerve root is getting, traumatized in that, no? And some of them have neuralgia, pain going on. We say 2 weeks mein kuch, I have had to see such results,
So
They
actually,
will come
sir, you
and,
give us
I
talks-
don't have hair because of that.
No,
People
you
come.
give us a talk for 10 minutes. So we need to, we tend to skip that part.
This morning I did a surgery, a young lady,
around 40, lady around 40, a huge central disc. She has disc herniation on the right side, but the pain on the left side. So I went from the left side. I took little more time to decompress that root till I was not sure that I'll be able to retract it nicely, and never retracted it. Decompress it, and then I went ahead and did the discectomy. So you have to be very careful. Don't go for number games that so many surgeries in per day. Nothing. If you work more, the complication rates will be more. This is I have mentioned in our book. When my boss used to operate 5 or 6 cases per day, his complication rate was quite in his limits. When I used to visit him and he used to stretch more 10 surgeries in one day from 8 to 8, the complication rate has gone up. Injuries, dural puncture, wrong levels, everything. When he changed from one hospital setup to other, the complication rate has gone up. Because of the social problems, complication rate has gone up. So we have to be very careful that we should not go for number games. One surgery, do it carefully, like a puja, what we do. Don't compromise.
Thank you, sir. Thank you, sir.
Just last question. You said something about right-sided pain and again from the left side. There are cases where the disc is projected on the right side, prolapse, but the pain is on the left side. In such situation, what do you do? And why does it happen?
My preferred choice would be a diagnostic root block on the symptomatic side first, just to inject a couple of cc's of xylocaine there and see how much of result and for what duration you get, and then you plan accordingly. This is a very common scenario that comes in our OPD. So unless you have a positive diagnostic root block, we will not offer surgical intervention in such patients.
No, today's case, she had pain on the left side, no pain on the right side. But because the disc is pushing the root into the left side, and I have to do a aggressive bony decompression on the left side. Because of that, I did the bony decompression first, and then I entered into the disc. Otherwise, if I would have gone from the right side, I would have done a very good discectomy. But the root decompression, for that, I had to do a bilateral decompression.
Bilateral decompression.
If I would have gone from the right side.
Side, then on the compressed side. I forget the name.
Okay, thank you. We will break for lunch now. We'll have
Thank you
a
very
quick
much.
lunch break.
I know we are keeping, but these are also little, spices for the food, what we discussed.
Yeah, so that's the message for all the youngsters. Not only discectomy, but nerve decompression. And if you want to see that video, you can subscribe to Dr. Ketan's YouTube channel.
अरे आराम से करो. That's why yesterday I mentioned आपका टेंशन नहीं रहता है. नहीं तो वो सिस्टर भी बोलती है.
Thank you.
Here is the neurofibroma. Then through the outer tube, we take the stay sutures. Push the roots anteriorly to expose the soil. We can use endoscopic bipolar to cauterize the vessels over the tumor for hemostasis. Use Then after detethering it from the nerve roots, you can just take it out, and this is the cord which is compressed. We can approximate the roots from lateral to midline, just shift them. And then you can close it with 4-0 Vicryl. When the anastomosis clips were not available, I used to close it with 4-0 Vicryl. This is one more huge tumor. This is the rudimentary nerve root from which the neurofibroma is coming out as arisen. This is the rudimentary nerve root. You can cut it. You can use scissor also, micro scissor. It from the caudal end. This is a meningioma at dorsal region. It was anterolateral. And this is the tumor CUSA which I am using. I use ultrasonic bone dissector, this tumor CUSA for safe spine surgeon. These are the anasto clips which we can use. Its closure is quite fast. This is the incision. This is pre-op and post-op. I used the 3D endoscope first time in 2015 for this neurofibroma. And these are the pictures of 3D endoscope. This was by Vision Sense. These are the 2D images of a 3D on the lower side. This is how it looks with the 3D. It's a big file. I'll just skip it. This is the incision. Dural incision. Take stay sutures. Open the dura. This is the tumor. Cut the nerve root from which the neurofibroma is arising. And this is immediate on the next day. We don't catheterize, we don't put a drain. This is at the cervical region. This is 4 hours after the surgery. No drain, no catheter. Till now, I have operated on 39 cases. Excellent result in 38. Better in one. That was a meningioma, long-standing meningioma. She had dense paraplegia. She recovered, but the spasticity remained. So neurofibroma was 28, meningioma 8, arachnoids is 2, and hematoma 1. There was no CSF leak. The highest level was C1, C2. Thank you.
Thank you, sir, for such a nice presentation. Do you have any concerns with the residual tumor with this endoscopy approach?
The neurofibroma, there is nothing like residual. In cases of meningiomas, only we'll have to think of it. But all the patients recovered, and in initial cases, we did the post-op MRI, but afterwards we didn't.
Any more questions from the audience?
See, as orthopedic surgeons, we are always frightened to cut the nerve root and all. And you are cutting it so.
No, it's a neurofibroma.
No. I'm just, and then you say the recovery is the usual way. Now you tell us so that we get informed and assure our patients when things happen like this.
When it's
maybe when you are busy, you're not available to come and help us.
When it's a neurofibroma, there is a rudimentary nerve root from which it is coming out.
Rudimentary.
Yeah, that you can see that it is a swollen nerve root. There is a arteriole over that. It's a tortuous nerve root from which it comes. So if you cut that, usually there is no neurodeficit.
And you say usual recovery. What we don't understand. What is the usual recovery?
Usually these patients of meningioma and neurofibroma at the higher level, they have spasticity and other things. When you decompress that, they feel like anything. The spasticity is gone, paresthesia is gone.
Just
only the
within
meningiomas
24
which
hours.
are long standing. Now the one patient which didn't recover, she had paraplegia for 2 years. That was a thoracic meningioma. She recovered, but this part of spasticity remained there. But she was able to walk around, do her all routine activities.
Okay.
But usually intradural extramedullary tumors, they recover quite good. We have seen in our residency days that paraplegic patient after 6 months, they used to come walking.
Thank you, sir. In the
Thank
interest
you.
of time, I'll
Thank you.
invite the next speaker, Dr. Nurbek Baban from Mongolia. Dr. Shumansur from Uzbekistan is also not there. Dr. Daniel. Getting past the endoscopic roadblocks to learning. He's from USA. So, meanwhile, he's setting up his talk. I'll request Dr. Pawnpavit to be ready with his talk. It will be the next one after this.
Pointer? Fantastic. Thanks.
Hello, everyone. And thank you very much for a fun night last night. Exactly. Seriously though, it was a blast, and I appreciate that very much. Doing anything endoscopic and they want to learn. So I put this together to try and help them. So for the more advanced and people that have done more endoscopic surgery, this is maybe going to be old news for you, but possibly you'll learn a few things. But I'm very humbled by many things, but endoscopic surgery when I started was very, very humbling because I didn't have mentors other than one guy who I could talk to, but nobody could show me anything. So I did what a lot of people do when I traveled. And I learned, I would have to say that I learned most from the Indian surgeons met along the way. Excuse that. So right is that I would get to the point where I would slow down. And it wasn't slowing down because I didn't have the right tool or something along those lines. Sometimes it is based upon your tools, but it was more because, and so I call that a roadblock, a mental roadblock, or possibly you don't have the right tool, but it was more along the lines of, I didn't know what to do next. So I've put this together and I said, there's got to be a way to present this to people so they understand how to get past those roadblocks. So some of the important things are prevent bleeding. And we all know that because when it's bleeding, it's a pain in the butt. You got to keep the case moving forward. Identifying where you are is always important. And some of the structures that you can use are where is bone, because bone is very much a constant. And then also keep your eyes open for the nerves and epidural fat because they usually hang out together. So, and the other thing was everything's based upon needle placement because that's how we get to where we should be. So I put this together because there's two lines. Midline is more here, and this is a line that's coming across the superior end plate of the vertebral body. But when I took the lateral, I found that I was at the wrong level. So always making sure where you're at is important. I mentioned that yesterday or 2 days ago, but also using an AP and a lateral to identify where you're at is always important because it's just confirmation. Avoiding exiting nerve root injury. And I learned initially by watching videos of some Germans operating, and I would watch them and they would take a hammer and a mallet and just mallet their dilator into position in the sheath. And I found that when I did that, people would have a neuropraxia and they'd have numbness or something would go on. So I said, you know, I could do things better and maybe I won't do that. So typically if I can't get into the foramen, what I'll do is I'll dock my dilator or the sheath on the SAP and then I'll start there. And the concept that I have is that I'm going to make space for me to get my scope in rather than force the scope into its operative area. So by removing a portion of the SAP and using either a drill or a trephine, basically you're increasing the size of Camden's triangle, and the triangle is basically bounded by the traversing and the exiting nerve roots. So by protecting those structures, you prevent problems in the future. The other thing that I found was that if I didn't do that, I would force myself into an inside out type of technique. And for me, I do not like getting forced into that particular position. So this is a patient that has an L3 and an L4 radiculopathy. So the problems that I encountered was, how do I take care of both of these at the 3-4 level? So I need to do a foraminotomy to decompress the exiting nerve root, but then take care of the lateral recess. So basically you start at the tip of the SAP and you go all the way medial. to take care of the lateral recess stenosis. So some of the initial things that you see when you put your scope in, obviously there's some soft tissue, and you just take that out. That's the simple part. Then let's see. Okay. So then as far as a foraminotomy, and for me, before I came to India, doing a foraminotomy was not a very common thing. Now I do it all the time. But some of the things you do, you just identify the roof, which is where the SAP is located, with the floor being the disc space. And you're bounded by the pedicle on either the caudal or the cranial end, but typically where you're working. You identify the tip of the SAP, and after that's been identified, then you take and remove it. So in the past, it seemed kind of a foreign thing to me, like I said, but now it's quite common. And I do it all the time because I find that it not only improves my ability to not get forced into this inside out type of approach. Get past that. And then another thing that I encountered was ligamentum flavum. And initially it was really a chore to move past and resect the ligamentum flavum. But with the use of bipolar electrocautery, you can identify the landmarks and develop your tissue planes. And using things like an angling curette like this has made a lot of improvements in my technique and what I'm capable of taking care of, because you can go in and free up the ligamentum flavum. And then after it's freed up, you can either remove it with a pituitary, or another tool that I like using is an angled cutter to get to where I need to go. So that's been very helpful. Some of the people that I'm teaching, they get quite flustered and they start trying to just grab the ligamentum flavum and remove it. The problem is with a grasper is that you pass point, you have to reach past the ligamentum flavum to get at it, and you can't identify what's on the other side. And we all know that on the other side of the ligamentum flavum is the nerve or the dural tissue, so you don't want to grab that. Let's get past. So identifying the disc space also is quite challenging for some people. And so the thought process that I use is I identify both the saphlad and the caudal poles of the end plates and the disc space, because you know that in between those two, everything that is bulging up and compressing the nerve is going to be disc material. So if I can't identify the saphlad and caudal poles along the medial border of the pedicle, I just put my bipolar or some tool in there. And then what I'll do is take an X-ray, which identifies the medial pedicular line, and then cauterize in between those two. And then entering the disc space is also the next step that I see people stop at. So what I'll do is I'll take an angled punch or cutter and then just cut along the end plate. And what that allows the surgeon to do is just move forward and get inside the disc space and also get underneath the nerve. Because again, whatever is bulging up is disc herniation or osteophytes or what have you, and you just take that out. Let's see. Again, you can use a pituitary in this case safely, because now you can see what you're taking out and you're not going to pass the point of the tip and take out the wrong thing. Let's see if there's anything else. So the other thing about the scope that I like versus doing MIS type of techniques is I can see underneath the nerve, which is not a very often spoken of advantage to endoscopic surgery. And as far as controlling bleeding, we've already talked about that many times during this course. I've only had to abort a case twice because of bleeding, and it wouldn't stop spontaneously. In retrospect, I probably could have used hemostatic sealant, But at the time I didn't have it available. So, and I didn't think about it probably, in all honesty, but I did go back on both of those people and they didn't lead the second time around and finish the case. So as far as keys to success, ask questions, visit other surgeons, and hopefully find some type of mentor that can help teach you all the tips and techniques that you've seen during this course. Thank you to everybody.
Thank you, Dr. Daniel. I'll now invite Dr. Pawan Pavit from Thailand for his talk. And in the interest of time, we are skipping the question and answers. Everybody's having a flight to catch, so we need to be a little rushed with the program.
Good afternoon, everyone. And thanks again for having me here. And today I would like to talk about the monoportal endoscopic treatment in spondylolysis, with or without spondylolisthesis. And this is spondylosis. All of you know is the PAR defect, right? And if they have the anterior slippage, so we can call the spondylolisthesis. And for the pathoanatomy of the root compassion, not every cases of the spondylolysis have the same symptom and the same pathology. No, because in some cases, for example, L5S1, some cases have the L5 compassion, but also in some cases has a S1 compassion. So what is the pathoanatomy of the nerve root compassion? If for the exiting nerve root, it was tapped in the stenosis foramen by the hook-like remnant. And I will show you the hook-like, not only the fibrocartilaginous mass. And this is increasing compromise by escalating the degree of slippage or not. Almost the spine surgeon that thinks more slippage increase the spinal canal, but it's not true. Huh? So you can see for this, you can see the more slippage. You can see the remnant bone hook right and slip forward together and compress the exiting the root. This is very important to know because when you perform the fusion as well, you have to identify the exiting the root first and to make sure you decompression the exiting the root adequately. The bony hook is the most important in the cases that have the L5 root symptom. And what is the monoportal decompression for the spondylolysis? Anthony Young is the first who report the 5 cases of the patient performed with the transforaminal endoscopic decompression. And I would like to ask you to see my patient, this patient, 21 years old, have a left L5 left radiculopathy. And you see, he has a PAR defect, right? And also he has an exiting, he has a foraminal disc herniation. So my choice is transforaminals and make the discectomy and decompression the L5 root. 1 year later, you can see the percent of sleepers increase. So what happened with my result? Why don't the same as the Anthony Young? And if I searched and I found that if in the case of the PAR defects, the second less strain for the anterior slippage is the iliolumbar ligament. And maybe when I perform the transforaminal, I cut some part of the iliolumbar ligament. So this is the reason why my case have the further slippage. And also, so I change my practice from transforaminal to interlaminar. You see that? In this case, 56-year-olds, discomfort and burning sensation on right ankle, and refer from the ankle expert to me. And you can see the PAR defect on the left side. Sorry, from the right side. And I perform the interlaminar decompression. But the trick is, in the case of alpha S1 spondylolisthesis, the entry point should in the L45. You can see on the 3D CT. If you shoot the alpha S1, it's very far away from the pars, and you have to cut a lot of the bone laminotomy until you reach the par. So if you perform the entry point L45, immediately you can reach the par defect and you can decompression very easy. The first thing, identify the facet joint first and go down to the pars. And then remove the fibrocartilaginous mass. Sometimes you can find the cyst. And after you identify the pars, you can decompression the nerve root. Keep in mind the nerve root just beneath the par. And then I use the overburl. And identify the nerve roots and decomp the nerve root and make sure you can cut the bony hook that compares the exiting nerve root completely. And this is the result. The MRI show adequate decompression. And this has been followed up for 7 years, still good. So in my practice, my option for the spondylolysis, if the patient had the back pain or instability, in the young patient, I perform the endoscopic decompression, par repair, and percutaneous back screw. And if the patient less than 40, because if more than 40, the fusion, but you can perform with the endoscopics as well. For the radiculopathy alone, no back pain, and the best option. So in conclusion, endoscopic par decompression is safe, successful treatment for the patient with stable lumbar spondylolysis and the nerve decompression. Even in the situation slippage occur,
Hello. Can you hear my voice? Okay. Dr. Malcolm Pestonji, please play my video that I sent earlier. Please unmute the Dr. Malcolm video, please. Thank you so much. There is no sound, please.
200 cases of transforaminal PELD. Good evening for all my senior and fellow. Thank you for inviting me in this great conference to Dr. Malcolm Pestonji and also staffs. This is my second presentation, PSLD, percutaneous stenoscopic lumbar decompression, a single surgeon experience. My name is Adam Mulyono. I'm the orthopedic spine surgeon in Indonesia, and my cases are still small, 30 cases of PSLD and 200 cases of transforaminal PELD. And the instrument I use is Karl Storz Coricet and Richard Wolf vertebrae. As we can see the anatomy, that is the lumbar vertebra, and all we know that we are dealing in this area, particular area, and this area. And for the stenosis and normal, there is a compression of the lumbar. And the therapeutic feasibility of full endoscopic decompression 1 to 3 level lumbar stenosis via single port is already published by Dr. Kang Pek Lim, Han Gawinam, and friends, and 2019 and 2020. There is a study that compare the study between uniportal full endoscopic spinal canal stenosis. This procedure, the full endoscopic, have more advantage rather than the traditional or the previous surgery. And the instrument used, we also use the Maxmore PSLD system. This is an instrument designed by Dr. Kang Tae Lim himself. And when we do this kind of surgery, we are doing this in lordotic because it can reduce the pressure to the bleeding of the endoscopic. Because if we do it under endoscopic, if there is a bleeding, there will be disaster or you cannot proceed to go surgery. And this is the interlaminar, not like my first presentation that I present in transforaminal. This is interlaminar, and we do from the posterior. And this is how I hold the scope. This grant the stability with this procedure, I can put the camera steadily. And this is the work that we use. I usually trim this bony mark first. And the entry point before we start the surgery, this is the most important. When we land in the interlaminary window, and the needle or the blunt needle should press the ligamentum flavum so that we can flavectomy and also burring. And the lateral entry point, we can do it medial entry point or lateral entry point according the pathology itself. And if we can do the over the top procedure, we can bend the scope, and so we can see the contralateral approach. This is how I do this procedure. This is how I press yes for central decompression. As you know that we can do this, and when we tilt the endoscope, we can do the contralateral side. This is the case that women 68 came to OPD with a chief complaint, pain, low back pain, and the buttock and the left leg. She couldn't stand still for a long duration, 1 minute only, and only 50-meter distance of walking, felt weakness and hard to move, and she had been treated of many medicine and nothing changed significantly. Yes, she has a history of hypertension, diabetes, and she is a heart failure patient. So we need to have a surgery that do not interfere her systemic condition. So this is the MRI pre-operatively. There is a stenosis here and the MRI myelography, and there is a stenosis also at the L45. As you can see, there is a the lumbar stenosis at the axial. And this is the procedure. The first, we burr and we detach the ligamentum flavum. As you can see, I use this this instrument to detach very carefully. This is my 30th case, and because for the earlier cases, I sometimes injured the dura or the root because I want to do it in a hustle. But as the time goes and we have the kind of handling that we have to handle carefully, especially for severe stenosis. And after we detach everything circumferentially, I try to take a burr everything and try to clean the flavum. And it can do this for approximately 5 minutes. We can detach everything and we can take out the ligamentum flavum in toto, or if we haven't have that skill yet, we can clean that with piecemeal garrison. And we identify the lateral recess and we try to decompress it with garrison. As you can see, this nice picture of dura and the vascular, and you can see this is lateral recess, and this traversing root is still compressed. This is the SAP. We try to do very carefully. I did injury also at the traversing root at my previous surgery, but after doing some of surgery, I try to do it very carefully. I can clean this for about 15 minutes, not because this is easy, but in order that we have to do it very carefully, not to injure. We can, if we injured, it will be disaster for the patient. Sorry. And this is the SAP, superior articular process. Since the patient has a pressure or foraminal stenosis, we can cut this by using chisel. As you can see that I use also chisel. Here, the burr is very very dangerous to use, and I have not the skill yet. I use this for a transforaminal instrument, and I try to cut the SAP so I can clear the foraminal. So you can see I use hammer also here also, and we take out this. And the final session, you can do it, the final check. As you can see here, all is decompressed perfectly. And sometimes I like to preserve some ligamentum flavum that is not compressing, because I believe the ligamentum flavum is a natural barrier for the dura, so it will protect from other complication later on. Or if there is a dural tear, it can work as a protector itself. So this is pre-op, and this is post-op. As you can see, there is a clear decompression of the dura, and this is clear. And the lateral recess and the cutting of the facet, as you can see here, the decompression here. And the MRI myelography is very, very good. And this patient can walk freely before pain, and she can get hemodialysis afterward, and she is very, very happy. So the take-home message is try to do easy case first, not to attempt difficult cases. Try to watch YouTube online about spinal endoscopy, repeat and repeat. Be persistent and never surrender. And complication like inadequate decompression, root injury, or complaint by anesthetic or OT team are the challenges. Try to be nice to them. Try to do the surgery in the morning as complication increase when the surgeon is tired or stressful in the afternoon or the evening. Do not try to prove to someone else. Please try to prove yourself that you are competent in doing the case, and good doctor should put their feet on the ground and pray to God. Thank you so much for the attention. This is my teacher and my fellow and in endoscopic spine Indonesia. Thank you so much.
Hello. We are now going to.
Yes, sir.
Yes, sir. Any questions for Adam? Adam, an excellent talk.
Thank you so much, Papa.
I love you. God bless you.
I love you too.
Stay healthy.
Yeah,
You
sorry,
are
I cannot attend.
You are advising us to be healthy, and you suffer a heart attack. Is that fair enough?
Yeah. Thank you so much. Sorry, I have a heart attack 2 weeks prior to conference, so I have to cancel my flight and also my visa, sir.
God bless you. Have a
Thank you so much.
care of yourself. Thank you so much, Adam. Okay,
Thank you so
bye-bye.
much, Papa. Bye-bye.
Bye-bye. I'm now going to announce, and I'm going to request Dr. Sameh, our chairman of the Congress, and co-chairman Dr. Nicholas Santau, to please come up on the stage. Please come up on the stage. We are going to announce the awards for yesterday's presentations, which so many of you faculties have marked these young boys. And I request all those who gave a talk yesterday to please come up on stage. Come on, Dr. Jipin, Dr. Anup, Dr. Maulik, Dr. Clevio, Dr. Kiran. Where are you all young men, young budding endoscopists? Please come up on stage. It is our pleasure and honor to have you with us. Come from this side. Come from this side. So please, आप इधर खड़े रहो.
We really did not plan this part. It was an extempore sort of a planning because the presenters presented the paper and went away. And if we had to tell them, we are going to give them a prize for each and every one who presented, they would have definitely stayed. So even then, we have out of the 6 guys, we have 4 of them here. Let's take a count from your side. Who gets the first prize? 1, 2, not this 2, 3 and 4. Which one? Huh? You should get the first prize. Oh, not me. Tell me, come on, wild guess.
Audience vote.
Audience vote. I don't want the ladies to vote. Huh? Come on, come on. Number 2. Malik, huh? Yeah. What about Jaiswal, right? Deep, Ghosh. What about Gopi? Anybody from the back? Stand.
Jipin, they're saying Jipin. You're not hearing, sir.
Oh, come. They are taking out your name. And who said this? He won. Oh, the lady. See, you're man of the ladies, huh? All right. And believe me, the ladies gave him the maximum marks. So the first prize goes to Dr. Jipin Gopi. He comes all the way down from Kerala. And he started this despite all the hardships and troubles. He is one man doing UB in Kerala. Please give him a big hand.
May I request Dr. Samay to give Jipin the check. And may I request Dr. Anta to give him an additional sweet gift.
Yeah. So next time when you come with this tie. Thank you. Yeah.
Do all the other participants?
No, this
Dr. Samay, please.
We had announced only one prize, so we just give that prize only.
To Dr. Kiran, please.
Jaiswal. Dr. Jaideep Ghosh. Okay.
It matters not who wins, it matters not who loses.
Huh? Who?
It matters who participates.
Yeah.
What matters is their courage. They are all young boys. They have taken their big step to come up in front of the world and present their case, their beliefs. And that is what is commendable. Sir, on behalf of everyone, I bow down and thank you all for participating.
And thank you, Dr. Malcolm, for the encouragement for these boys. That's also very important. Thank you.
Thank you. Thank you very much, everybody. We'll now progress with our next session, please. Why don't you sit here and chair the session? We have to start with the virtual talk of Dr. Elmer, please. And Raghav.
I would like to thank the organizers for their gracious invitation. I made all the preparations to be with you in person, even getting the ticket and the required RT-PCR test for the COVID, but it's not meant to be. I sincerely apologize for not being there in person to deliver my talk. I will be discussing a very interesting case I recently had, and the patient is still undergoing treatment. I have nothing to disclose. So let's move on with the patient. 61-year-old female, type 2 diabetic, hypertension, which is controlled. There's no history of trauma.
history of 10 years recurring joint pains managed by pain medications, and long time on and off pain score 3, with numbness on the left shoulder to the first 3 digits of the left hand, which progressed pre-pandemic to pain score 6, 2 years prior to admission. A year prior to admission, the pain persisted until patient was seen by a rheumatologist, treated with pain medications which afforded temporary relief. The patient continued to seek treatment and failed rehab management. She was seen by a spine specialist and was advised MRI, which revealed a C1-2 canal stenosis with Panus formation. Also was a C6-C7 foraminal stenosis was noted. And there was an incidental finding of an enlarged right lobe thyroid mass. There was no weakness, no bowel and voiding problems. The patient had intact neurology. The radiology showed os odontoideum with C1-2 hypertrophied ligamentum flavum, causing severe stenosis on the C1-2 spinal cord and with edema. You can take note that the canal diameter is only 2 to 2.4, ranging from 1.7 to 2.4 millimeters. So this is severely compromised spinal cord. Peculiar to this case is her recurrent episodes of osteoarthritis, for which may have facilitated autofusion of the atlanto-occipital joint and atlanto-axial joint. The blue arrow clearly delineates the separated dents from the body of C2, thus the diagnosis of os odontoideum. This slide is to reiterate the diagnosis of os odontoideum. It shows the patient's coronal views compared, this is the patient's coronal views compared to a normal. So this is the floating dents, and then the obliterated atlanto-axial joint. This is the dynamic X-ray, which showed stable occipital cervical junction. The patient can be regarded as having orthotopic os odontoideum. This is the 3D CT reconstruction that shows, aside from the fused atlanto-occipital joint, which is the green arrow, you can also see the fused atlanto-axial joint, the blue arrow. There is also the posterior ossified posterior atlanto-occipital membrane. So you can see the orange arrow that fuses the C1 to the occiput. So this is the problem list again. The main cause of the main symptom is the C6-7 foraminal stenosis, more pronounced on the left, and the incidental finding of C1-C2 severe spinal stenosis, which is asymptomatic, and then the incidental finding of a thyroid mass on the right, lobe. So it is also an incidental finding. The issues discussed during the informed consent is number 1, instability. The patient had been advised a transoral odontoidectomy and occipitocervical fusion, but the patient refused. So at this point, do we advise her to have that procedure, or do we just decompress? What kind of decompression do we do? So if we assume that the autofusion is enough to stabilize the occipitocervical junction, then if we do an open procedure and then to decompress the patient, we are going to injure the posterior ligamentous complex and probably remove the stabilizers or the autofused bones. Another issue is the doing the operation and a staged procedure. Are we going to do the decompression of the C1-2 together with the C6-7 foraminotomy? and then thyroidectomy. So the patient decided to have a stage procedure. So this is the plan for the patient. I planned for a posterior left spinal laminar approach with laminotomy of C1 and C2. This will maintain the posterior ligamentous complex and the outfused bone and keep it intact. This is the OR operating room setup of the patient. And here are the steps divided into three: the approach, the endoscopic stage, and the endpoint stage. For the approach, I did the C1-2 left spinolaminar docking. And then initially I drilled the lamina of C2 and then the lamina of C1. And then just taking out the ligamentum flavum. This is the video of the procedure. But don't worry, I'm going to pass through quickly with this. I have images that I can show you. So these are the still photos. This is the identification, the ligament, rather the C2 lamina, spinal laminar junction. Drilling of the C2 lamina, and Kerrison applied on the lamina of C2 until you reach the edge of the attachment. So you can see here the free epidural space. So you have reached or breached rather the edge of the attachment of the ligamentum flavum. Here now is identification of the C1 lamina or posterior arch, and then the drilling of the posterior arch of C1, Kerrison of the posterior arch of C1, then taking out of the ligamentum flavum carefully by piecemeal, and then you drill also the C1 and the contralateral C2, and this is the endpoint. We can see free dura of the C1-2 junction. The nuances of the procedure that I used is that the use of fiber optic intubation during induction of anesthesia, saline irrigation by gravity, insertion of instruments through the working channel should be deliberately slow to prevent sudden increase in the hydrostatic pressure, the bone drilling up to the edge of the ligament attachment. I have to maintain the BP at 90/60 to minimize bone bleeding. I need to control any visible bleeding right away. And then I had to close the saline irrigation to observe for bleeding before concluding the surgery. This is the before and after the surgery, and pre-op MRI showing the post-op MRI, the pre-op axial MRI, and the post-op axial MRI. Careful evaluation of the history and PE and radiology will determine the indications and appropriate procedure for each patient. There is a subset of patients who can have possibly stable C1, C2 junction despite the presence of ostodontoideum. Posterior stenoscopic cervical decompression is a viable option in this case and is a straightforward procedure. It will not injure the built-in stabilizers of the occipital-cervical junction. Our body is capable of healing itself as manifested by autofusion. Who knows, maybe some issues or pathologies that we are treating today is actually a poorly understood way of the body on its way to healing itself. At present, the patient is happy and is more open now to receive treatment for the thyroid tumor and the C6-7 foraminal stenosis. Patient safety and satisfaction is paramount. Thank you very much for your attention. Hello, everyone. Thank you very much for your attention. I will receive any questions if you have.
Hello. Thank you for a very informative presentation. Excellent skills. When will you not do this procedure? When will you not do this procedure?
For cases with osteodontoideum, it just became, it's just as a case for this. For osteodontoideum with unstable occiput C1 C2 junction, then it cannot be a endoscopic indication. Only for this case, for several reasons. First is that there's autofusion that holds the ossicle of the C2 in a stable position. The C1, the occiput C1 and C2 has fused itself. So that's why endoscopic procedure was able to be done on this patient. Only in these cases, I think endoscopic procedure is indicated.
Very often you have aplasia of the lamina and the ring and all, C1. In such situations, will you advise this procedure?
I have researched and the prevalence rate of these cases that you have thickened a flavum over C1 and C2 is only 0.38%. So it's less than 1%, very rare. And many studies in 1980s, Dr. Punjabi mentioned that in his cadaveric study, he did not find any ligamentum flavum between C1 and C2. And in my research, the term used is posterior atlantoaxial membrane. It's not even ligamentum flavum. So it's a rare case. And however, if it's there is no issue of instability, only a enlargement of the flavum or a ossified ligamentum flavum at that level, then an endoscopic decompression is, I think, is more superior because you will prevent total laminectomy and injury of the posterior ligamentous complex, and then you don't have to do fusion.
Thank you.
So any concern with the vertebral artery in that region, posteriorly?
Oh yeah. The vertebral artery is way lateral on this case. No problem. Docking is on the spinolaminar junction of C2. Since there is no spinolaminar junction in C1, it's important to dock on C2, so you know you're in the midline. And from the midline, you're allowed 1.5 centimeter of lamina from midline to both sides before you will encounter the vertebral artery. So it's very safe procedure. Although angiography may be necessary.
You don't believe in stabilization for these procedures, or only this one you are not stabilizing?
Only this one, because the patient is already stabilized itself. That's why even in my readings, I haven't encountered autofusion of the occiput C1 and C2. Even the occipital condyle and the atlanto-occipital joints are already fused, and even the atlantoaxial joints are already fused in this case. C1 and occiput are also fused. So I don't want to disturb that fusion. It's the body healing itself. So we have to listen to that.
Okay. You are with the nature. Thank you very much for a lovely presentation and showing us your excellent skills in this surgery, difficult surgery. Thank you. I now call upon Dr. Neeraj Jain. All of us talk about surgery. Whole day is surgery. Some instruments here, some instruments there, and removal here, removal there. And now Dr. Jain will tell us before we advise and show the patients our knife and scopes, what are the ways to get around the patient, make him happy, and strengthen the trunk.
Hello. Yeah. Good afternoon, friends. It's nice to be present around and talking in front of our senior most person here, Professor Nicholas, Professor Malcolm, and the team here from the World Congress. It's been a pleasure to present my work. Yes, rightly said, from big surgery to knives to the endoscopes to the epiduroscopes and now to the needles now. So we're going to do some needle surgery from here. And let's see what there is a wonders with the needle surgery, what all we can do, and let's maximize. So this is, I talked about this yesterday about the vertiplasty and all, and now we're taking it further onwards to the this disease. Is it for me, this tool and all? Let me see. Now I'm fine here. The disc disease, and now this has become a menace with the younger age group with so much of, see, I always keep saying, and I want to share here, the evolution takes ages, maybe a few generations for evolution. But here is a revolution for last 10 years, what is going on in life with the laptops and WhatsApp going on. So the human species per se is not adjusted to this revolution which is going. So that's why all these things are coming up, the neck pain, back pain, other things coming up. There's so many of this disease coming in, so many of neck pain people coming in, especially younger age group, which is meant to be an older age disease, become young age disease now. And these all people are coming, they keep creeping around and with this. And yes, obviously painkiller is not the solution. It's a easy thing, but it's a worse thing which people do it and it's to be avoided. Another thing is, yes, some good surgeries are on, but there is a patient who has got 3 surgeries done, and there is a cut in here, there's another cut in here, there's another cut in here. After 3 surgeries, still he's suffering. And look at the list he's having, and he's due for his 4th surgery. So sometimes that is not the best option either. So what is the best thing? We are trying to look at it. Yes, we have an option which is opening up now, which is interventional pain management, right from the conservative management to the big surgery coming in. And then yes, this has been taken, shared by the endoscopic work, and a very, very good endoscopic work, must say. Look in the conference, 4 days, it's a very good job done, and so much of work has been done around the world, and it's advancing very fast. The pace is very fast with the advancement. Now, this is the low back pain. It is a puzzle. Now, is it an annular tear, or is it the facial arthropathy, or is it the canal stenosis, or is it this mild listhesis which is coming in? Is it the Bartolotti syndrome, or is it wet facet? You can very well see they're more of a surgical candidate, not to be touched by the interventionist, and or is one of those 3 discs which is actually the main problem. So really you have to find out what is the issue like. And we know it that this degeneration, it has to get its own stages coming in, and we know the Dalla scoring. Now the back pain for ages together or for years together, months together, suddenly one day it bursts out and there is a leg pain. The history is very, very specific, and you know what has happened. As soon as the patient says, I said, your disc is burst, it's onto the leg now. So that is how it is. And we've been doing, like, there are the 3-level disc disease. This is 2, 3, 3, 4, 4, 5 kind of thing. But all discs, they don't need surgery or endoscopy for that matter. There will be few discs which are just painful, but they don't need a surgical work. A needle procedure is good enough for them. And it's very, very common, by the way. You don't see a single disc patient who's got other discs are all good and one disc is disease. There are coincidental, some disc disease, which needs little work, not that big work. Yes, evocative discography does really help to find out which disc is eventually painful. All discs which are looking big are not painful for the back. Remember, the smaller disc may be painful for the back and bigger disc may be painful for the leg. So that is important. And the disc which is burst, there was a back pain burst, now there's a root pain coming up. We really know the pain generator before we go inside the body. It's very, very important, because ultimately patient is bothered about the pain. He doesn't know what is going inside the body. He knows about one symptom, that's pain. And then pain goes down the leg for sure matter. If there is a history, then obviously it's a radicular pain. But by the way, radicular pain goes below the knee, but the other pains, facetal and SI, may stay above the knee. So this is important to understand. Well, there is many patients who need a root block. Yes, initially we always try, by the way, before we put them for any on table for surgery or endoscopy or other procedures. This is something minimum, or it buys you time also. Patients start thinking, okay, It's a shock for the patient. So patient gains time out of this. This is a subpedicular approach. We started initially, but we found it unsafe because there's a radicular artery there. So we started doing a canvas angle approach, which is much safer approach. Although it used to be called safer triangle, I say safe triangle. Now I say safer triangle is a canvas angle, which obviously is the right thing to do. Because disco-radicular conflict is in the canvas triangle. In the lateral recess block, we call it. And that's where we start doing neuroplasty. And if we open up the nerves, it is good enough for 50-60% patient whom you think could be a surgical candidate. Yes, I've done few further things, which is global first, by the way. I take ownership of that. And we just doing a epidural epiduroplasty, which I presented in World Congress in South Korea, I mentioned you. And this is what I do. Well, there would be some patient who is having a back pain, be it surgical or non-surgical. Understand, patient is in pain. That's why it's all black, obviously. So, but one has to take care. They're all not surgical candidate. Another important point. So what, but they still are in pain. So better do something about it. We do a facet RF, we do SI joint block, and sometimes there is a piriformis syndrome. So we do a piriformis work. Well, if there is a big SI pain, then we do SI RF, which is on, and there's a new technique for SI RF. We do a neuromodulation, or we can do a RF, which is called a strip lesion on the SI nerves. So the one needle will be good enough for strip lesion, or we do a neuromodulation these days. Bartheloti syndrome is another issue. We do miss on these things good number of times because it's a coincidental finding. If I find L5S1 is nice, L45 is disease, I do see good number of patients of these are having a Bartheloti syndrome or transition vertebra. So the load is shifted on the L45. That's why L45 is more disease. L5S1 is looking cool. But yes, because it is a transition vertebra, not a complete sacralization or lumbarization. So patient is having pain, we do a Bartheloti. What I do is I put a needle here, do RF and do my LA test first. And after LA test, either I phenolize or do I RF again. And that is good enough for these patients. And they are really been helped. And it's a real entity. Another is a coccydynia. We've been sitting here for last 4 days. I think few of us must have had a tailbone pain because long hours of sitting can cause this, but it is a known entity and it is very, very much treatable after physio and medical. Anything which I say here on this dais, 1 month of conservative management is on for anything, everything, until unless there is urgency for some cases. And thereafter only you start thinking about all this. You're talking about all this. You do a coccydynia ganglion impar RF or ganglion impar block. We do a spread of steroid over the coccyx. And if it keeps coming again, intractable one, you do coccygeal nerve RF. And that is what is really very helpful in these patients. Otherwise, they keep coming back every 6 months. There would be some patient of a rib tip syndrome. Now, I'll give you one lead, my friends. When I have a patient where we don't know radiologically what is the problem, I put the patient on table, CM. I ask the patient to put a finger on the pain. I call it a finger test, finger on the pain and do a fluoro check. And most often I'm right. Patient is telling, was a facial pain or which pain? This patient had to put a finger on the rib tip. So we do see rib tip syndrome. Just a shot is good enough. Steroid or phenol is good enough. We do see this. We don't talk about squeaky nerve syndromes. There are another problem patients. And if we just know it, what I'm trying to bring up on this dies is that we have other things also beyond just plain disc bulges. And this is what I'm talking. And we have seen entrapment. People have opened these squeaky nerves. We do ultrasound guided block on these nerves and we open up neuroplasty and they really work very great. Parts, obviously we know it. You do a bone scan. If there is anything, even facets can be picked up. And obviously for the matter, malignancy and other things or fractures can be picked up. And if there's a parts thing or there's lysis, obviously they have a different pain, more of a surgical candidate, but then let's see, which patient needs what. If there is spondylolysis, just an enterolysis is no lysis, or there is a weight facet, bad patient for interventions, but few patients may merit intervention, and then we can go ahead. Yes, this is something new coming up, which is the PRP therapy. We've been doing steroid for ages, be it tennis elbow, be it plantar fasciitis, be it knee also, but it's more inclined towards PRP, regenerative medicine. And we're doing a PRP with all these facet injections. And it said PRP fares better than steroid after about 2 months' time. So it's better to go with PRP. This is a regenerative medicine with a longer lasting results. So it's better to do a PRP. And this is about a medial branch. We have to burn only the medial branch, which is going on to the facet. We leave the other branches, intermediate lateral branches, because they are the motor branches to the muscle, paraspinal muscles. Never ever burn those things because you're taking the core muscles out. So it's not fair. And that is where the needle has to be placed. We're doing RF, facial RF. We keep seeing post-surgical patient. Why? Because there's a transition syndrome now. These 5 places are fixed now. The load increases on the other levels. So there is a facial arthropathy or disc disease. So we keep seeing these patients coming in and we have to help them out. Cool RF is doing good job. It gives a bigger lesion. Yes. And there is another RF which is coming, is tri-pronged RF. It is evolving. Science is ever evolving. We cannot be finished with the science. And yes, obviously, and human body is such a, what do you call, secret thing. And this is, I told about yesterday, I immediately browse upon the sinovertebral nerve, which is causing vertebrogenic pain. This goes to the end plate. What I'm talking is the modic changes now. The end plate pains can be taken with sinovertebral nerve. And this is where we just go at the posterior 1/3 and we have a sinovertebral nerve coming out, burn it out. And this is done typically like a kyphoplasty system. And the system is already there in place. And it has been used. Understand, this intracept has been used already. This is another is vertiflex, just to gain little height at the posterior column. And that is what vertiflex has been used, where you don't need anything much. Disc looking okay, only the posterior areas are gone. And they maybe some patient which be having some disc disease, but how far a surgery is right, this is to be thought, or is overdoing, that is to be seen. This era of lesionism, and we do with the needle procedures. Again, a PRP or BMAC for the all-days disc. Ozone we've been doing, by the way, but now we are already onto the BMAC or the PRP, which is better than anything else as far as chemical part is concerned. Methylene blue had come in, chymopepin has come in, now is the PRP, BMAC. And this is what I was saying, ozone, the monopolar RF, the bipolar RF, bioplasty, and we remove the disc material, the disc effects, and endoscopy obviously is on. And then epiduroscopy, you saw very good disposition of epiduroscopy for last 2 days. And this, I've got a 80-watt Mac laser. This is my own laser, by the way, from Acutech. I use it very, very often for my endoscopy cases and more so for my epiduroscopies. And I use it. And as a patient who is there, who's got a small disc bulges here, well, it's a patient call now. You give them options. Always give them options. And let's see what patient chooses. Whether I go for disc effects removal and the annuloplasty, like typically a fragmentectomy from the posterior annulus only under fluoro guidance, strict fluoro guidance, and do annuloplasty. It's a dental surgeon, by the way, he's doing fine. And he owns a nursing home. He doesn't want to take a big leave of the endoscopy, and which is always on. If it doesn't result good, then your endoscopy is on. And this is bioplasty. This is how the needles are placed in the posterior annulus, in the torn annulus, and you just bioplasty, burn this out, and we kind of take the pain away, denerve the annular nerves, which are new innervation, by the way. And this is a typical of the decompressor. We started doing ages back 2007. And this is 2007, by the way, picture. And we could remove good disc debulking, only closed disc, not the open disc. So we always do a discography and check whether it's a closed open disc. Closed disc, yes. Open disc, no. This is like open disc. Big open disc, big fragment coming in, young patient, and you can remove such a big fragment. Look at this fragment, has got all 4 parts of the endoscopic disc removal. This is the head, which is dead head epidural reaction, the mass, which is epidural part, the neck, which is at the annulus area, and this intradistal portion with the end plate. And this is all removable. And then you have a nicely
Sir,
decompressed.
we are running off time. Can you
Okay.
sum up the thing?
Actually, I've got 2 talks. That's why it's a joint thing. So I'm just going fast on this. And this is like we saw the cardiac vena part. You cannot go from posterior because it is all covering, tenting over the big fragments. So we can go from the side and remove the fragments in there. And this is another patient who has got a fragment on the side, by the way. The fragment is lying on the side. So we can go from the back, remove the fragment from the back. And that's how it is. I'm coming to the interventions quickly. We talked about facet RF. And I'll just take the slides which are relevant. Now, this slide was important from one point of view. When we do a decompression, I do a epidurogram on the table, on table epidurogram, just to be satisfied my job is done. If I'm not too comfortable and know the facts, there may be patient who's got 2 lesions. Jolly will address both the lesions if the patient has got a problem with them. Now, this is about the cervical part, the second half, quick half. And this is a patient who's begging for suicide. Truly, he came to Bombay for the business purpose, fell in the bathroom. He had a problem. He was treating on brachial plexitis, and later on proved to be a cervical radiculopathy patient. And we just did an epidural steroid first and a root block thereafter. And then we went on for intradiscal procedure. I'm talking long back 2010 or something. And we do intradiscal procedures like coblation, decompressor, or monopolar RF, or laser. You're seeing laser now in work. And that is intradiscal laser debulking part, just a debulking part. And it doesn't help the protruded part for that matter. It just debulk that is. Now it's a beautiful thing which is coming. Ultrasound guided procedure. Now what is going on is that they're just looking. They look at the pictures here. This is ultrasound view, and you're looking at the disc areas now. You can jolly well get into the disc interiorly under ultrasound guidance because there's a lot of vessels and structures around. And once you're inside, you can pick the fragment in, and this is disc cervical disc effects. You go to the back, take the fragment out through a small bore needle and take it out. At the end of the procedure, must always do annular repair because otherwise annular rent will bother the patient, will have a neck pain. And it's a small scar, almost stitchless procedure being done. Never ever miss on facet orthopathy. If there is facet orthopathy which is coexisting, must treat it either same sitting or next sitting. That's my word to everybody. And because otherwise patient will still be cribbing with the back pain. And it is obviously a disease entity by itself. It is done ultrasound guided very often and with the good results. And we can reduce the radiation part for that matter. Sometimes there is a C1, C2 arthropathy. Rarely we do see it, but we do treat it. Patient needs help sometime, and then you're doing all this procedures post-surgically also. They come with post-surgical patients. It's our duty to help them out. And means we as a mass together. I do a DRG block. And one small thing in here is because I see a nice Cambius triangle here. We've been talking about Cambius triangle. This is a nice Cambius triangle. We can take some measurements for the future studies also. Yes, we do RAX neuroplasty. But the problem with the RAX is sometimes it's a very supple catheter. It doesn't give in after that, big fibrosis. So, and this was the flexi-tip catheter, which was there spring loaded. But what I've devised, and this is what I'm going through the Cambius triangle again and getting into the place and taking it from the caudal area or transmural area or through S1 foramina. You can look at it. This is gone through transmural area. You're going above, going below, same catheter, or going just behind the disc and going against the posterior cortex for vertiplasty, other reasons which I mentioned the other day. You can go through caudal, transmural, via endoscope, and even through S1 foramina. And it is doable. It's 2.8 mm, so it can go through. Some patients, rarely, although if need be, I do a cervical neuroplasty. And I've just seen the needle in here and the catheter has gone up to the C2 dense. You're seeing the catheter, the C2 dense. It's a balloon, by the way. And we take the balloon up there. I mentioned you this yesterday. This small thing, which is, I think, of relevance to the group, and I must share, that I do sometime if I feel my fragment has gone out, the tail is there, and I am not able to catch hold of my fragment off the side, I just put the balloon up there with a Fogarty catheter and pull it back towards it. So my fragment comes along with the balloon, just like a stone retrieval in the CBD or other places. Why it can't be done in here? And through the same rent, which annular rent was there. So the fragment, you start seeing fragment, you catch hold of the fragment and take it out. And that is how the balloon looks like. It takes the fragment towards you rather, and then you can just retrieve it instead of leaving it alone or doing another opening up. This is another device which I have started doing lately. Through the endoscope, I start putting flexible endoscope, and you can really rotate it 180 degree to your choice, and you can really see where the fragment has gone. Now you're seeing sidewise lately, which your endoscope cannot see, rigid ones can't see. And then you can put your instrument through this. There's a forceps in here. There's a claw, jaw forceps in here. You see prong in here, which can really, catch hold of the fragment and take the fragment out. I've started doing few basketings also, and baskets can go really far, and they're very almost no atraumatic, and take the fragment out from there. I'll be presenting this in one of the congresses. This is the disc mesh plasty. I'll be sharing maybe in a due course of time. I'm going New York for my talk in November, and that is the talk is about the advanced interventional pain interventions in difficult spine cases. And these are few of my things which I want to disclose there. Caudal neuroplasty, Koreans are taken up very well, and they're masters in it now, and they're doing good surgeries also as it is. And they're doing good job in there with the balloon. They put a balloon tip catheters now, and which opens up, and they do medication also. Epiduroscopy, yes. With the laser, it has become from diagnostic to operative. You can really de-roof the synovial cyst, or sometime you want to really see if there's adhesions and all. I think it's been beautifully talked, so I'm not just going to leave it alone. And post-surgical patients, this is, by the way, patient who's got his 13 procedure done, 6 surgeries done, and still is having pain. And look at the root, which is getting impinged in here through the implant. Now the answer is remove the implant, but patient is not agreeing, the doctor is not agreeing, and then you have some options, although ultimately you had to go for the implant removal. You can put it, this is something which sir was saying, this is the core muscle strengthening. This is called reactive aid. This is the new thing come in neuromodulation, which you put in the multifidus muscle, and you stimulate multifidus muscle for core strengthening only. And this has become, wow, this has shown a very good results in those patients in core strengthening. And yes, post-surgically, spinal cord stimulators are on. It has been used here and there, more in the Western world because of the cost reasons. Indians are not using that enough. But yes, DRG stimulation has come in. It is proven to be very effective, very focal, and very, very effective, more than the spinal cord stimulation, and less traumatic. And let's see, you can put multiple of those spinal cord stimulators, DRG stimulations, and that's it. This is the patient which I was showing you. The spinal cord stimulator had been put in the posterior dorsal column, and patients giving thumbs up on table because you do stimulation there on the table. And at the end of the procedure, patient is going back home. The very other day, there's no morbidity per se of the surgical morbidity. We just, yes, we have to put a battery. That's the only thing there. Yes, there should not be any spine cripples in the society. Such an efficient team there, such a confident team there. Spine cripples are not on in the society. So please beat any procedure, but let's, kind of cure them all. And we should tilt a perspective, which way one thinks is a different thing. Yes, we have a duty towards our coming generation, and we should fulfill our duty towards them. Better off the science to the best possible one can, beyond the bars of the boundaries or the caste and creed. And yes, teaching is learning. I always happy about it and pleased about it. Thanks to my global family who allows me to take time out and do all this. And thank you very much, friends, for your time. Thank you so
Dr.
much.
Niraj, for showing us a plethora of cases and opening the Pandora's box. Thank you indeed.
My pleasure, sir. My pleasure.
I now call upon Dr. Bhupesh Patel. He will talk about high migrated.
Dr. Varun is going to give his talk. Is take a flight.
He is. Dr. Varun Agarwal will talk on navigation guided endoscopic spine surgeries.
So good afternoon, everybody. I'll try to be quick about my talk. It's not coming. Yeah. So I'll be talking about use of navigation and how it is combined with endoscopy, and you can use the spectrum to deal the pathologies with an endoscopic solution. So when we talk about navigation, this is the question which is always asked. Who needs navigation? It is too expensive. It will slow me down. The doctors say they are doing fine without it and don't fix what is not broken. It is just marketing and is good for new surgeons. But this is how man has evolved. But we should ask ourselves that as spine surgeons, are we ready to evolve? So this was in the earlier days when my dad used to say that I used to study under candlelight, and now everybody is with LED, and everybody would remember booking their STD, ISD calls, and now even the rickshawala has the iPhone in his hand. So the magnitude of spinal problem is increasing. 80% of the population is suffering from it. The spine surgery has increased. And this is what is traditional spine surgery. And this is what everyone wants. With endoscopy, we are achieving this. And this is the new definition of MISS by the AO Spine MIS Task Force, where it says it is a suite of technology-dependent techniques and procedures that reduces local operative tissue damage and systemic surgical stress, enabling earlier return to function, striving for better outcomes than traditional techniques. So this is the benefit zone. And what is the scope of navigation? Where does it work? So with great technology comes great possibility. So this is a case of Carey spine, 55-year-old female, 1 year follow-up of heel TB, not getting pain relief, severe back pain, and severely osteoporotic as well. So you can see here that the vertebral body is destroyed and there is quite a lot of instability there. And you can see here, even the vertebral body is hollowed out in the CT scan right there. So this is how we do it under O-arm navigation. So I did a anterior to the psoas corpectomy and put a cage there. So this is the OLIF kind of a procedure where a mini open technique was used to reach anteriorly, put a cage there, navigated screws. And this is the final picture. You can see the stability there. Anterior MIS anti-psoas approach for corpectomy with an expandable cage. and posterior percutaneous cement augmented screws, all done MIS and under navigation. So this is the final picture, and these are the small scars. That one is for the graft on the ilia crest. So another case of a spinopelvic dissociation, a 21-year-old female came with spinopelvic dissociation, type C3U fracture of the sacrum with fracture of the transverse processes of the L5, bladder and bowel involvement, bilateral foot drop. Once her fat embolism settled, you can see here that the sacral fracture is there. We decided to take her again under navigation. So this is the fracture pattern you can see on the CT scan. And under C-arm again, under the navigation under O-arm, we did it percutaneously. This is the fixation, all done percutaneously and stabilized. And you can see here that the fracture has been reduced. No need to open up the fracture of the sacrum. And everybody knows that opening a fracture sacrum is inviting, a lot of trouble on yourself with the wound healing issues. And this was all done percutaneously. Patient by second post-operative day even got a foot drop, started recovering. So no need to talk about the spine surgery under local anesthesia in this forum. So when we combine endoscopy and navigation, we can, enhance the benefits of the both, and we can boldly go where no one has gone before. So another case of an occipitocervical anomaly, 8-year-old male came to me after 8 months neglected case, complete quadriplegia. The occiput and the C1 are assimilated. The C2 and the C3 assimilated. There is subluxation, basilar invagination. And this is the basic problem. On the arteriogram on the CT, we can see that the vertebral artery is overlying the C1, C2 joints, and there's no space to enter the screws for the traditional fixation without mobilizing or maybe damaging the vertebral arteries. So this is the open surgical route, transoral odontectomy or Goel-Harms fixation. Then MIS options have been described, wherein the tube retractors has been placed. So this is how we approached it. The patient was positioned supine, and this is the endoscopic way. The standard Anderson approach from the anterior below the from the anterior cervical area that was used. And you can see under navigation, there's a tracker on the endoscope, and we have reached the odontoid, and then the odontoectomy was done. So the transoral approach has its own sets of complication, and this is through the standard Anderson approach. And you can see here that the odontoid has been resected, and then later the patient was flipped over and fused posteriorly. So this is the 20th post-operative day that the patient has started recovering. You can see. So this is a long follow here, 2 years post-op. He has now gone back to school, doing all his daily work and recovered well. So this full endoscopic uniportal odontectomy has also been described by Dr. Reuten from Germany. He has done a couple of cases there. This is the approach basically. So for Carey spine again, between like I showed, a 15-year-old female with complete quadriplegia, patient planned for decompression, no oxygen due to the COVID second wave. And then again, endoscopic guided. Under local anesthesia, we just placed the Jamshedi needle through the transforaminal route in the D6, D7 area. And then this is how it looks like, decompressing the cord anteriorly. And then the patient presented after 4 months with complete neurological recovery. And then she was taken up for fixation, and she was mobilized the next day and at 1 year follow-up. So where do you want to be in this technology adoption life cycle? Early adopter or one of the laggards? So when we talk about spine surgery, the mortality in the 19th century, this was the first case reported in 1827. The operation was successful, but the patient was dead. In 20th century, now we come down to morbidity, but in 21st century, we are talking about outcomes, and image guidance can assist even the most experienced surgeon. So keep upgrading yourself. And when your cab driver is using Google navigation, so you should ask yourself, why aren't you? So thanks a lot for a patient hearing.
Thank you, Dr. Varun, for enlightening us on this latest use of technology in endoscopic spine surgery. Have a nice trip back home. Now I call upon Dr. Bhupesh Patel, the king of Gujarat in endoscopic surgery. Sometimes you get disc migrating high and low. So Dr. Bhupesh Patel will gives us some tips and tricks.
Yeah, good afternoon, everyone. I think we are few people are left. So I will be talking on high migrated disc herniation, how we deal with transforaminal and interlaminar endoscopy. So I'm not going to detail on this thing because you all know what is disc migration, but I just highlight this zone 1, zone 2, zone 3, and zone 4. Zone 1 and zone 4, we are basically discussing here. Zone 2 and zone 3 is relatively easy to tackle because zone 1 and zone 4 are far up migrated disc herniation and zone 4 far down migrated disc herniation according to this classification. So what are the surgical options we have? We have traditional inside out technique, transforaminal, outside in technique, transforaminal, modified technique of transforaminal approach. Then fourth is interlaminar approach, like interlaminar and monoportal or biportal. First is inside out technique. Here we have two. If we are dealing with near migrated disc herniation, then we should do half and half view. Sorry. And if we are dealing far migrated disc herniation, we can do complete epiduroscopy. So here angle of insertion is very important. If we are dealing with down migrated, we all know we have to come from above downward. If we are dealing up migrated disc herniation, we have to go below upward. So these are images how we deal up migrated disc. We can change our direction of cannula for transforaminal endoscopy. Position of cannula again half and half view. So you can see here partial tip of the cannula is inside epidural disc and partially in the epidural space. This is endoscopic picture. This is a complete epiduroscopic technique. Here we are completely staying into epidural like what we do outside in technique. But we first anchor our cannula inside the disc just to get orientation. Left are the option outside in technique, modified transforaminal interlaminar. Now this is the first we are dealing with inferior migrated herniation. So what are the option we have via transforaminal approach? First is superior oblique pediculotomy. Second is foraminoplastic. Third is transpedicular approach. So this is a 45-year-old male with severe right leg pain since 3 months, all conservatives, SNRB, but no relief, no neurological weakness. You can see L23, highly down migrated disc herniation. So disc is reaching below L3 pedicle. So CT scan, no instability, no calcification. In transforaminal endoscopy, calcification, whether disc is calcified or not is very important. That also decide our approach. You can see we are completely staying in the epidural in AP and lateral view. We did superior oblique pediculotomy. You see, this is a pedicle. We drill this part, junction of superior articular process and upper part of the pedicle. And we reach to the herniation. This is a short video. So we are drilling this part of pedicle and superior articular process to get to access to the epidural space. So now we entered into epidural space. We can with RF we just cauterize the bleeders in epidural space and we puncture that part of the herniated fragment. So you can see the fragment is herniated and down migrated. With hook we tease out the fragment. So two to three big fragment. Oh, sorry. So post-operative image. So there is good decompression. We remove entirely complete fragment. So he's again, the next case is 64-year-old male, right side radiculopathy with no weakness, and he has an open discectomy in 2009. So again, you see the L23 highly down migrated disc, but here the important part is the root is medial to the disc fragment. So there is nothing between pedicle and disc fragment. No instability. So here we little modified our approach. We go through pedicle. We call it transpedicular approach, and we drill the part of pedicle and we remove that chunk of bone. And again, after end of surgery, we just replace that bone after removal of disc. You see the approach again. Yeah, this is the most important. You need to stay when you are reaching the medial pedicular line. You need to stay at the posterior vertebral line. This is gradual drilling, and last part of the medial wall of the pedicle, we just need to drill with a burr, high speed burr. You can see here. So where moment you breach the medial pedicle, the fragment is pop out inside the cannula. So rest of the thing you can go tease with the hook up and down. You can remove easily. Now you can see complete removal of fragment, and you can see periculotomy also. So now third case is, now we move to interlaminar approach. Third case is, this is a case for debate. I think if Dr. Malcolm, we have time, then we can see this case. What are the approaches for these cases? This is a 57-year-old male with severe right leg pain since 1 month, bilateral foot drop. Right is complete, left is partial since 15 days, urinary retention since 1 week. And he is wheelchair bound due to pain since 15 days and not able to walk. And all our weaknesses progressively increase, first on right side and gradually progress on the left side. These are his MR images. You can see huge down migrated disc and also L5 S1 disc, 4-5 L1 both level. Here you can see completely occupied epidural space. This is images, sorry. So what could have been done in this case? Sorry, man. Again.
You let the cat out of the bag.
Okay. So I go through interlaminar. First, I did L5 S1 interlaminar, and then I went for L4-5. So what here we did little different thing. From L5 S1, we angulate our cannula and we removed fragment of L4-5 down migrate fragment from L5 S1 interlaminar space. So here we don't need to do any bony work at L4-5, and then remaining part of the fragment we remove from L4-5. So we don't need to do too much bony work. You know, all fragment are removed from L5 S1, majority of fragment, and little fragment for L4-5. So I'm doing first L5 S1 discectomy. Then now I move my cannula towards the L5 end plate. This I am doing L5 S1 because it's hard calcium fragment. With osteotome, we just did the discectomy, which just open the mouth of L5 S1 disc. Sorry. Yes, this is L5 up migrated fragment is lying here. This is the second fragment. This third fragment. So this space is completely empty behind L5 body. And then I move to L45. So we burr the part of lamina and spinal junction and lower lamina also. This I use a transforaminal endoscope. Here I didn't use that PSLD scope. So again, I retracted the nerve root. Again, that fragment remained fragment from L45. I removed from the L45 approach, interlaminar. So total almost around 7 to 8 centimeter fragment we remove. And I think this case we already discussed last time. L5S1 upmigrated disc with high upmigrated disc on right side symptom. We approach from right side interlaminar endoscopy. There is complete decompression. So fragment was lying here behind the L5 vertebral body. And this is L5S1 disc. Here one strange thing I found that there's some connection with S1 root, something going into the L5S1 foramen. So I tried to dissect that, but it was something different structure. So I didn't touch much. I don't know whether it's Furcal now something different. This is a post-op MRI of same patient. You can see complete removal of disc with very small interlaminar nick. It's only this around 4 to 5 mm window. We just split the window. So in a conclusion, endoscopic discectomy is gold standard even for migrated disc herniation. Pathology and level of herniation will decide your approach. Due to high iliac crest, LIL in the interlaminar approach is good for L5S1 because you need to go transiliac, you need to move dissection and it's fixed window. So we cannot do too much if you are not landing completely. Adequate pre-op planning is must for successful completion of surgery and early completion. And surgeon expertise level of skill is also important to deal migrated, especially high migrated disc herniation. Thank you.
Thank you, Dr. Bhupesh, for such difficult surgery made simple with planning. I now call Dr. Rohit. Is it Rohit? Yeah, this one? Yeah, because you make it the auditorium. All right. Dinesh is gone. Yes, Dr. Rohit. Dr. Dinesh Patel, that's your last talk. Please upload your.
Good evening all, and thank you, Dr. Malcolm sir, for giving opportunity. I'll be talking on transiliac transforaminal endoscopy. My name is Dr. Rohit Dilat, and I am orthopedic spine surgeon from Surat. Till now, we have discussed everything of all form of endoscopy, but transforaminal endoscopy is special in the sense that it has various advantages of less damage to paraspinal muscle, rapid recovery, less complication, and moreover, it avoids spinal canal. But at some level, like alpha S1, there is some difficulties because of narrow foramen, high iliac crest, narrow intertransverse space, thick transverse processes, wide hypertrophied facets, sacralella, and moreover, inclined disc trajectory. So we have seen various methods like microdiscectomy, interlamellar endoscopy, foraminotomy, ventral epidural endoscopy, but for some cases like foraminal or extraforaminal disc, and to avoid the spinal canal, transforaminal endoscopy is have certain advantages. So we have two form of transforaminal endoscopy, that is suprailiac and transiliac. Suprailiac is good for foraminal, extraforaminal disc, but some central or cranially migrated disc, there may be some difficulty in removing that. And there is a possibility of damaging L5 root and S1 end plate. So the transiliac approach needs to be known because it eliminates the limitation of suprailiac approach. It is safe and feasible. The only thing is it is through the iliac bone. This is comparison between suprailiac and transiliac endoscopy. Suprailiac is above the iliac crest, transiliac is through the iliac crest. Suprailiac comes at an angle to the disc, whereas transiliac is in the line with the disc. In suprailiac, we need more expansile foraminotomy, whereas in transiliac, drilling of ilium is required. Whenever iliac crest is below L5, suprailiac is good, and when iliac crest is above L5, we can think of transiliac procedure. The biggest obstacle for alpha S1 disc through transiliac approach is iliac crest, and for this, iliac crest height was described by Choi and Park in 2016, which is the vertical distance between tangential line to iliac crest and the midpoint of S1 pedicle on radiograph. He has classified in 6 types. I'm not describing in detail, but whenever the iliac crest is below L5 pedicle center, we can go through suprailiac approach, and whenever L5 iliac crest is above L5 pedicle, we can think of transiliac approach. There is one more paper by Dr. Prasad Padgavkar where he has considered AP and lateral radiograph to guide which approach is to be taken. So talking about transiliac approach, we need X-ray, MRI, and in some of the cases CT scan. X-ray is required to see iliac crest height, pedicle with respect to disc, angle of disc, size of TP, height of foramen, and intertransverse distance. MRI is required to see site of the disc, whether it is central, paracentral, foraminal, extraforaminal, up migrated, down migrated, and for approximate planning of the entry. What we need is Jamshedi needle, biopsy needle between ACL reamer set or cannulated or solid reamer set to enter the ileum. Patient is position prone. Whole surgery can be done in local anesthesia plus sedation. Before starting surgery, you should check AP and lateral view. Basically, Ferguson would to check whether we can see properly in CM or not. Entry point is marked using KY parallel to disc in both Ferguson and lateral view, and usually it comes at angle of 11. Usually it comes between 11 to 13 centimeter from the midline. Local anesthesia is infiltrated from skin, subcutaneous muscles, and periosteum. Using K-wire, level is marked and local is given. Using breath pin, we can enter or make penetrate the ileum, keeping target the middle margin of pedicular line and posterior one third of the disc. Using cannulated or solid reamer, we will make iliac window. Using 8 mm, 9 mm, 10 mm reamers. Iliac window is approximately 4 to 5 cm anterolateral to PSIS. The guide wire is stopped on the target. That is middle pedicular line and posterior one third of the disc. All steps are similar to transforaminal endoscopy that I will not be describing in detail. Complications of this are brutal artery injury, injury, possibility of sacroiliac joint violation and pelvic cavity entrance, which can be avoided by remaining close to PSIS and taking entry as lateral as possible. By Osman saying that Altering is 4 away from our working window. So don't worry. While you saying that arteries now are 6.68 to 60.4 millimeter PSI. So the disadvantage you can think of is blood loss because of branches of damage. So that is operating time. Splits foramen and chances of fracture which can be prevented by one-shade members. It has over central and up migrated this trajectory is the line is that is not a main plate of S1 and reduce of injury to zero. Moreover, there is easy foramen on the access. So take home message is translate effective in number pathologies, simple orthopedic instrument like between animals are required and it can eliminate the limitation of supra-iliac approach. Thank you.
Thank you, Doctor. For want of time, we will not ask questions. Can I call Dr. Dinesh Patel? Give him a big hand. And now we are coming to UB history anatomy of lumbar, basic to advanced, and difficulties for right-handed person when doing from the left side. Sorry, this should have been the first lecture.
Good evening, ladies and gentlemen. Let me introduce myself. I am Dr. Dinesh Patel, MCH, Neurosurgery from PGI Chandigarh. I belong to Riva, which is a land of white tigers. First white tiger found in world in Riva. I have started my journey as a neurosurgeon last 15 years, and I'm practicing last 8 years in Riva. I started my UB journey last 6 years, started from transforaminal to PSLD and from PSLD to UB. I am very grateful to express that I did about 200 cases of UB from decompression to discectomy to interbody fusion. Now today we will discuss about the history, basic concepts of UB and difficulties facing right-handed surgeon when he is going to left to right side, or left-handed surgeon facing problem from left to right side. UB is considered to the most innovative method of endospine spinal surgery and has been recently developed at a rapid pace because it has vast application and as similar to open surgery. History, D. Antony et al. In 1996 published his paper in which endoscope and instruments were inserted independently through 2 ports, followed by Abdul Ghaffar, Suleiman. But basic and advancement in this UB surgery done by Koreans, Jim Howe and Dr. Sun. They use the term biportal in 2016. Basic anatomy of UB. UV is basically a posterior approach. And we always in search of natural corridors for the all spinal endoscopic surgeries like transforaminal Campbell's triangle. Similarly, for UB, we find two spaces, interfascicular space, which is located between the two muscles of multifidus, and a space containing fat and connective tissue located between multifidus and lamina. Multifidus is basically a deep layer of muscle, which usually starts from the C2 to S1. It is paraspinal muscles originated from the cervical region, from the articular process, in the thoracic region from the transverse process, and in lumbar region from the mammillary process of the lamina, and inserted 2 to 4 level above this spinous process. And one important thing in this UB anatomy is ligamentum flavum, which usually attach anterior surface of the cranial lamina and attached to upper margin of the caudal lamina. When these two spaces connected, an atraumatic working space for the corridor for the UVID can be developed. During surgery, we have to go through these layers: skin, subcutaneous tissue, thoracolumbar fascia, multifidus muscle, and finally we will dock on the lamina and interlaminar space. Indications of UV: for lumbar disc herniation, it can be central, paracentral, foraminal, extraforaminal disc herniation. Calcified disc herniations, Cauda-Equina syndrome, lumbar canal stenosis, spondylolisthesis. For cervical, it's paracentral foraminal disc, thoracic canal stenosis. Why UV? Unlike one portal endoscopy, biportal endoscopy, spinal surgeries has long and wide field of view and access, and portals for the endoscopic and instruments are separate. Therefore, the instruments can be used over a relatively long distance and wide field of view. This unique feature of bipolar endoscopy facilitates anatomical orientation and handling of instruments for the surgeon. UV has advantage over conventional in muscle preserving and bone manipulation. Let's talk about the basic things during surgery. Anesthesia, you can give GA or epidural for lumbar region, but for cervical and thoracic, you have to go for GA. Instruments required for UV are endoscopic system, drill system, RF system. Endoscope, you can use 0 degree, 25 degree, or 30 degree as your convenience, or degree of view. Drill system, you can use automated drill like Midas and Striker. RF, you should use good RFs like Endovision and Bones, or whatever available. During an surgery, usually hypotensive anesthesia is preferred to avoid excessive bleeding. Surgical steps: skin mark and incision. First, check AP view and mark the midline. Then mark center of the disc, followed by preparation of working portal. Mark the working portal or instrumental portal medial to inferior pedicle, just medial to that, starting from the spinolaminar junction towards the pedicle. After marking that, make skin incision going through deep through subcutaneous tissue and thoracolumbar fascia. Insert codilator under C-arm, then serial dilators are inserted. Dilator move mediocranially and caudally 2 to 3 times, not more than that, because it leads to damage to the muscle and release of fibers, which can hamper your surgery because they are floating during surgery. Mark scopic portal 2 to 3 centimeter cranial to the working portal. 2 ports should be 2 to 3 centimeter to prevent interruption during surgery. Then Scopic portal, insert sheath with the obturator from the scopic portal. One thing I have left, make skin incision in the scopic portal, go down the subcutaneous tissue, make slightly caudally thoracolumbar fascia incision because it helps during surgery. Otherwise, you will in trouble. Make triangulation between the working portal and scopic portal. Many beginners have complaining that they have their irrigating fluid not coming from the working portal, because most of the time they are in the middle layers of the multifidus or somewhere in between. Move working portal and scopic portal in a 2 to 3 times in a kissing manner cranially-caudally. This will help the making a passage to irrigating saline to come out. Insert the scope through sheath, check the irrigating saline coming easily from the working portal. There is important thing, the hydrostatic pressure of the irrigating saline should not be more than 30 to 50 mmHg, and this can be calculated by distance between the patient and the saline bag divided by 1.36. Roughly 1 feet is equal to 22 mmHg. If you find a blurred vision in the absence of bleeding or water retention are noted, portal dilatation and facial dissection should be repeated again and again. Laminectomy and flavectomy, usually you land on the spinolaminar junction. There is some fat and connective tissue. Use RF to clean for that. Laminectomy starts at the spinolaminar junction with automated drill, which the point where have to drill and up to where cranially we have to land up. Start at the spinolaminar junction and undercut the spinous process and cranially where the ligamentum flavum attached. Do good ligamentum flavum removal for easy discectomy. Drilling of the lamina, removal of the ligamentum flavum. Finally, discectomy. Disc space is usually located medial to the superior border of articular process. We can found disc at the ipsilateral shoulder, ipsilateral axillary, contralateral shoulder, contralateral axillary. After locating the herniated disc, ruptured disc is removed. Bleeding control and annuloplasty can be achieved with RF. Drain insertion is an optional. If meticulous bleeding control you have find, then there is no need of drain insertion. If you are suspecting the bleeding will occur, you can put 50 or 100 cc drain through working portal. Skin suture can be sutured with 3-0 nylon or surgeon's preference. These are small incisions for UV. Complications are like bleeding, traction, dural tear, and some fluid-related complications you can find. If excessive pressure you can use, then it leads to headache, nuchal pain, epidural bleeding, seizures, intracranial hematoma, and even blindness. And one of the most common complications is hypothermia. To prevent this, use tepid saline and heating pads on the surgical table. Studies showed that UV is not superior to anyone of the endoscopic surgery. All surgeries are good and excellent, but there is less post-operative back pain and shorter hospital stay. Take-home message for the beginners. Beginners should start with open spine surgeries, and after a few cases, they can switch to endoscopic surgery. Because when you call some other surgeon during surgery, he will insult you and embarrass you. If you able to do open surgeries, that is good for your practice. For endoscopic spine surgery, when you start endoscopic spine surgery, cases should be simple, like lumbar canal stenosis, in which dissectomy is not required. In that, you do laminectomy, flavectomy, and nerve root exposures, and then gradually switch over to dissectomy. Beginner should never start with the right-sided cases, because right-sided is a very difficult issue in the UB. That is the most important thing you keep in your mind. We will discuss detail for the right-handed surgeon when switching over from right to left side. It's like what I feel that it's like that if you are using scopic portal on the right hand, it's very easy to work. And scopic portal, because it's your non-dominant hand, you are standing there like a mountain. You are standing on the mountain. You are seeing a scope with down on the right sided. But when you switched over to left side, its scenario totally changed. Your scopic portal is on the left hand and caudally, and your working portal is on the cranial side. You are standing with your working portal on the top of the hill, and you are seeing from the base. Whole anatomy is changed and very difficult to work. For this, you can make a working portal incision just caudal to laminar margin, and then you start the work. A case, 30-year male presented with back pain radiating to right lower limb. MRI shows L4-5 PIVD. After 2 hours of surgery, patient is walking and talking, but he is little sad because of slight back pain. But after 12 hours of surgery, he is walking and he is happy. Excuse me, sound.
Huh? Yeah, we can make out what he's saying. All thanks to you, Dr. Dinesh.
Okay.
Yeah, he's very happy. Yeah, we are slightly short of time. Can we conclude the session?
Yeah.
Because we have to give this room to some other event. Thank you very much.
Thank you.
Let's give him a big hand. Can I call Dr. Same? Dr. Same Hassan?
Thank you. Just open.
It's okay. Dear friends, welcome again. I'd like to invite you to visit my home country, Egypt, country of civilization, which backs to 7,000 of years. And you will find also there a friend for all of you called Sam Hanosi. For past 3 successive years, I have been honored to be the chairman of this fest for endoscopic spine surgery, and our family teamwork have made an amazing, extraordinary hard work. So far, we developed this Congress year after year. What we have seen here is the result and real meaning of brotherhood. What we have seen here is the result and real meaning of brotherhood of science. Brothers who are eager to teach every one of you with care and love. And they are always welcome everyone to join this family. Behind the scenes, there are a huge number of members under leadership of me, Malcolm, and Tao, KV, and Holy Spirit administrators. What we have seen here is also the net result of multiple international collaboration that I have made by EWNC Academy with multiple famous and eminent international federations. Believe me, to get an accreditation for this course from these federations wasn't an easy job at all. It has cost me and Malcolm an extra effort, time, and mega preparations. Year after year, we include more faculties and delegates to make this Congress the best one in the world. Success that we have got this year will not end at this point. Dear friends, scientific committee of this Congress are proud to announce that we have got preliminary approval of most of international faculty here to take the next step in the future of this Congress and to make it a separate entity of spine interventions by launching WCSE International Society, the first international organization that deals specifically with spine endoscopy. We will open its membership soon. Please join this prestigious society and invite all your friends who are interested in spine endoscopy to join this family too. And to add more wisdom to what we have learned here, I'd like to remind you about the golden rule for any surgery. It's not only about the tools that you have. It's mainly about the mind beyond the tool, who is leading it to the targeted pre-operative aim safely and efficiently, with tricky multiple different plans to deal with different surprises that anyone may face intraoperatively. That's why we all are here. Also, I'd like to add something to your knowledge about your teamwork to make the best team who can go far beyond expectations. You have to study first every single detail about every member of it, especially the best thing that he is passionate to do it. and coat your whole family with love. Makes them to make a family. Always listen and study their plans. Care about every one of them separately. Don't underestimate any. Always encourage them to give their best efforts in their mission to reach the highest levels of success. My journey will not stop here, and my collaborations with international societies too. Next collaboration and my 187 physical event will include AOSPA in Egypt. And we are trying to make it a hybrid event to facilitate joining of our international colleagues too. And these are the faculty who will join us in this event. 4th November 2022. Fehlings, Gasparini, Guel, Elvis, and Jukaslan. And the long list of our famous national spine faculty too. When we talk about EWNC, it will be an endless talk. But please let me add one more information about it. Since we have started EWNC, we have built it up on most solid scientific innovative base. That's why every 3 months, specifically on 18th day, we are making rank for activities for activities there and asking about recommendation for the future. We have postponed this month till the end of Congress, and I am 100% sure that you will never see this percentage of members satisfaction in any other community in the world, because we are competing ourselves to be more better and better minute after minute. At the end, please allow me to invite you to our next events of EWNC. On 15th October, we will continue our third session of most remarkable lessons from ER Zoom event. This was the previous one of this series. On 5th November 2020, OncoSpine seminar in Cairo, Egypt, hybrid event. On 18th and 11th December 2022, second EWNC Skull-Based Congress, Zoom event 2, and this was the first one of this series. These are the confirmed events of EWNC so far. Others will be announced on EWNC groups once it's get finished. Enjoy pure neuro and spine science with big family. If you have missed any one of previous events, don't worry. We will find your recordings available on our YouTube channel. Now it's time to celebrate our achievements that we have gained so far and plan for more and more for the future. Special thanks to my dear brother Malcolm, Anand, and Antao for what they have done for the society so far. Please prepare yourself for more and more next year. More special thanks for Malcolm family for great love, hospitality, and they quoted us by dear Holy Spirit administrators and staff members, thanks a lot for helping us. Dear faculty and delegates, thanks a lot for joining us. I hope you have enjoyed it. And your comments and suggestions are highly appreciated. Dear sponsors and supporters, thank you for what you have done for all of us. And I hope to see you all next year. Thank you.
Thank you, Dr. Samse. And I will now just do the closing. They say what starts well always ends well. Though we had some hiccups and all, we went well, and now we have come to the end to say a big thank you, a thank you from the bottom of the hearts, a thank you which is not a mean word, but really when we mean it. So when we started this concept of starting this Congress here and holding it here, we went to the administration and we had a lot of meetings with them, getting ideas and what to do. And with their assistance, cooperation, and goodwill, that we could have this meeting, a big Congress here. So our thanks go to Sister Lisi, first Sister Sneha, now Sister Lisi, the CEO of Holy Spirit Hospital, then the medical director, Dr. Susan Sauder, Assistant CEO, Sister Felsi, the medical superintendent, Dr. Anuja, and Sister Elsie, the public relations team. Our thanks go to the collaborators, the Bombay Orthodox Society, EWNC Academy, WSCE, plus the industry who has helped us in a great deal. My vote of thanks will not be enough without thanking the faculty which has come from all parts of the world, right from the ends of the earth, Argentina to north, our friend Ten, and the Middle East people, the Korean faculty, plus our Middle East faculty, Japanese faculty, and all you delegates and the local faculty, right from Kashmir to Kanyakumari. I can say that's the north, Kashmir, south is Kerala, Kanyakumari, Tamil Nadu, and then from Bombay, Gujarat, west to northeast is the Assam. So it's like just like a vertical and horizontal dimension of India has taken part in this great Congress. I must thank my department very much. My fellow consultant, Dr. Rajesh Shirishkar, Dr. Lunde, Dr. Paras, Dr. Nerurkar, Dr. Babin, and all the residents that have helped us behind the scene. Without their help, this meeting will not have been successful. I know the amount of hours, the nights they have spent to make this Congress a great success. And this last part is, I must talk about the sisters, the students, BSc students who gave us a beautiful prayer dance at the inauguration. And then the OT staff that worked so hard, keeping the theater ready, Sister Raji and Sister Vasanti. The students, the teachers of the second year students who did the prayer dance, and all the industry that has come out with us together with the collaborators. And not to forget the great man, Mr. Ali, where are you? Who had done the audio visuals for us. I think we are so happy with the food that was given to us. And so, Joyson, wherever you are, thank you very much for feeding our tummies well. And the hotel who gave such lovely hospitality, Beats Hotel, the Kamath Group. And lastly, and but not the least, the woman who keep moving around but saying, not expecting much. She is in charge of the PR department, Dr. Miss Annie Peters. Please give her a big hand. I should not take it as success of this is behind the foundation. The Endoscopy Spine Foundation of India deserves a big applause from us for virtually lifting everything from Vasai to here, right from these sofas to whatever you see all along the way. And the patients, very important, who were ready to come for the surgery and were volunteered enough for the surgery. If I've missed still people, please forgive me. And they say bye-bye, and we meet again somewhere, somehow, sometime. Thank you very much.